Over to you, sir. Rituparna Shindeda.
लाइट बंद करा. थोडंसं हे करा, फोकस करा. ओके. Good morning. At the outset, let me thank the bearers of the M A Pandharpur body to have invited me here, and Ram Krishna Hari to everybody. आजच्या ह्या लेक्चरमध्ये पुढच्या 20-25 मिनिटांमध्ये ॲक्च्युली मला जो टॉपिक दिला होता तो आय हॅव टेकन लिटिल लिबर्टी टू मॉडिफाय अँड सिम्प्लिफाय इट. तो खूप बोर टॉपिक होता की प्रिव्हेन्शन ऑफ सडन कार्डियक डेथ. सो लेट्स सी समथिंग इन रियल प्रॅक्टिस. How can we apply prevention of sudden cardiac death through the means of ECGs? We'll just discuss some 8 to 10 ECGs which are very common and which can cause sudden cardiac death. So ECG, first and foremost, whenever we order, it has to be interpreted in the clinical context. You cannot interpret a ECG without any clinical knowledge. That does not mean that every ECG you have to write kindly correlate clinically. Whenever I see somebody writing that, it just irritates me to the core. So this is the most difficult ECG of the lot. This is a normal ECG. This is the most important ECG we all should know. Unless and until we know normal ECG, we don't know how to diagnose a subtle changes which can cause sudden cardiac death. So majority QRS complexes are positive, except for AVR and V1 and V2. R wave progression across the precordium is very, very gradual. And T wave in V1 should be very small or flat, or sometimes inverted. Now why this particular, we'll see in the next coming issues. So first and foremost hallmark of any sudden cardiac death, if at all they get any pre-monitoring symptoms or any idea, is a syncope. In fact, syncope is defined as, it is as same as death, but in one you recover. Syncope is the one in one you recover, you don't recover, you get death. That is very simplistic definition of syncope. And these are the various causes of syncope and sudden cardiac death. So primary myocardial disease such as cardiomyopathies, dilated, hypertrophic, restrictive, ventricular dysplasias, and so on and so forth. Arrhythmic syndrome such as WPW, QT prolongation, Brugada's. In fact, with LQTS, QT prolonging drugs such as hydroxychloroquine during the COVID time, we had lot of arrhythmic deaths, because there was a rampant use of hydroxychloroquine and people did not actually monitor QTs, and plus there were antibiotics which were prolonging QT, so we had a lot of cases. So QT had a little bit more glamour during the COVID days. Then various arrhythmias and patterns such as benign early repolarization, which is not really a very benign phenomenon, and other normal things which we see in the this AMI and pulmonary embolism. We're not touching into ischemic heart disease because that is a topic in itself. So what is a sentinel death event? Sentinel death event is something which is actually a precursor of a sudden cardiac death. And again, these are the same causes which lead to close to 5 to 6 lakh sudden cardiac deaths happen in India. This is a United States statistics, but then it is the highest cause of mortality due to any single cause. Forget about communicable, non-communicable, is sudden cardiac death. In fact, every now and then in papers you read that he has died of sudden cardiac death, she has died of sudden cardiac death. And in fact, sudden cardiac death is eminently preventable. We'll come to that. You know, the only thing which can prevent a good sudden cardiac death is a timely CPR and the help, which is unfortunately lacking in our country. So these are the things which we see. So 70% of sudden cardiac deaths usually have structural abnormality, and there are some primary arrhythmic syndrome where the heart is structurally normal. So coming to some ECGs. So what do we really see in ECG in a sudden cardiac death? One is cardiomyopathies, hypertrophic cardiomyopathy, you will see LVH. Dilated, again you will see LVH pattern, sometimes left bundle branch block. Restrictive cardiomyopathy is very specific. Low voltage pattern, atrial fibrillation and various conduction disorders. Arrhythmogenic right ventricular dysplasia, you have specific splintered QRS complexes which are characterized by waves called as epsilon waves, we will see them. Then RBBB pattern can be seen. So these are, basically T waves and QRS complexes are affected in a cardiomyopathy, and they are very subtle at times. There are some primary arrhythmic syndromes such as Brugada, and mind well, Brugada is not something which we just throw on your face to impress upon you. कि बाबा हे काहीतरी मोठे मोठे वाक्य वापरतात आणि डॉक्टर मोठे म्हणून आपले मोठे बोलतात असं नाहीये. If you see really, Brugada pattern is very common, very, very common. In fact, we should know how to catch a Brugada pattern, and the issue with Brugada is sometimes it is not present, it gets amplified in presence of certain things such as hypoglycemia. Then WPW, prolonged QT, benign early repolarization so-called, and catecholanergic polymorphic ventricular tachycardia. Again, a very big name, but then a very fatal kind of a condition. Myocarditis, very common these days with the advent of all these viral diseases. We all faced a lot of myocarditis where you see a diffusely flipped or inverted T waves, tachycardias, sometimes bradycardias. But again, diagnosis has to be done with clinical correlation. Congenital coronary anomalies, coronary artery disease, we all know, Valencine, hyperacute T waves, so on and so forth, and valvular diseases. So we'll just see some case-based scenarios now. Too much of theory. So this gentleman says, my heart feels racing, मला धडधड होते, खूप fast एकदम heart चालतं माझं, आत्ता मला बरं वाटतंय. So what is this ECG? If you carefully see this ECG, the PR interval, there is no PR interval. P wave is getting into the QRS complex. Hey, laser hai? So P wave is getting into QRS complex here, you can see, and there is a upward slant here, and this is nothing but the delta wave. Mind well, this is classic WPW syndrome or pre-excitation. Now, what is the problem? Why should we diagnose this? Because many times this is there and patients do not have any symptoms. So whenever you see this ECG, or whenever somebody comes with a history of palpitations with this ECG, you have to be very careful, because these people, if they get atrial fibrillation, they get into uncontrolled atrial fibrillation, and that can result into sudden cardiac death. And they also have orthodromic and antidromic tachycardias. So what are the classic things of WPW syndrome? If you see here in the lower ECG, you can see this slant, that is the delta wave. You see tall R waves in V1. Usually positive R wave in V1 is a very important sign that there might be a WPW syndrome. Then RBBB pattern, and very rarely you get pseudo infarction pattern. If you see this particular, you can see there is a QS here, 2,3 AVF. Unfortunately, this is merged below. So QS in 2,3 AVF can be a negative delta wave, leading to a assumption that this is a old inferior wall infarct. But just look carefully at the PR interval, and this is not a WPW. This is not a infarct, but this is a WPW. So this is another guy who has history of fainting. So forget about rate, rhythm, axis, because whenever we come to the axis part of it, we stop reading ECGs. At the level of MBBS itself, we have stopped reading ECGs at the level of axis. So forget about axis. You have to have a physical picture memory of these ECGs. So what is this ECG showing? Very classic. Look at the lead 2, T wave. See there is a long ST segment, and the T wave is going into the P wave. This is very classic QT prolongation. So this is long QT. Very important, because umpteen number of medicines, terfenadine, cetirizine, gatifloxacin, anything, most of them can cause this. And if this is combined with another QT prolonging drug, amiodarone, very commonly used. Every atrial fibrillation will be on amiodarone. You give them erythromycin, you give them some other QT prolonging drug, they will land into a torsades. So very important to make a picture memory of this ECG. You can see here. Sometimes it may remain normal. Now how do we think that this is a long? So there is a rule of thumb. If the T wave falls into the second half of RR interval, what we used to do is to take the ECG and fold it on two RR intervals and just see if the T wave falls into the second half, then it is a prolonged QT. Another problem with the QTC is people don't have calculators. So ते अंडर रूट आणि अंडर क्यूब रूट करण्यासाठी आम्ही ज्यावेळेला ससूनमध्ये असायचं आम्हाला एकाच कुणाकडे ते कॅल्क्युलेटर असायचं शोधायचं आणि ते क्यूटीसी कॅल्क्युलेट करायचं. प्रॉब्लेम आता तो नाही आहे कारण वी हॅव ॲप्स. Just put in how many millimeters of QT interval, how much is the heart rate, and it will give you a QTC corrected. Second thing is you have QTC usually calculated on the ECG itself, but that has to be taken with a pinch of salt. Anything above 500 is bad. Anything in the second half of RR interval is usually prolonged QT. So this is prolonged QT, and what happens with this? You can see there is a R-on-T phenomenon, and it has triggered a very bizarre-looking twisting kind of a ventricular tachycardia, which is rightly called as torsades de points. That is twisting of the points, and it's a polymorphic ventricular tachycardia. Unless it is shocked or given magnesium or it reverted back, this would lead to degenerate into a ventricular fibrillation and lead to a sudden death. So this is how we measure QT interval right from the start of the Q wave to the end of the T wave. Many times if the patient is having hypokalemia, you have U waves, and so you get pseudo QT prolongation. So do never ever take that U wave into the calculation of QT. Always remember, lead 2 and lead V6, V5, V6 are the good leads to see as far as T waves are concerned. If you don't see a good T wave, another good example of the lead is AVR. Except that the T waves are inverted. So in this patient again, it is extremely opposite scenario. This patient also feels I feel woozy, मला चक्कर येते, डोळ्यापुढे अंधारी येते. आणि काय करायचं तो? You see, this patient is having a very short QT interval. ह्याचे QRS complex दाबले गेलेले आहेत. So hypercalcemia, very common cause of short QT interval. So these are some people who have short QT congenital, and they are also predisposing to sudden cardiac death. So this guy had a nice party in the evening Saturday and suddenly lost out. So what is this ECG? Very common ECG. So just look at the anterior leads V1 to V6, deep symmetrical T wave inversion with little bit of ST segment. So again, make a visual memory of this. This is deep symmetrical T wave inversion, not always is non-STEMI. Most often than not, this is hypertrophic cardiomyopathy, especially of the apical variant. And these people will have someday or the other. You see the voltage, that V4 is going out of the ECG. Sometimes you see normalized QRS complexes, but you have to see these machines, they adjust the standardization. So look at the standardization. If it is half standard and normal ECG, it is hypertrophy. So always look at those standardization on the ECG. This is severe hypertrophy with T inversion. You can see almost all leads have T inversions. STEMI or ischemic heart disease does not cause T inversions globally unless it is a left main occlusion. So this is hypertrophic cardiomyopathy. You see left ventricular hypertrophy, you see abnormal ST segments, and you see deeply inverted T waves, tall R in apical leads, and deep Q waves. Why this is important? Because these people usually lead to sudden cardiac. They have ventricular tachycardias and they have sudden cardiac deaths. There are various criteria on how much echo and other things, how to risk stratify the risk of sudden cardiac death. But always remember, hypertrophic cardiomyopathy is not very benign. And whenever they are settled, patient ला काहीही त्रास नहीं है, दम लागत नहीं है, कहीं नहीं है, and they have sudden cardiac death. Patients with breathlessness and heart failure don't die of sudden cardiac death. Patients who are into NYHA 1 and 2 die of sudden cardiac death. That is always the case. So when they are like admitted with a class 4 dyspnea in ICU with BiPAP and diator infusion, that time they won't have arrhythmias. Arrhythmias will happen when the patient is settled, and it will catch you off guard. And that is why it is very important to give them high doses of beta blockers. Very important. Anybody with IHD, anybody with hypertrophic cardiomyopathy, beta blockers are a must. Nowadays, beta blockers have gone out of vogue as far as hypertension treatment is concerned, but I always make sure that you give them little bit of beta blocker if they are having ischemic heart disease, if they are having hypertrophy. These are very important people to be saved. You know, you see this ECG, I am sorry for the quality of the projection, but then these are again deep symmetrical T waves. No differential diagnosis, apical Yamaguchi hypertrophic cardiomyopathy. Now this particular gentleman, palpitations and breathlessness. What is the thing? Forget about PQRST. What is the biggest thing you see in this ECG? Short QRSS, low voltages, extremely low voltage. If you see, again, whenever you talk about low voltage, look at the standardization, it is correct 10 millimeter, and there are hardly 3-4 millimeter, all QRSS. Somebody would say this is pericardial effusion. Yes, that is possible. But in a stable patient with no pericardial effusion, this ECG is diagnostic of restrictive cardiomyopathy. Now again, restrictive cardiomyopathy हा मोठा शब्द वाटतो, पण प्रॅक्टिसमध्ये खूप कॉमन आहे. Amyloid, people on dialysis, people with carpal tunnel syndrome and breathlessness, people with neuropathy and breathlessness. Look for heart. You will find a hypertrophic cardiomyopathy, the restrictive cardiomyopathy. Again, transthyretin hypertrophic cardiomyopathy, very common, we don't look for it. Somebody with breathlessness, heart failure, normal ejection fraction, and neuropathy is restrictive cardiomyopathy. Hallmark on echo is big left atrium and right atrium, but again on ECG, you see diffuse T-wave inversions and low QRS. So this is what we have to remember. Hypertrophic cardiomyopathy, huge QRS. Restrictive cardiomyopathy, very small QRS, because the muscle itself is diseased. It does not produce that much amount of voltage. So it's a primary muscle disease. So this is again restrictive cardiomyopathy, low voltage with T inversions. Now, what are the causes of restrictive cardiomyopathy? Amyloid, sarcoidosis, hemochromatosis. Again, Dr. Nemane will agree with me. These children with thalassemia, with repeated transfusions, they have huge amount of hemochromatosis, and they have these ECGs, they have failure, they have heart failure. Do their NT-proBNP, it will be sky high. Again, they will require desferrioxamine and other things, but then those are the very common people and young people who have restrictive cardiomyopathy, which is reversible, by the way. Then ventricles become rigid, shortness of breath, another thing. Again, important to diagnose any heart failure, very important test, blood test is NT-proBNP. Even if clinically you find the patient is having breathlessness and it is not respiratory, please do a chest X-ray and NT-proBNP, you will get your answer. Simplest test to differentiate a respiratory and a cardiac dyspnea is NT-proBNP, very commonly available, and it will give you a diagnosis in such patients. Do not dismiss them as COPD. So specific causes of non-specific T-wave inversions. So first and foremost is ischemia, non-STEMI, cardiomyopathies we just saw, pulmonary embolism, and last but not the least, stroke, IC bleeds. Again, somebody coming with severe headache, a worst headache of my life, and ECG shows T inversions, boss, subarachnoid hemorrhage. No need of anything. This is the classic ECG of a subarachnoid hemorrhage, very deep symmetrical T-wave inversions. So eye does not see what the mind does not know. Now, another problem with practice is differentiation between syncope and seizure. बऱ्याच वेळेला आपल्याकडे त्याला लहानपणापासून खूप सारखी एपिलेप्सी आहे, 4 एपिलेप्टिक मेडिसिन चालू आहेत, पण त्याचं एपिलेप्सी इज कंटिन्यूइंग. 110% this is seizure, not seizure, this is syncope. Something with a syncope gives hypoxia, and these are hypoxic seizures. Most of the times children मध्ये ज्या so-called resistant epilepsy असतात, they turn out to be long QT syndrome or syncope. So always whenever somebody gives you repeated seizure history, please take out a ECG, do an echo, and take a good family history. की बाबा मामाला काय झालं, तुझ्या काकाला काय झालं, फॅमिलीमध्ये कोणाला सडन कार्डियक डेथ झाली होती का? सडन कार्डियक डेथ कळत नाही, हार्ट अटॅक आला होता का तरुणपणी म्हटलं की लोकांना कळतं. मग अशा वेळेला यू गेट अ आयडिया दॅट दिस इज नॉट अ सीजर, this is a syncope. Always, whenever in Pune hospital I have a patient, me and Dr. Sudhir Kothari have a nice debate. This is cardiac or this is... One patient, I had referred to him, ki, nahi, this is 100% seizure, sir. And while doing a video EMG, they put a ECG also. And that karta tala motta pause ala. So that was the diagnosis. So this is a seizure versus somebody with a young guy, kaka, mama, died suddenly. And this is the ECG. Now again, this ECG you have to make a visual impact. V1, V2, V3. असे टेंड सारखे ताठ आहेत. Very classical. You see V1, V2, V3, this is looking like a something bizarre RBBB pattern. So this is not RBBB, this is a tenting of T waves in V1, V2, V3 with a history of seizures or syncope. This is Brugada syndrome. Now this Brugada syndrome is a big thing, but the problem is Brugada syndrome is caused by a gene called as SCN5A, which codes for sodium channel. So you give any other sodium channel affecting medicine and this pattern will come up. So somebody who is genetically predetermined having Brugada pattern on ECG, you give them sodium channel blockers, and they're very common, tricyclic antidepressants, very commonly prescribed sodium channel blockers. You don't require antiarrhythmic for sodium channel blocking. Your so-called ivabradine is one of the sodium channel blockers, though it blocks another current. So this is Brugada syndrome, V1, V2, classical. Now you go and see in your practice, you will find more Brugadas. Brugada syndrome is not only Europe or America, it is very common in India. In fact, after seeing in Sassoon, we had diagnosed 8 to 10 Brugadas. So this is another pattern of Brugada you see. This is a sodium ion channelopathy and it has a good predilection for VFib. Basically, somebody with Brugada pattern and a history of syncope should get an ICD straight away. And that is very important. You have to genetically screen them for SCN5A mutation, them and their family members. So this gentleman again, history of sudden syncope, breathlessness होतोय मला आणि थोड्या दिवसापूर्वी मला 2-3 वेळा चक्कर आली. So what is this? Again looks like Brugada but not Brugada. How is this QRS? If you see that AVRचं टोक बघा वरती की QRS complex दात लावल्यासारखे असं कतरलेलं आहे. किंवा you see this V1, this is classical fragmented QRS. So when you see something like this, which is not artifactual, and you see there is another, in V2, there is a flip on the end of the QRS and start of the R. There is a small notch. That notch is called a J wave. It's a repolarization wave, also called as epsilon wave, also called as Osborn wave. So this is basically at the end of the QRS, which is a fragmented QRS, this is epsilon wave, and there is no differential diagnosis. So this is arrhythmogenic right ventricular dysplasia. So you have to see कि QRS complex जसा आपण पाहिला उंच होता, hypertrophy, छोटा होता, restrictive cardiomyopathy. If it is stented in V1, V2, V3, Brugada syndrome, this is fragmented QRS with epsilon waves, and this is nothing but arrhythmogenic right ventricular cardiomyopathy. And very, very important, you can do a cardiac MRI, diagnose it. Again, these people require antiarrhythmics or ICD. So this is associated with VT and VF, and these are how the fragmented QRS and epsilon waves look like. So this another gentleman. This is a very common ECG. Everybody in your practice must have seen this ECG. You know how is the lead V2, V3, VF? There is ST elevation, you can see. This is not a normal ST segment. It's a concave upwards ST elevation. Very common in young children with bodies, heavy bodies, gym goers. This is early repolarization. You have something called as fish hook sign here. If you see carefully here, गळ असतो ना मासे पकडायचा गळ, तसा असा नॉच असतो इथं. This is very classical of early repolarization. But they put one prefix to this early repolarization. It is called as benign early repolarization. So on looking normally, this is benign, but you have to take history of again syncope, sudden cardiac death in the family. This is not very benign, especially if it is seen in 2-3 AVF inferior. Michel Hessaguerre in 210 published a very classic paper, and ever since we call it not so benign early repolarization. So the early repolarization आपल्याला practice मध्ये खूप commonly दिसतं. Don't do anything, don't do echo वगैरे. झाला echo easily ठीक आहे, पण just take a history, family history, की बाबा तुमच्या घरात कोणी वारलं होतं का, लवकर कोणाला अटॅक आला होता का, तुझी बहीण भाऊ कोणी मेलं होतं का. So just ask them, and this is how this early repolarization looks. Thank you. Again, this particular, if you see notch here, these are upwards. ST elevation with AMI is convex upwards. This is concave upwards. Another differential diagnosis is pericarditis, but pericarditis is very rare. Patient gives classic history of chest pain. श्वास घेतला की मला छातीत दुखतं आणि if you have this ECG, this is a pericarditis ECG. Just 2 minutes.
Yes. Yes.
So this is another gentleman. Chest pain, breathlessness, and suddenly breathlessness. So what is this ECG? You see a R wave here, there is a T inversion, looks like a ACS. 90% of people will say this is acute cardiac coronary syndrome. But the problem with this gentleman, his symptom is breathlessness more than chest pain. Now what is this? See here, S1, Q3, T3, RBBB and T wave. And I will always remember, these T wave inversions are more in the right precordial leads, V1, V2, V3, V4. ACS T waves are usually, they start with V2, V3 and go up to V6. So they have leftward predomination. In PE, you have usually rightward leads. So this is right strain, ventricular strain, and S1, Q3, T3. This is pulmonary embolism. Again, simple thing. Breathlessness, desaturation, tachycardia. Pulmonary embolism is a diagnosis of clinical exclusion. It does not require ECG or echo. You have breathlessness, desaturation and tachycardia, you just send them for a CT pulmonary angio. So most common ECG abnormalities in PE are not S1, Q3, T3. They are just RV strain and T inversions. So this is very important. There are various scores, we will not get into this. This is another patient with severe breathlessness. Now what do you see here? Short QRSS, like restricted cardiomyopathy, low voltage. But then if you see carefully here, what is happening? Ha motha QRSS hai chota hai, ha motha hai chota. Alternance. So this is electrical alternance with low voltage. Just do an echo, this gentleman will have a cardiac tamponade. Again, very important, look at the neck. In cardiac tamponade, no JVP. It's a silent neck, always remember. So when you have a suspicion that person is having cardiac tamponade, just look at their neck, you won't see any JVP. And that is cardiac tamponade. When you tap, JVP comes back. So this is another pattern which you should remember, 2, 3, V2, V3, V4, T inversions. This is nothing but Wellens sign, very important. Patient will have more than 70% proximal LAD and they should not be given stress testing. This is very important to know this Wellens sign. Again, this gentleman, chest pain. And look at this T wave. There is a hyperacute T wave, but there is a ST depression. Okay? This is called as De Winter sign. This is pre-myocardial infarction chest pain. So if you see such kind of hyperacute T waves with ST depression, always remember that something is coming in. So I think we will just last ECG. This ECG will show chest pain, ST elevation lead V1. You see V2, 1, 2, 3, V4, V5, V6, everything. ST depression, more than 8 leads with AVR ST elevation. This is left main ischemia. In fact, from Ruby Hall, we were one of the first to describe this finding in British Heart Journal. And these are the classical ECGs of left main. Again, lead AVR is a very neglected lead. If you see lead AVR, you can diagnose certain things. One is ST segment elevation lead AVR suggestive of left main occlusion. Then if you see PR elevation in lead AVR, pericarditis. If you see prominent R wave, tricyclic antidepressant poisoning, and ST segment elevation suggestive of AV reentrant tachycardia, that we will see. So these were very classic ECGs. Again, there were certain ECGs which were seen in ICU. See, if you see this kind of rhythm, slow ventricular tachycardia, it is usually hypokalemia. Hyperkalemia, and again, very important, look at these T waves. One anecdote, if you want to sit on the T wave and you feel they hurt your butt, it is usually hyperkalemia, always remember. They are not very smooth, they are sharp and pointy. So if you remember these kind of anecdotes, you will never forget. This is almost 8 or 9, almost sine wave pattern. This is severe hyperkalemia. This gentleman had almost 9 potassium. So this gentleman, weak, feeling weak, QT, so-called QT prolongation. What is this? This is hypocalcemia, very common. So, just I come to the end of this talk. This is the first ECG machine by William von Anthoven, which was this big. And then this gentleman actually created a kind of a revolution in the field of cardiology, and he was given a Nobel Prize. But to sum it up, one thing very important, no ECG, nothing. To prevent sudden cardiac death, you require CPR. And that is very important. In fact, this is my personal mission, and I show this slide at the end of every ECG, that everybody of us have to train at least 1,000 people in CPR. I have my own 10 dummies, and we have actually collaborated with Pune Municipal Corporation and train every student in 9th and 10th standard for CPR. So far, I have covered almost 20,000 students for CPR, and I always tell them, go home and teach your mom and dad. So this is what is the answer for sudden cardiac death prevention. No ICD, no antiarrhythmics. A good CPR, because tomorrow your father, mother, brother, sister is going to be in the road and will have a sudden cardiac arrest, and if nobody gives them CPR, they won't survive. So it is our duty, everybody in this hall should make sure that, even I think IMA Pandharpur can take lead and get some dummies, buy some dummies, and you can have a periodic CPR training sessions all over the Pandharpur Taluka and Satara district. Thank you very much.
Very commendable work in teaching CPR to lay persons. Now the topic is open for discussion. I request the chairpersons or from the audience if you have any questions. Any questions?
हाँ बोला. Okay. Asymptomatic Brugada syndrome is basically known as Brugada pattern on ECG. What you require is just take an history of sudden cardiac death or syncope in the family. If they do not have, nothing more needs to be done, just monitor them. Sometimes, if you really want to study, you can do SCN5A mutation studies, which are now available in Mumbai, Pune, and maybe in Solapur. As far as WBWE syndrome is concerned, तो बऱ्याच वेळेला आपल्याला पेशंट्स मध्ये दिसतो. अशा वेळेला just do a simple stress test. And on if stress test, as the heart rate progresses, the WBW delta wave is vanished. Your PR interval becomes more, then you need not worry. So that means the refractory period of that particular pathway is very long, and it will not cause any arrhythmia. So this is a way of, re-stratifying WBW. So just do a simple stress test. If that thing disappears, need not worry. Second thing in that WBW syndrome, make sure that they do not have atrial fibrillation, and during atrial fibrillation they are not given any AV nodal blocking agents such as verapamil, diltiazem, digoxin. You can give amiodarone, which acts, you can give 1A, 1C drugs, which act on the pathway. So this is very important in a WBW syndrome. Do not give AV nodal blocker agents, especially in the presence of atrial fibrillation.
Well, I congratulate you on that important topic of ECG.
Sir, yes. Is there any correlation between neuropathies and cardiac arrhythmias? Neuropathies, carpal tunnel syndrome and cardiac arrhythmias?
Yes, that's what I was trying to tell. Usually this amyloid-related hypertrophic cardiomyopathies, restrictive, they have very common symptoms of carpal tunnel syndrome, neuropathies, breathlessness. What happens is you do echo in these patients. Nobody does echo in these patients. So make sure that these people, if they complain of breathlessness, just take out an ECG. ECG will show low complexes, or if it is a hypertrophic, sometimes huge complexes also. Then do a NT-proBNP. If NT-proBNP is raised, 100% त्या माणसाला preserved ejection fraction with heart failure आहे, and then they require some genetic studies. In fact, there is a drug called as tefamidis, which is a very good drug, which can be used in amyloid-induced hypertrophic cardiomyopathy, and that is why it is very important for us to break the barriers of neurology and cardiology, and that is where a role of a physician comes, who looks at a patient in whole, as a whole. Then मी फक्त cardiology बघणार म्हणजे एक आंधळा आणि तो हत्ती, चार आंधळे आणि हत्ती असं नकोय आपल्याला. हां सर.
Yes, thank you for making that very simple. I, being a gynecologist, don't look much into the ECG part, but I would like to congratulate you on that CPR initiative.
Thank you,
I would like to inform that Pandharpur IMA, few members of it who are the members of anesthesia team, they are doing this job and they are giving CPR initiatives. We had a workshop in Pandharpur IMA itself, and they are doing it various schools and various CMEs. We do have one lecture of CPR as a part of that CME.
In fact, Dr. Dikshit, Dr. Zhirpe, and Dr. Kapil Borok and the IDCCM Pune branch, they have good dummies, and they do these programs quite often.
Yeah, Pandharpur Anesthesia Society has a dummy, and they keep on doing this.
But the issue is, one dummy is not sufficient. You have to invest in at least 10 to 15 dummies so that you can do many people.
Yeah,
you know, एक dummy घेऊन नुसतं दाखवून उपयोग होत नाही. Everybody has to actually have a hands on.
We are doing in group of 10. Then
yes.
Thank you so much.
Hello, sir. Hello, sir. Sir.
Yes, sir.
Thank you for your excellent talk. I want to ask two questions. One is how to work up for this restrictive cardiomyopathies, amyloidosis or sarcoidosis, and how will treat.
See, unfortunately.
And your experience regarding the restrictive cardiomyopathy in our area.
See, restrictive cardiomyopathy again is also called as heart failure with preserved ejection fraction. Basically, the heart failure is the symptom. Otherwise, they don't come to know. So you see the ECG, you find something, you do a echo. In echo, you see huge left and right atriums and a very hypertrophied and stiff ventricle. So this is a very advanced level of diastolic dysfunction. And these people will require beta blockers. These people will require, nowadays, SGLT2 inhibitors have very good data in restrictive cardiomyopathy and basically ARNI and other things. So the treatment remains same as heart failure, but then the diagnosis is echo and NT-proBNP. Again, why I insist on NT? बराच वेळेला echo मध्ये ejection fraction normal आला की आपण म्हणतो हे काही नाही आहे. So again, you do NT-proBNP, it will be in thousands in these patients, and then you can, as far as specific treatment is concerned, one of them is amyloid and tafamidis. Tafamidis is prohibitively expensive, like 10 lakh rupees per treatment, but it is a good treatment.
Hello, sir. I have one question. You just told that WPW syndrome patients, they need to go for stress test, and when there are positive findings, then only you go for intervention. So if the patient is symptomatic and, for prophylactic, can we go for EP studies and ablation irrespective of?
In WPW syndrome, if you have one, recurrent palpitations, two, documented tachycardia, such as orthodromic narrow QRS tachycardia, which looks like a AVNRT but which is actually AVRT. And third, patient has a history of syncope. In these three scenarios, either of it, if it is causing problem in patient's day-to-day activity, you can refer them for EPS and ablation. It is very easy to get rid of it. Most of the times, half of our EP study referred patients are for cosmetic ECG correction, which is not required.
Yes, sir. Or any recommendation for ICD implantation in those cases?
ICD implantation usually is not required for WPW unless it has got a very short refractive period and they have what is called as orthodromic, म्हणजे उलट्या बाजूनी वरती येणारा जो tachycardia असतो, which is a broad QRS tachycardia. In that case, but very rarely you require ICD for WPW. WPW is that way a very benign arrhythmia.
Yes, sir.
Another problem with WPW is atrial fibrillation.
Yes, sir.
See, the Achilles heel of WW is atrial fibrillation because normally whenever you get atrial fibrillation, तुमचा AV node strong असतो, AV node बंधन पलीकडे जात नाही. जरी atria are beating with 300, your ventricle is beating max by 150, 160.
Yes, yes.
But when you have a atrial fibrillation and WPW, the एट्रियाचे सगळे जे इम्पल्सेस आहेत ते त्या एक्स्ट्रा पाथवेवरनं डायरेक्ट व्हेंट्रिकलला जातात आणि ते पेस ventricle with 200 and 300. And that is the time when you get ventricular fibrillation and cardiac arrest. So never give in presence of atrial fibrillation digoxin, diltiazem, verapamil or any AV nodal blocking agents.
Okay, thank you.
Thank you.
Thank you.
The next questions we will ask in lunchtime also.
Thank you.
So I request Dr. Vora sir to felicitate Dr. Rituparna Shinde. request Dr. Boraveke sir to felicitate chairpersons. So a healthy heart will give you courage to face and overcome any challenges in life. It's never too late to take your heart seriously. So make it a priority. This is the take-home message from this lecture. Thank you, everybody.
Next lecture is by Dr. Subal Dikshit on neglected part of healthcare. I request Dr. Vivek Gujar, Dr. Sandeep Gauri and Dr. Suraj Paskavade to come on stage to chair the session. Dr. Gujar will be introducing the speaker. Our next speaker, Dr. Subal Dikshit, let us know about the speaker. He has done MABS from Bharati Vidyapeeth, Pune. His MD is from Pravara Medical College. He is fellow of American College of Critical Care Medicine. Also fellow of IDCCM, Indian College of Critical Care Medicine. He has worked as chairperson-elect, chairman, secretary and treasurer of ISCCM. He is examiner and teacher of Indian Diploma in Critical Care. He has organized various teaching courses in ICU, patient management and sepsis. He has received many awards such as Presidential Citation Award, Appreciation Certificate for many outstanding work at ISCCM Pune.
So thank you very much. At the outset, I would like to thank the entire organizing committee, especially Dr. Girish Borawke sir as the organizing chairman, Dr. Guzre and Dr. Sunil Kalinde, the president of the M A Pandharpur, for arranging this excellent CME. This is a great initiative. In fact, after Dr. Borawke sir said that he started the CME after the COVID pandemic, this is a great initiative and they must continue it. And this is a part how the way the future is going to be of academics, so that everybody stands on the same page and they know exactly what are the current concepts and what are the current guidelines in all fields of different specialities. So again, after thanking all the organizing committee members of M A Pandharpur, I would like to talk on this topic of how I feed of patients in ICU. Of course, nutrition is a neglected topic in intensive care medicine, not only in intensive care medicine, but also into a general practice or even in OPD or even in a physician practice. We just have a habit of just referring the patients. I'll be sticking around to hospitalized patients, and vis-a-vis certain part of the talk, it correlates and overlaps with the hospitalized or even OPD practice. All of us know that mainly all patients who come, especially because of any fever, dengue fever, whatever kind of fever, they are in a hypercatabolic state and they are in a rapid prone of malnourishment. We have got dengue, we have got COVID, we have got swine flu, the appetite is not good, they have got hepatic dysfunctions, and as a result of which these persons are in a hypercatabolic state. They don't eat well, they don't hydrate themselves well, and as a result of which there can be malnourishment which can be set in. And of course 50% of the hospitalized patients, especially those with ulcerative colitis, Crohn's disease, malignancy, ARDS, difficult to wean patients, they are of course very severely, abnormally and obnoxiously depleted as far as protein and calorie nutrition. Inadequate nutrition, whether it's for any recovering patients, we have the habit to give it in the OPD. We do write OPD prescriptions of enteral nutrition support. That's only because we want to get the patients recovered faster. Inadequate nutrition is important with increased length of hospital stay, increased morbidity, mortality, secondary infections, because weight loss occurs, and that weight loss, if it continues over a period of more than 10% or 20%, within a period of about 3 weeks to 6 weeks to 12 weeks, then there is an immune suppression which occurs, and that immune suppression can precipitate secondary infections. And more importantly, along with that, there is muscle wasting, and muscle wasting almost about 1 1,000 grams, that's almost 1 kilo of muscle loss can occur per day in severe hypercatabolic state, especially in those patients with dengue with multiple organ failure, those patients with leptospirosis with multiple organ failure, those patients with renal dysfunction, hepatic encephalopathy, ARDS who are being intubated and ventilated. And therefore, you have to plan the nutrition prescription in all these patients as much as you plan your antibiotic policies, ventilatory strategies, or dialysis prescription. Nutrition, as I said, not only is important for that particular day, it is important right from the date the patient comes to you in your OPD or in your hospital, whether he is a fracture neck femur, a simple stroke, whether it's a pleural effusion patient or a simple pneumonia or a COPD with acute exacerbation, or he's just come in with organophosphorus poisoning or whatever kind of patient, or a polytrauma, or even appendicectomy or intestinal obstruction who has not been eating well, or a resection anastomosis which has been done. So the nutrition starts right from the day the patient gets admitted. You are supposed to definitely evaluate it as much as you evaluate to reach a diagnosis. Because if you see here from the graph, if the cumulative energy deficit is more than 10,000 kilocalories, then the chances of these patients landing up into sepsis are high, and these patients then having the increased length of hospital stay or increased morbidity into these subset of patients will be on the higher side, vis-a-vis as against the cumulative energy deficit. If it is less than 10,000 kilocalories, then the chances of these patients landing up into protein energy malnourishment or the length of hospital stay will be less, and decreased chances of sepsis. Mind you, it's a demand versus supply gap. You have to see that every patient's nutrition needs to be optimized. We definitely see that we maintain OPD patients who are not requiring hospitalization, we tell them to maintain hydration. Minding hydration is not just one part of it. You also need to see that those patients also recover well. Even those patients on the OPD patients with dengue hepatitis, they don't eat well because of a dengue hepatitis or even because of viral fever, acute infective hepatitis. Certain patients don't need hospitalization at all, and you need to supplement them with enteral branch and amino acids. So you need to plan the nutrition prescription as much as you can plan your ursodeoxycholic acids or adeoxycholic acids or vitamin K or any other form of antibiotic prescriptions. And therefore, whether it's a medical patient or a surgical patient, you have to see that the demand versus supply gap has to be very narrow, and starting of timing of nutrition support is very important as much as you give thrombolysis within the first 1 hour, 3 hours in stroke patients or AMI, as much as you should plan the nutrition prescription on day one once the patient sees you in whichever form, whether it's a casualty or OPD or a IPD patients in an ICU or a non-ICU patients. Mind you, the impact if you don't feed it, why nutrition is important. As I said, it's going to cause a protein and a calorie malnourishment. Not only protein calorie malnourishment, there's going to be a muscle loss, and that muscle loss is very impairment, and that muscle loss, almost about 800 to 1 kilo of muscle loss occurs per day. And therefore, if you have a surgical patient, you will have a poor wound healing occurring. You will have a burst abdomens which are then coming up. You will have fistulas which will be formed. Those patients who are COPD, who have been intubated, or those patients who are been on non-invasive ventilatory support, they will have impaired respiratory muscle functioning. The mechanics of the respiration will be low. The respiratory muscle fatigue will be occur. They will be difficult to wean off the patients. There will be organ dysfunctions, and these, because of organ dysfunctions, the immunity will be suppressed, and hence there will be increased chances of SIRS or morbidity, mortality, length of hospital stay, and then you'll have to go up into a sepsis and septic shock like scenario. Mind you, the timing is early. Early initiation of the nutrition prescription is important. Early optimization is there. We do have the specialized nutrition formulas, immunonutrition, which has now got limited role. I'll just touch in the talk that where exactly it should be considered. And mind you, as I said, is not only for the ICU patients, even for ward patients. Even if you consider a simple ward, even if your hospital doesn't have any ICU, it's okay. You should optimize nutrition patients for even your ward patients. That is very important. A fracture neck femur, you see that he doesn't walk. A TKR undergoing a total knee replacement, total hip replacement. Of course, just changing the joint is not useful. You have to optimize the patient nutritionally. Do you give them supplements with calcium? You give them vitamin D or whatnot. But definitely, unless and until the protein or the muscle strength is there, he or she is not able to attain that weight and do the physiotherapy. And that's what is also equally important. Mind you, assessment of nutrition is very, very important, and this nutrition assessment can be done with the help of Nutri-Score, indirect calorimetry, which is available in few institutes. There is a subjective global assessment, the ultrasonographic measurement thickness for the rectus femoris or the triceps thickness, what we do, or the NRS or the nutrition risk screening score. Mind you, commonly if you have a dietitian which is there, she or she does a subjective global assessment or a nutrition risk screening tool, which can also be done. And mind you, all patients who are admitted to the hospital, who are seen on OPD or IPD patients, you must do a nutrition prescription planning within the first 24 hours after being admitted to those. So, and you must identify the patients who are at a high risk, who is going to require nutrition support apart from your surgical maneuvers or apart from your ventilatory or nutrition prescription. Indirect calorimetry is the best because it helps you to achieve and give you a precise amount of delivery of the nutrition support to almost an accuracy of almost 90%, vis-a-vis if you compare it with subjective global assessment or nutrition risk screening or with the help of a Nutri-Score. It just helps you to identify whether you have got a high-risk patients or the low-risk patients, and you can deliver nutrition support into these subset of patients with almost an accuracy and specificity almost about 72% in these subset of patients. The guidelines are very clear. As I said, a prevention is much more better than a pound of cure. So you see that whatever patients who are there, a simple CLW, even if it's coming and if he's nutritionally weak, if he's got edema, it also shows that the patient is definitely protein depleted. They are bound to ooze, and these sutures may give off, and they can also give rise to burst abdomens, and that can give rise to pancreatic fistulas or even enteral fistulas. The route, as I said, oral is just where the patient can identify the taste, but in those patients who can't eat, of course, enteral nutrition support is the best way. Enteral nutrition is easy, it is cheaper, it is physiological, and it is much more easy, and because you have to use the gut, and in case if you don't use the gut, you'll definitely lose it. Of course, we have got plenty of things. We did have exactly amount of proteins, carbohydrate, lipids, fats, and everything was available for breakfast also today. Of course, we have got the carbohydrates, lipids, but mind you, we have got the typical amount of an entire thali which should be had, which should be served with fibers, calcium, proteins, magnesium, lipids, minerals, trace elements, antioxidants, omega-3, all needs to be taken because each one of it has got a different source of action. Of course, you know that the carbohydrates give you about 4 kilocalories, the proteins give you 4 kilocalories, and of course the fats, the butter, the cheese, equally important, whatever form of cheese you have, they give you 9 kilocalories of energy per gram, which is important. The standard nutrition prescription, either you should have it, you should just have it with 25 kilocalories per kg of ideal body weight and give proteins about 1 to 1.5 grams of per kg body weight of ideal body weight. Of course, if you are dealing with a high stress factor, mind you, you have got a perforated appendix, a perforated intestinal obstruction or a sigmoid volvulus, a fractured neck femur, ARDS, who is on ECMO, who is on ventilator, who is on dialysis. Definitely the stress factor or the seriousness of the patient is quite high. A burns patient, a polytrauma patient, they require proteins almost up to 2 to 2.5 grams per kg of ideal body weight. Of course, the calorie count will remain between 25 to 30 kilocalories. We do have softwares, we do have nutrition prescriptions, we do have got apps which also tells you and helps you to calculate the nutrition prescription even if you don't have the luxury of a dietitian. But mind you, the dietitian is an ancillary support, but I personally feel as a doctor, as a physician, as a general practitioner, as an intensivator, it is our moral duty as much as you write casually as erythromycin or even any form of antihistaminics. It is our moral duty and responsibility to see that you plan the nutrition prescriptions in whichever way so that the optimization of the patient is done so that the recovery occurs faster. The combination is quite simple, is 50s to 30s to 40 with a mixture of glucose plus proteins per fat so that you give an easy delivery of system, and it also helps you to have a smooth control. Mind you, nutrition does not increase the sugars. The sugar levels go up because of the stress factors or infection, because of the liberation of the anti-insulin catecholamine hormones, and enteral nutrition is cheaper, physiological. It prevents the gut mucosa, it prevents villus atrophy, it is much more cheaper, and it prevents the bacterial translocation. In case if you are dealing with enteral nutrition support, the concept is very easy. You don't require, this is a typical chart. You try to achieve 80% of the calorie goals within the first 72 hours. And if you cannot achieve it, then the role of early partial parenteral nutrition or supplemental parenteral nutrition come up. The concept of total parenteral nutrition has practically gone from anywhere. It is mainly supplemental or partial parenteral nutrition support. There is no need to see the gastric residual volume. It's outdated concepts. So that's a very outdated concept. There is nothing like a test feed. You just start feeding the patients with small dose of feeding. And in case if you find that there is abdominal distension, or only if you find that the returning fluid, in case if you check it is quite high, or there is a distension, don't stop the feeding. You can reduce the rate of feeding by half, but use prokinetics aggressively. And this prokinetic should be used in the form of levosysulfide or in the form of metoclopramide or erythromycin, but continue to feed the patients and try to achieve 80% of the calorie goal within the first 72 hours. And in case if you cannot meet it, then supplement it with the help of partial parenteral nutrition support in whichever form, whether you are having amino acids or intralipids or a disease-specific nutrition specifically for using it in the way of hepatic patients or renal failure patients, that is there. So enteral, parenteral, partial parenteral, what is there? Combine enteral and parenteral in case if you cannot achieve the goal, but see that you deliver nutrition patients throughout the care, because we have seen at the start, a cumulative total is important. A cumulative balance of calorie deficit should be less than 10,000 kilocalories, and only then you can prevent infections, and only then you can reduce the length of hospital stay, morbidity, as well as mortality. Only those patients who has got almost a major gut resection who have been done, who cannot assume it, those who are severe cancer cachexia, sometimes you need to define or sometimes postpone a planned surgery also, in case if you have got to optimize the nutrition patients, because you want the outcome of post-operative patients to be better rather than just doing a heroic surgery. Most important, optimize the patient and then take up the patient for a planned surgery. Mind you, my words are very clear. Don't defer an emergency surgery. Of course, if it's a planned surgery, guidelines have even suggested that first optimize the patients nutritionally, and in case if you require aggressive, use partial parenteral or total parenteral nutrition support with enteral nutrition, and then plan the surgery in case if it's not an emergency patients. The sugar levels, as I said, is not because of the sugars, it's mainly because of the sepsis or the anti-inflammatory hormones which are liberated, which are there. But try to keep the sugar levels reasonably well under control, which has been backed up by the nice sugar levels or the intensive sugar levels, or we from ISCCM also came up in the Indian Journal of the Management of Dysglycemia, where we have recommended that the sugar levels in whatever form of disease you are dealing with on the OPD patients or in even ICU or non-ICU patients should be kept between 150 to 170. See that the HbA1c levels is below 7. In case if you are taking for a hip replacement, joint replacement, the surgical HbA1c needs to be around 6.5. And for all hospitalized patients, see that the sugar levels are at least checked in a calibrated glucometer almost 6 times to 7 times a day. The guidelines have also said the same things, that assess nutrition prescriptions as fast as possible. Only those patients who are hemodynamically unstable in the ward or whatever in the ICU, in case those try to optimize the fluids first, and if the patient needs inotropes, see that you can start feeding the patients only once you have got fluid optimizations and once you have achieved that there is a decreasing doses of vasopressors as defined with the MAP of more mean arterial pressure of more than 65, then it is said that the patient is hemodynamically optimized, and then you can start feeding the patients. So guidelines again suggested that do a subjective global assessment, start enteral nutrition, give 80% of the calorie goal,
5 minutes
see that there
remaining.
is hemodynamic stability. 1 minute I'll take. And there is nothing as such that give nutrition support early as possible as to achieve the calorie goals into these patients. Whether you should use exclusive supplemental or total parenteral, there is no role for exclusive supplemental. Mind you, any form of enteral or parenteral can be given, but enteral nutrition support, mind you, only commercially available polybaric formulas are the best way, where you can exactly deliver the calculated amount of calories and proteins. There is no role for hospital feeds or kitchen feeds. They are outdated. They are definitely bacteriologically content, and there is nothing like home feeds or kitchen feeds which we still give it. Only use commercially available blenderized commercial formulas, those, and which can exactly know the delivery of content. They are bacteriologically free, they are isoosmolar, they don't cause blocking up of the peg or the gastric tube or the Ryle's tube or the jejunostomy tubes, and standard polymeric formulas are the only ones which should be considered. Is there any role for any rules of commercially available immunonutrition? There is no role for commercially available nutrition into it. And should we use only partially digested peptides into all patients? No, they should not be used into all patients. They should be reserved only in those patients where you think there is malabsorption, ulcerative colitis, or there is severe cancer cachexia with amount of loose motions. Are loose motions caused every time because of feeds? No. Please assess the used dose of prokinetics what you are using, and don't forget to rule out a Clostridium difficile infections because of the inappropriate, sometimes long-term use of antibiotics into intensive care units. Just to avoid diarrhea, should we use fermentable oligosaccharides? No, they should be considered only if there is persistent diarrhea into a reserved subset of patients with ulcerative colitis, Crohn's, or severe malabsorption syndrome. Any antioxidants, vitamins, supplements should be considered and given into all subset of patients too, especially in persons of burns, trauma, and critical care illness, difficult to be in patients of mechanical ventilations. So the last slide is that assess patients whether they are in the OPD or whether they are in the IPD or non-ICU patients, give enteral nutrition prescription, and use partial parenteral if need be to give the caloric deficit goals. Thank you very much, and I'll be happy to take any questions.
Thank you, Dr. Dikshit, sir. The topic is now open for discussion. Any questions?
Thank you, Dr. Subal, sir, for giving such informative information on parenteral nutrition. Here, in a rural setup, we have to prioritize the things. We agree that protein and energy nutrition will improve the survival, everything. But there are a certain group of patients who cannot afford antibiotic also. In that case, nutraceutical industry and other things should come down the prices. This is my suggestion.
This, in fact, we'll have to discuss it, and you'll have to discuss it and see that the nutraceutical factors are included in the National List of Essential Committee, DCGI, and you should write a letter to them, and so that the price control occurs into the NLEM. But you cannot compromise the nutrition prescription.
Even this is my experience, even on an OPD basis.
Technically, nutraceuticals are not being considered for price control. I am a part of the NLEM committee, DCGI, as far as the blood, till December. They have not been considered as far as price control as of minute of time. But in 2024 April meeting, that's a possibility that the nutraceuticals and even the enteral nutrition products will come under the DCGI NLEM committee as a part of nutraceutical. Currently, nutraceuticals are even not covered by insurance companies also. That's the reason. But that's the reason why they are going to come under price control. So your point will only be valid only when if these patients the price is controlled, then everybody can use it. But more important, scientifically, as a scientific forum, we need to see that you have to consider nutrition support in all hospitalized patients.
Thank you.
Very true. Nutritional support is very much needed in post-operative patients, and the outcome significantly changes if we give amino acids in post-op patients. But in periphery, we have to be very careful about the cardiac status of the patient, because generally the nutritionally debilitated patients are old age, and cardiovascular status is not very much known. So we have to be careful about that, but it cannot be underestimated that the nutritional requirement.
In fact,
and
that's what exactly, madam. In case if the patient is very cachectic,
Yeah.
you are supposed to gradually go up feeding so as to avoid the complications of refeeding syndrome.
We have to give it slowly.
Hyperphosphatemia. At the same time, echo, which is now easily available,
Yeah.
you know that clinical examination, you will have edemas which are there, you will have angular cheilosis which will also be there, you will be skin things which will be suggestive of a possibility of a B complex deficiencies which will be there. So you can easily identify whether we are having got complications which we are dealing with. And if the LV function is normal, there is no contraindication to give nutrition. In
Yeah,
fact,
a normal
not
LV function
giving
is needed.
selenium, trace elements, copper or other forms are going to precipitate and possibly aggravate a dilated cardiomyopathy, especially in alcoholics, over a long-term period of time.
Yeah, but well-managed nutrition post-operatively significantly changes the post-op outcome of major surgical patients. Thank you, sir. Now I request Dr. Vivek Gujar, sir, to felicitate Dr. Dikshit. I request Dr. Sunil Karande, sir, to felicitate the chairperson. Looking good, feeling good go hand in hand. If you have a healthy lifestyle, your diet and nutrition are set, and you are working out, you are going to feel good. Let's move to the next lecture, that is the lecture on organ donation, myths and facts. The lecture is by Dr. Kapil Zirpe, sir. May I call upon stage Dr. Arjun Sarunke, sir, Dr. Sunita Karande, madam, and Dr. Amit Paule to chair the session. Let me introduce Dr. Jirpe, sir. He is head of Neurotrauma Intensive Care Unit. He is affiliated to Government Medical Foundation, Ruby Hall Clinic, Pune. He is president of ASARCC, past president of ISCCM, past president SNCC, past WFSICCM council member, past chancellor Indian College of Critical Care Medicine. He has written many chapters in various books, plus 75 research articles. His areas of interest are neurocritical care, mechanical ventilation, sepsis, and organ donation. Thank you, Dr. Jirpe, sir. The lecture will be started.
Yeah, 25 minutes, right, madam? 25 minutes, okay. I'll take 5 minutes extra. Okay. This topic is different, organ donation. This topic is for everyone. I am giving lectures since last 30 years in this topic. Still the situation is same. Generally, in medical field, we were taught that save the lives. We doctors save the lives. We doctors save the lives. I am talking beyond that life. Unfortunately, suppose in few patients we are not able to achieve those targets. Are we going to drop our shoulders? Or we are going to save another 8 lives? And that's where this concept started, the organ donation. There are still lots of myths and there are confusion regarding the organ donation in a medical field. I am not going to talk about the common people. I am going to talk about the medical field. The questions are same. Whatever the doctors are asking me and whatever the relatives are asking me, more or same, I will try to cover in next 30 minutes. First thing, first difference, everybody should know, body donation and organ donation, completely different. Still, today I am getting called that we want to donate the body. Whole families are filling the form. Body donation is different. Body donation means after the circulatory death, ज्याला एखादा मनुष्य मृत पावतो त्यानंतर आपण ती अख्खा देह एनाटॉमी डिपार्टमेंट ऑफ द मेडिकल कॉलेजला डोनेट करतो आणि त्यावर आपल्यासारखे सगळे डॉक्टर्स शिकतात, त्याला बॉडी डोनेशन. सो दॅट इज ऑल्सो द डोनेशन. प्लीज डोंट डिस्करेज. If someone asks you they would like to go ahead with the filling the form for the body donation, yes, we should support that. Organ donation is different. Organ donation means patient is only brain dead, clinically brain dead, proven brain dead, but his all other organs are still working. Then we can retrieve those. Completely different than what we are doing on the survey. Look at the numbers. What must be that? 8.4 billion deaths happens per year. Out of that, 1 to 4% are the brain dead patients, where we talk about the organ donation. That comes to 84,000 to 3,36,000 patients are brain dead officially declared. Out of that, only less than 1% patients' relatives gives the consent. And the rate of the organ donation in India is 0.007. That means average 600 to 700 organ donation happens across India out of the 84,000 to 3,36,000. That is a reality in 2023. Look at these graphs, very simple to understand. In other countries, these are the organ donation, these are the live organ donations, and these are the cadaver organ donations. In India, 95% is a live organ donation. If you want to stop the all malpractice regarding the kidney racket and all these rackets, the answer is the cadaver organ donation. Avaydan, Shreshthdan. If you convince even one family for the organ donation, it saves the 8 lives minimum. I will tell you what we can do wonder. No need to go to the any mandir, masjid or anywhere to get the blessing of the God. The best thing is God is coming to your hospital. Just help that families to take a decision, because it's going to save your 8 lives and you get a lot of blessing from the God. I am standing in a Pandharpur, still I am talking, but that is a truth. Look at, there are the liver failure patients. There are the patients on a dialysis. There are the patients of the heart failure. This young girl is a heart failure patient. Can you imagine? Hardly out of year she attends the, her school for 1 or 2 weeks. Rest of the time she is in a hospital. Dialysis life is miserable. Miserable life is on dialysis. They are nutritionally poor, they are cachexic, they are infection, pain, agony, waiting in that machine. And when dialysis goes, hell of the problems goes to this thing. These all patient needs organ. Organs are available. Only will is not available. Only system is not geared up. Only we are not aware about this concept. And that's why these patients are either dying or living with the miserable life. We can do that. We can help them out. That is the only purpose of the organ donation drive. Which organs you can give? Even natural death happen, natural, where the heart stops. That is a very standard process. You can give eyes, you can give heart valves, pacemakers, bone marrow, skin, cartilage, middle ear bone, so many things you can give. Even the patient is not heart beating. Believe me, we have retrieved the Around about 50 to 100 valves and pacemakers in rubeole since 1995. The moment patient of the valve get unfortunately expired, we approach the family, can we retrieve those valves? We call the cardiologist, they come, they take the patient in cath lab, remove those valves, and we can use it in a free patients. Pacemakers, they are machines, they never dies. The human body dies. So we are doing it since 1995. Even if you don't have a concept of the organ donation, you can do this good work. At least somebody will get the pacemaker, valves and those costly 5 lakhs, 6 lakhs machines, and it is easily possible. Relatives never say no. You need to take them in a confidence and give them what you are doing. This is what happens in a brain dead patient. If suppose he is a one brain dead patient clinically, either head injury, stroke or IC bleed or post cardiac arrest or whatever the reason, when the patient is clinically brain dead, you can take the eyes, larynx, lungs, heart, liver, kidney, intestine, pancreas, skin, bone marrow. So many lives you can save. I am the actually part of the cadaveric organ donation of the rubeole, and we have done in rubeole since 1997 more than 200 cadaveric organ donation. That means minimum 600 to 800 lives we have saved. Simple. So we are talking about what we did in ICUs and the wards and the saving the lives. We never talk about these lives where there is no life. These skin burn patients are waiting for the skin. If suppose there is a 80-90% burn, from where you will get the skin? Only from the brain dead patient. Nobody is going to give him the skin. Your pancreas, we generally talk about the heart, liver and lungs and kidney. What about the so many other organs? They can be retrieved. And when family generally give consent, they give consent for everything. Very few families, I will give the example, specify that recently only happened. This is one of the best way to promote organ donation. This young girl of the heart failure standing next to dustbin, and she is saying that kid, don't throw your organs in dustbin, I need it. Nobody takes the organs in heaven. This is what the organ donation, nothing else. It is a noble cause. It is one of the best way to help the families. It is one of the best way to get the satisfaction in our day-to-day practice. We say a lot of burnout. Where is burnout? We don't do anything. We are not doing our duties. We are dropping the shoulder once the patient is lost. I think that your life, that 7-8 lives starts after the patient becomes brain dead or clinically even dead, I told you. There are so many myths. Believe me, in last we have done in rubeole the first cadaveric organ donation on 11th of April 1997, and since then we have done more than 200, and fortunately or unfortunately I am the part of the each and every cadaver, and I have came across a lot of myths. I am going to clear with those. First myth generally in a common people about the doctors is that if suppose my relative comes to the hospital and if with a severely head injury, you will not try for his saving lives, you will consider the organ donation. And that is one of the side effects of the organ donation. If rubeole is doing the maximum organ donation, there is a lot of myth that the rubeole is creating the organ. Nobody creates the brain dead patient. So we need to take the families in a confidence, say that we are doctors. Our first aim is save the lives. We are only made for saving the lives. We only save the lives, we try our level best, but unfortunately, in spite of the aggressive and the scientific management, if patient becomes clinically brain dead, then we may. So, where we Indian people are lacking in a communication, 6 hours you will work for saving a life, but with the families you will spend few minutes. Exactly opposite you should do. If you are spending 4 hours with the patient, spend at least minimum 30 minutes with the family. Explain them, take them in a confidence, never sit across the table, that is confrontation. That means they are asking and your question and answer, that is confrontation. Sit by side of the families. We are not the lawyer and this thing, they will say that, doctor, have you tried? We are saying that we have tried everything. Doctor, do you have any facility? We have every facility. Why this confrontation? I will sit by the side of this. So we never sit across the table. We sit the side of the table. And we say that we are one of your family member. Ask us a question, we will answer your questions. Simple things matters in our medical field badly. Madam, give me 1 minute more. This laptop is very slow. Take some slide. Okay, sorry. Second myth. The family asks you, when you declare the brain dead, you will declare the brain dead or you will immediately declare the brain dead and you will start. No. We have to tell the families that brain dead is not a diagnosis. Brain dead is a process. There are the government experts. Suppose I would like to declare the brain dead or authorize. I have to register myself on a government expert panel. Then I will go to the entire clinical examination, starting from the pupillary reflex, light reflex, dorsal movement, calorie test, cough, gag, spontaneous respiration, apnea, reflexes, so many things. I will document. Then I will do the apnea test where I will disconnect the ventilator for 10 minutes. Nowadays what we are doing, we are calling relative by the bedside and in front of them I am doing the apnea test. So look at your patient is not breathing. So don't believe on anyone, you believe on yourself. And these tests are repeated after the 6 hours. So after 2 tests, the gap of the 6 hours, if there are no signs of the brainstem, then we are declaring brain dead. So it's a proper diagnosis, it's a process. So we are not casual about it. If someone in the unit says that this patient is brain dead, we fire them. No loose talk. No loose talk. The patients are still, unless and until second apnea is positive, patients are still live. There is a still chance of surviving. So that we need to explain to the families in detail. Third myth. Families ask that, okay, I have a 74-year-old relative. Can we donate the organ? इसका age तो बहुत ज़्यादा है. Sir, age खूब जास्त है. ते खूब वर्ष cigarette पीत होते. ते दारू पीत होते. Answer, there is no age limit for organ donation. Even leave it to that transplant team. They do the lot of tests to see the quality. See, कुठलाही दान करण्यासाठी क्वालिटी बघायला पाहिजे. इवन आपण शिळं अन्न कुणाला दान देऊ शकत नाही, कुणाला भुकेल्याला देऊ नये, ताजं द्यायला पाहिजे. ऑर्गनची क्वालिटी असते. ऑर्गनची क्वालिटी भयंकर डिटेलमध्ये टेस्ट केली जाते. ह्याच्यामध्ये आम्ही सगळे एक्सपर्ट्स इन्व्हॉल्व असतो. 79-year-old पेशंट्स मध्ये पण आम्ही लिव्हर ट्रान्सप्लांट केलेले आहे. सो एज इज नो मोर कॉन्ट्राइंडिकेशन फॉर ऑर्गन डोनेशन. पहिला. Second thing is the smoking. We doctors are, careless. We are not taking history properly. There is a definition of smoking. 40 cigarette packs per day for 40 years is a smoker. If somebody is having the 4 or 5 cigarettes per day, he is not smoker. Don't reject his lungs. 80 ml of the hard liquor for 20 years is a alcoholic definition. बरोबर ना बरोबर sir? Saturday Sunday तो हम भी लेते. We are also regularly taking Saturday Sunday. So am I alcoholic? Believe me. Somebody in my unit few days back said that it's a history of chronic alcoholic take. I said, have you taken the history? No sir, he takes the alcohol. I said he takes the alcohol, but which type of the alcohol? Whether wine, beer, rum, whiskey, what was the percentage, what was the amount? Then when we took the history, he was taking Saturday, Sunday. I told, I am also taking Saturday, Sunday. Why you are talking? Am I alcoholic? He said, no sir. Then believe me, that organs, even liver, we retrieve and transplanted. Please don't label anyone casually in your practice. त्यांचं मेडिक्लेम जातं, त्यांची फॅमिली डिस्टर्ब होती आणि तो खरंच काय अल्कोहोलिक नसतो. आणि एकदा एकाने क्रॉनिक अल्कोहोलिक लिहिलं ना, आयुष्यभर सगळ्या फाईल क्रॉनिक अल्कोहोलिक होतात. तुम्ही लिहिताना प्लीज, एकाला कोणीतरी लहानपणी टीबी लिहिलं ना, तो आयुष्यभर 50 वर्षापर्यंत टीबीच असतो त्याला. मेडिक्लेम पासून सगळ्या गव्हर्नमेंट स्कीम रिजेक्ट होतात. त्यामुळे रुटीन लाईफमध्ये पण नका लिहू, हिस्ट्री घ्या. Smoking, alcohol, all are proper definitions are there. So they are not contraindication for organ donation. And I am not suggesting to take alcohol or smoking. I am just giving you the definition. Saturday, Sunday, I am talking about organ donation, but there are COPD and other things may happen, or every genes are different. Huh? Okay, the next question frequently asked. तुम्ही माझ्या फॅमिलीला चार्ज करणार का? तुम्ही तर म्हणता ऑर्गन डोनेशन इज अ नोबल ऍक्ट. तुम्ही तर म्हणता की सर्वात श्रेष्ठ दान आहे. मग तो खर्च कोण उचलणार? सिंपल. जर समजा क्लिनिकली ब्रेन डेड डिक्लेअर केल्यानंतरचा सगळा खर्च ट्रान्सप्लांट होईपर्यंत हॉस्पिटल बिअर करतं. बरे फक्त रुबेवॉल करतं का नाही, हा गव्हर्नमेंटचा नियम आहे. इंडियातल्या सगळ्या हॉस्पिटलला हा नियम लागू आहे. जर ऑर्गन डोनेशनला तुम्ही ब्रेन डेड पेशंट डिक्लेअर केल्यानंतर जो मेंटेनन्सचा जो खर्च असतो तो खूप असतो, 1,00,000, 1.5 लाख 2 लाख जातो, कारण तुम्हाला सर्व ऑर्गन्स इन्व्हॉल्व करायचे असतात. इव्हन आम्ही पेशंट डायलिसिसवर घेतो, इक्मोर घेतो, ब्रॉन्कोस्कोपी करतो, हायर अँटीबायोटिक देतो, सर्व एज्युकेशन, सगळा खर्च ऑफिशियली गव्हर्नमेंट ऑफ इंडियाच्या नियमानुसार हॉस्पिटल बिअर करतं. इवन ॲट द लास्ट मोमेंट पेशंटच्या नातेवाईकांनी कन्सेंट विड्रॉ केली तरी तो खर्च हॉस्पिटलच घेतं. सो देर इज नो मिथ अबाउट द मनी. There are no money is involved in our organ donation. We don't charge to any patient, and we means government of India rule is like that. Next, can I specify the organ? Okay, family is donating, they are doing the good work, so you cannot put the this thing. नाही नाही तुम्ही फक्त सगळेच द्यायला पाहिजे, आपण 8 ऑर्गन वाचवायला पाहिजे, 12 जणांना द्यायला पाहिजे. Family has a entire right to take a decision. फॅमिली काय स्पेसिफिक की नाही आम्हाला फक्त हार्टच द्यायचं आहे, नाही आम्हाला फक्त लिव्हरच द्यायचं आहे. मेजॉरिटी मोर दॅन 90% फॅमिलीज से आम्हाला सगळं दे गिव्ह कन्सेंट फॉर द ऑर्गन डोनेशन, देन यू कॅन रिट्रीव द एलिजिबल ऑर्गन. yesterday night at 11:30 I got the call from my hospital. There was a brain dead donor. The family said that we want only one organ we want to donate. I said speak with them, try to convince, but they said no, only one organ will donate. So then we said, which organ? They said, we only want to give a liver. At 4:30 early morning, we take him in OT, we retrieve the liver. Don't say no. Don't say no to the family. Give them the entire satisfaction of the donation. Somebody gives the 8 organ is a great man, and somebody gives the 1 organ is not something, nothing like that. Organ donation, whatever the फॅमिलीज आर डुईंग, फॅमिली ज्या काही वाईट परिस्थितीतून जाते ते जे काही डिसिजन देत आहे त्याला रिस्पेक्ट द्या, त्यांना फोर्स नका करू, त्यांना प्रत्येक गोष्टीला आम्ही यस म्हणतो. इवन OT टेबलवरनं पण पेशंट परत आणायचा अधिकार फॅमिलीला असतो. अँड वी हॅव डन इट इन अ पास इन रुबिऑल. फॅमिली टू कन्सेंट बॅक इज ओके, नो प्रॉब्लेम, काही फरक पडत नाही, एखाद दुसरं डोनेशन झालेलं नाही, पण it should not be the force on a family. So family has an entire right to take a decision about the organs to be donated. We can convince them. Religion, very sensitive matter in India, but believe me, I had a discussion with the Maulavi father and Sadhu, and we generally meet them. कुठल्या धर्मामध्ये लिहिलेलं नाही ऑर्गन डोनेशन करू नका, पण काही धर्म परवानगी देत नाहीत. बेस्ट वे काय माहिती का, त्यांच्या धार्मिक लीडरला भेटायचं आणि त्याला कन्व्हिन्स करायचं. म्हणजे जर तुम्ही त्यांना कन्व्हिन्स केलं ना तर, म्हणजे समजा एखादा ख्रिश्चन असेल ना, तो त्याच्या चर्चच्या फादरला विचारतो की डॉक्टर इज सेइंग दॅट की कॅन बी गो अहेड विथ द ऑर्गन डोनेशन, आणि इफ द फादर से यस प्लीज गो अहेड, दे विल गो अहेड. बिलीव्ह मी. सो वी हॅव चेंज द स्ट्रॅटेजी. वी स्टार्टेड लेकिंग द सच लेक्चर्स इन अ चर्च, मशीद, Mandir. If I convince even 10 Maulavis and the fathers and this thing, I can convert the 10 to 50,000 people into the organ donation. Nothing. This is one of the lecture I took it in a church on a Sunday, one of the Sunday, where there are the entire those people who are coming for the church, they will listen and they all take a oath that we are willing for the organ donation. Nothing. I'll never, this community will never in that area will say no to the organ donation. It takes some time out of you. So just see who are the key leaders and convince them. But no religion says no for the organ donation. Everybody says it is allowed in their commonest belief की फक्त श्रीमंत लोकांसाठीच हा सगळा ऑर्गन डोनेशनचा प्रकार चाललेला आहे. आन्सर इज व्हेरी क्लिअर. तुमची रेसिपेंट लिस्ट नोटो बनवतं सेंट्रल गव्हर्नमेंट, ऑनलाईन आहे, प्रत्येकाला ॲसेसेबल आहे, नंबर आहे, तुम्ही जाऊन बघू शकता तुमचा नंबर कुठे, तुमच्या नातेवाईकांचा, की बा तो काल 50 होता आज 40 झालाय आणि 10व्या नंबरला दिलेलं आहे का. यू कॅन व्हेरी वेल चॅलेंज. नोटो, गव्हर्नमेंट ऑफ इंडिया इज डुईंग द एक्सलंट जॉब. दे हॅव केप्ट द ट्रान्सपरंट लिस्ट ऑनलाईन ॲसेसेबल टू एव्हरीवन. कोणी चीफ मिनिस्टर कोणीही मर्यादे जम्प करू शकत नाही. मी असं नाही म्हणत की आपल्या चीफ मिनिस्टरला ऑर्गन डोनेशन लागावं, पण सांगतो. आणि विलासराव देशमुख चेन्नईला गेलेले होते, त्यांना महाराष्ट्रात का नाही मिळाला मग ऑर्गन डोनर, कारण ते लिस्टमध्ये नव्हते महाराष्ट्राच्या ह्याच्यामध्ये. सो देर आर सो मेनी थिंग्स, बट गव्हर्नमेंट ऑफ इंडिया इज एक्सलंट जॉब. ऑनलाईन लिस्ट, एनीबडी कॅन ॲक्सेस. सो आन्सर टू द क्वेश्चन इज नो, इट इज अवेलेबल फॉर. आणि मी तर म्हणतो सिम्पल आहे, गव्हर्नमेंट कॉलेजनी चालू करा ना ऑर्गन ट्रान्सप्लांटेशन. खर्च पण कमी होईल, हे सगळे अजून होतील. प्रायव्हेट हॉस्पिटल्समध्ये आता चालू आहे. जर जितके जास्त हॉस्पिटल ऑर्गन ट्रान्सप्लांट करेल तेवढा खर्च कमी होईल, तेवढा जास्त कॉमन मॅनचा आपल्यावर विश्वास बसेल. तर ते हळूहळू आता ऑलमोस्ट प्रत्येक हॉस्पिटल ट्रान्सप्लांट फॅसिलिटी डेव्हलप करत आहेत. व्हेरी कॉमन मिथ लास्ट 1 or 2 की समजा आम्ही ऑर्गन डोनेशन दिल्यानंतर बॉडीची डिस्फिगरमेंट होईल, मग आम्हाला पुढचे अंत्यविधी करता येणार नाही. बिलीव्ह मी, these all surgeries are done by the very skillful surgeon. You will not even find a bad suture mark or any wound. You can even, म्हणजे तुम्ही सर्व अंतविधीपासून सर्व गोष्टी करू शकता. आम्ही त्यांना सांगतो, समजा आय डोनेशन केलं ना, ते आर्टिफिशियल आय बसवतात, लक्षात पण येत नाही ह्याचं आय डोनेशन झालेलं आहे. आम्ही काही आर्मीच्या ह्याला लिंब डोनेट केले होते आमच्या इथल्या एका पेशंटनी, तर त्याला आर्टिफिशियल लिंब बसवलेले होते. म्हणजे लुक ॲट ना, जर समजा दोन्ही लिंब डेव्हलप केले, अप्पर लिंब डोनेट केले, तर फॅमिलीला किती प्रॉब्लेम येईल, कारण तो ट्रॉमॅटिक असतो ना नंतरचा. हे आर्टिफिशियल लिंब बसवले जातात इमिजिएटली. एव्हरीथिंग इज क्लीन, टायडी, की असं की जस्ट तुम्ही हॉस्पिटलमधनं दुर्दैवाने सर्जरी केल्यानंतर प्रॉब्लेम घरी आलेला आहे, एक्सपायर झालेला, असं क्लीन तुम्ही सर्व अंत्यविधी रेग्युलरली करू शकता. त्यामुळे तो मिथ इज ऑल्सो नाव गॉन. आता अलीकडे नवीन नवीन गोष्टी आलेल्या आहेत, जसं ड्रायव्हिंग लायसन आहे, किंवा गव्हर्नमेंट ऑफ इंडिया आता एक ड्राईव्ह रन करत आहे की टेक अ ओथ फॉर द ऑर्गन डोनेशन. आय हॅव ऑल्सो ऑनलाईन डन दॅट. All these are facilitating activities. They are not consent. They are not consent. If suppose such certificate is available or driving license, it will be never take it as a consent. Relatives has to give consent. फक्त फायदा काय असतो, मला नातेवाईकांना कन्व्हिन्स करायला सोपं जातं. कित्येक वेळेला नातेवाईक तयार नसतात, त्याला मी सांगतो, बघा तुमच्या नातेवाईकांनी जिवंत असताना ड्रायव्हिंग लायसन्सवर मेन्शन केलेलं त्याच्या भावनांना रिस्पेक्ट द्या, तर कन्व्हिन्स करायला सोपं जातं. सो ड्रायव्हिंग लायसन, ऑल दीज ऑनलाईन सर्टिफिकेशन्स आर द फॅसिलिटेटिंग ॲक्ट. सर्वांनी करायला पाहिजे, जेणेकरून ॲटलिस्ट त्यांना ऑर्गन डोनेशन हा वर्ड तर माहीत होईल, ऑर्गन डोनेशन हे नोबल ॲक्ट तर माहीत होईल. आणि दुर्दैवाने कधी अनफॉर्च्युनेटली इफ समबडी कम अक्रॉस, इट मे हेल्प्स टू कन्व्हिन्स द फॅमिली. अदरवाईज दीज आर नॉट कन्सेंट. डोंट गेट कन्फ्यूज विथ द युअर ड्रायव्हिंग लायसन्स अँड द ऑर्गन डोनेशन प्लेज. काही फॅमिली काय विचारतात माहिती का, की समजा रिबर्थ झाला आमचा मनुष्य, पुढच्या जन्मात परत मनुष्य झाला, आणि मग त्याला लिव्हरच नसेल, कारण तुम्ही तर लिव्हर रिट्रीव्ह केलेले. हे खरे तर मी काही बोलले. ते म्हणतात, मग आता माझा प्रश्न त्यांना असा असतो की पहिली गोष्ट, रिबर्थ असतो का मला माहीत नाही, पुनर्जन्म होतो का नाही हे मला माहीत नाही. आणि ज्यावेळेला आपण क्रिमेट करतो फ्युनरल, तर त्याची राखच होते ना, मग तिथं ऑर्गन असे तसे ते तुमचे जातातच ना, ते कसे रिबिल्ड होतात. तर ते खूप अवघड असतं असे. पण गिव्ह रिस्पेक्ट टू द फॅमिलीज. वी नेव्हर मेक अ फन ऑफ द फॅमिलीज. वी से की प्रश्न बरोबर आहे, पण माझ्याकडे असं उत्तर आहे की मी पुनर्जन्म माहीत नाही आहे, आणि झाला, आणि समजा तू डोनेट नाही केलं तर तू क्रिमेटच करणार आहे, मग तो ऑर्गन कसा त्यावेळेला असेल. अशा पद्धतीने तुम्ही त्यांना समजावून सांगू शकता. बट दिस इज फ्रिक्वेंटली आज क्वेश्चन. एक फॅमिली, एक यंग भाऊ बहीण होते, त्यांचे वडील IC ब्लीड विथ एनी होते. त्यांना मी सगळं सांगितलं की 2च मिनटं, ब्रेन डेड आहे, पेशंटचं ऑर्गन डोनेशन हे करा, सगळे अवयव चांगले आहेत, तुम्ही 8 लोकांचे वाचवाल, फक्त ब्रेन डेड झालेलं आहे. तर तो मुलगा म्हणतो की मग सर, मग ब्रेनच फक्त ट्रान्सप्लांट करा ना आमच्या वडिलांमध्ये. तर दिस इज व्हेरी ट्रिकी सिच्युएशन. तुम्ही प्रश्न एकदम हसू शकत नाही, तुम्ही त्यांना इन्सल्ट नाही करू शकत. त्याचं म्हणणं बरोबर होतं. तो म्हटलं ऑर्गन डोनेशननी जर 8 माझ्या वडिलांना तर फक्त ब्रेनच पाहिजे, बाकी तर सगळे अवयव नॉर्मल आहेत. मग त्यांना तुम्हाला समजावून सांगावं लागतं की बाबा प्रत्येक अवयव अवेलेबल नसतो, ब्रेन डेड नंतरच होतात, आणि नॉर्मल ब्रेन कोण देणार डोनेट करायला कोणाला. सो द बेस्ट वे इज अवेअरनेस, 360-degree awareness. Wherever the ways create awareness, discuss when you are in a party, discuss when you are in a good mood, discuss when you are in a group meetings. आज गरबा पण खेळणार आहात ना, तिथं पण मर्यादा डिस्कस करू शकता. तर दिस इज द बेस्ट वे टू अवेअर. वी हॅव टू क्रिएट अ अवेअरनेस. मी तुम्हाला 2023चा आकडा दाखवला, 0.007. म्हणजे आउट ऑफ 8.4 billion डेथ, out of 3.5 lakh brain dead patients, only 600 to 650 people gives donation to the consent for the organ donation. Thank you. Thank you very much.
Thank you, sir. The topic is now open for discussion.
Any questions?
हॅलो, आपल्याकडे ऑर्गन डोनेशनच्या आता सरांनी सांगितल्याप्रमाणे गव्हर्नमेंटची ड्राईव्ह चालू आहे. तर ऑर्गन डोनेशनची जी लिंक आहे ऑनलाईन इझी आहे, फक्त आपला आधार कार्ड नंबर आपल्या मोबाईल नंबरला लिंक असावा, तर आपण ते भरू शकतो. मी लिंक आपल्या ग्रुपवर शेअर करतो. जे कोणी आपले IM मेंबर्स इंटरेस्टेड असतील, मला वाटतं मॅक्सिमम रिस्पॉन्स मिळावा असं वाटते, तर ते एक लिंक मी आपल्या ग्रुपला शेअर करीन प्लीज. थँक्यू.
तुम्ही कॉन्फिडेंटली सांगा की भरा म्हणून, मिळावा कशाला म्हणताय? भरा ना सगळेजण, भरायला काय हरकत आहे, नका देऊ ना कन्सेंट, भरा तर सगळ्यांनी. येस सर.
On this good drive, but I have a question that cornea transplant, as far as my knowledge goes, is the one of the oldest one organ transplant, highest number and oldest one. Why is it that the other organ transplants are not so much in vogue?
अगदी बरोबर.
कारण पंढरपुरात पण कॉर्निया डोनेशन्स होतात. अचलारी सरांसारखे सिनियर प्रॅक्टिशनर.
मी तुम्हाला त्याचं कारण सांगतो. कॉर्निया ड्राईव्ह इज वन ऑफ द सक्सेसफुल ड्राईव्ह बिकॉज इट हॅपन्स आफ्टर द डेथ ऑल्सो. त्याला फॅमिलीज जनरली नाही म्हणत नाहीत. एक तर लेस टाईम कन्झ्युमिंग असतं, तुम्हाला कुठेही डिस्फिगरमेंट होत नाही, वेळ जात नाही. आपल्याकडे प्रॉब्लेम काय असतो माहिती का, मी डेथ डिक्लेअर केली ना की एक फोन गेला की अख्खं गाव घराच्या बाहेर येऊन बसलेलं असतं. दे डोंट गिव्ह यू द टाइम. ते काय म्हणतात, डॉक्टर तुम्हाला काय करायचं करा, 4 तासात करा, पण आम्हाला संध्याकाळी 6च्या आत जायचंय आणि आम्हाला सगळे अंत्यविधी करायचे आहेत. ऑर्गन डोनेशनला कमीत कमी 12 ते 24 तास लागतात सगळ्या मेंटेनन्सने बघायला. कॉर्नियाचं काय असतं, तुम्ही डिक्लेअर केला सकाळी 10 वाजता, तुम्ही ते बिलिंग आणि ही प्रोसेस कंप्लीट होतो, ती टीम येते, कॉर्निया घेऊन जाते आणि येतात. त्यामुळे कॉर्निया ड्राईव्ह इज वन ऑफ द मोस्ट सक्सेसफुल अँड द ॲग्रेसिव्ह ड्राईव्ह. कारण त्याच्या तो पेशंट एक्सपायर झाल्यावर पण घेऊ शकता. ही तर पेशंट ब्रेन डेड बट अदर ऑर्गन्स लाईव्ह असतात. आता जो सर्क्युलेटरी डेथ जो कन्सेप्ट आहे ना, की इव्हन हार्ट स्टॉप झाल्यानंतर पण करू शकतो, त्यानंतर कदाचित हा प्रकार थोडासा कमी होऊ शकतो, म्हणजे वाढू शकतो.
One more point, I think cornea transplant is technically not that difficult as all other organs are.
It is bedside na. Those guys come bedside, they retrieve the cornea and they leave the place. म्हणजे पेशंटचा वेळ जात नाही, काही खर्च नाहीये, त्याला काही मेजर कन्सेंटिंग असा काही इश्यू नाहीये. नंतर इमिजिएटली त्यांच्या वेळेमध्ये त्यांना बॉडी परत मिळते आणि दान केल्याचं समाधान पण मिळतं.
Because in my family, I had a personal experience of donating almost 8 to 9 corneas after death. But organ transplant becomes more technically difficult also.
That is technical. It takes some time and that
availability of institutions.
Lot of cost is involved. So लोकांमध्ये अजून खूप मी सांगितले ना, हे काही मिथ्स आहेत, असे 1000 मिथ्स आहेत, तर दरवेळेला क्लिअर करत बसायचे.
थँक्यू सो मच.
थँक्यू.
हॅलो
सर. यस, लास्ट रो.
Last question.
Good afternoon, sir. I just want to add one important thing. की सरांनी सांगितले की त्यांच्या फॅमिलीमध्ये त्यांनी 8 कॉर्निया ट्रान्सप्लांट केलेले आहेत. Whenever you are doing a corneal transplantation, please don't do only corneal transplantation. Do the whole eye transplantation. Organ donation. Because when you do only corneal organ donation, it will reduces the individual count also, and the corneal quality is also not at that good. Okay. Also, with cornea you can use the sclera also for scleral patch graft.
Okay.
सर असे बरेच पेशंट असतात. आता पेरिफेरीला जर तर पेशंट डेथ झाला समजा पेरिफेरी हॉस्पिटलमध्ये, त्यांनी ऑर्गन ट्रान्सप्लांटचं कन्सेंट दिली असेल, तर अशा वेळेस म्हणजे आता आपल्या इथं पेरिफेरियल तर ऑर्गन ट्रान्सप्लांटची टीम लगेच येऊन पोचून सगळ्या गोष्टी करत नाही. अशा वेळेस काय करायचं?
गव्हर्नमेंटने काय केलं, वेगवेगळ्या फॅसिलिटीज केल्यात. म्हणजे काही हॉस्पिटलला ओनली डिक्लेरेशन फॅसिलिटीज आहेत, काही हॉस्पिटलला रिट्रिव्हिंग फॅसिलिटीज आहेत, काही हॉस्पिटलला ट्रान्सप्लांट फॅसिलिटीज आहेत, काही हॉस्पिटलला तिन्ही आहेत. म्हणजे गव्हर्नमेंटची ती एजन्सी येऊन तुम्हाला सर्टिफाय करतात. आता डिक्लेअर करण्यासाठी काही मेजर एजन्सी नाही आहे. इफ यू आर फाइंड दॅट की क्लिनिकली इज ब्रेन डेड, बट तुमचं जर हॉस्पिटल रिट्रिव्हिंगला अप्रूव्ह नसेल किंवा ट्रान्सप्लांटला, तर यू हॅव टू शिफ्ट दॅट पेशंट टू दॅट हॉस्पिटल फॉर द रिट्रिव्हिंग. समजा तुमचं हॉस्पिटल रिट्रिव्हिंगला अप्रूव्ह आहे, तर बाहेरची टीम तुमच्या हॉस्पिटलमध्ये येऊन रिट्रीव्ह करून जाते, आणि तुमचं हॉस्पिटल ट्रान्सप्लांटला आहे तर बाहेरची टीम येऊन तुमच्या इथंच करते, किंवा तुम्ही स्वतःची टीम घेऊ शकता. तेव्हा आमच्याकडं रुबेलमधले पेशंट असतात, जवळपासच्या हॉस्पिटलमधले पेशंट असतात, काही बाहेरगावचे पण पेशंट येतात. म्हणजे वी टेक केअर ऑफ द एव्हरीथिंग, द ट्रान्सपोर्ट, फायनान्स, फॅसिलिटी ॲज वेल ॲज द एव्हरीथिंग.
Now I request Dr. Salunke sir to felicitate Dr. Jirpe sir. I request Dr. H.D. Dikshit sir to felicitate the chairpersons. Since we cannot take our organ to the afterlife, the best possible way to recycle them is donation. Be a hero and pass it on. Let's move to the next lecture. Next lecture is on diabetes mellitus and erectile dysfunction by Dr. Kapil Buraoke sir. I request Dr. S.B. Gaikwad sir, Dr. Suresh Katkar and Dr. Karan Vora to please come to on the stage to chair the session. Few words about Dr. Kapil Buraoke sir. He is GNB in medicine, IDCCM and FICCM. Presently, he is Director Critical Care and Senior Consultant in Department of Medicine, Sahyadri Super Speciality Hospital, Pune. He is Treasurer of National ISCCM, member of RSSGI, API and Endocrine Society. He is present Treasurer-elect for year 2023 to 2025, National ISCCM. He has got President Citation Award for year 2020-2021 National ISCCM. He has various publications and poster presentations in many conferences. He is faculty in various national and international conferences. He has contributed to critical care update and critical care clinics. He is the lead author in more than 10 chapters and in various critical care books. Thank you, sir. Sir, yeah. Please start the lecture.
Yeah, thank you very much for kind introduction. It's a pleasure. First of all, thank you M A Pandharpur for inviting and having you. Itself is so important that you will come across and will see in next 20 minutes why an intensivist is talking about erectile dysfunction or ED. As we all are aware, anybody who hears about ED, they will definitely have a hell of a time, and we are in a situation where ED is everywhere in Maharashtra. So definition of erectile dysfunction in diabetes is very simple. It is inability to achieve or maintain an erection for satisfactory sexual intercourse. Definition is very simple, but if you talk to patient, condition is horrible. So we have a situation where very simple definition, but very horrible situation. And why horrible, that I'll explain. If you come across the diabetics which comes to your clinic, this is considered to be very important factor and leading to one of the complications of diabetes. We talk about all other complications of diabetes to patients when we convey them why sugar control is important, but we forget about erectile dysfunction. Now it depends upon many factors. And when prevalence has been seen in these patients, particularly when this paper was published in year 2022, 2022 ला तेव्हा त्यांनी हा पेपर पब्लिश केला. So what he has seen, 20%, म्हणजे 19.4%. So 1 of every 10 or every 5 patients is having erectile dysfunction in diabetes. So 20% is a huge number for anybody who is walking to hospital. Now, which decides severity in ED? It's a type of diabetes, duration of diabetes, type of treatment, and associated comorbidities. कशामुळे इरेक्टाइल डिस्फंक्शन होऊ शकतं डायबिटीस मध्ये? द लिस्ट इज बिग, राइट फ्रॉम ऑटोनॉमिक न्यूरोपॅथी, पेरिफेरल न्यूरोपॅथी, हायपरटेन्शन, पेरिफेरल वॅस्क्युलर डिजीज, डिरेंज लिपिड प्रोफाइल, वेरियस ड्रग्स व्हॉट यू आर युझिंग, पेशंटला BPH असतंय, पेशंट डिप्रेस्ड असतात. इफ हायपोगोनॅडिझम इज देअर, आता सध्या प्रॉब्ली एक फॅशन आहे की 1200 रुपयात सगळ्या टेस्ट, 1500 रुपयात सगळ्या टेस्ट, त्याच्यात ते फिमेलचं पण करतात टेस्टोस्टेरॉन लेवल. सो आफ्टर दिस टेस्ट ओव्हर लास्ट 5 years पेशंट कम्स टू OPD आणि तो काय सांगतो, सर बाकी राहू द्या, ते टेस्टोस्टेरॉनचं बघा तेवढं. दॅट इज द लोएस्ट लेवल. So there probably last 3 years we have come across n number of patients of hypogonadism, and ultimately psychological factors are very, very important, but that is not my part to deal with now. So if you see diabetes and you see how it actually impacts to sexual dysfunction, right, by increasing oxidative stress, have venous occlusion, angiopathy, neuropathy, leading to androgen tissue loss and failure of signaling mechanisms. So the mechanisms are plenty where the diabetes is going to act on to. So in simplifying this, when you have risk factors lead to atherosclerosis. And atherosclerosis means aging process which is aggravated in diabetes. And we all are aware कि जेव्हा atherosclerosis होणार है, that is going to reduce arterial inflow, blood supply कमी झाला की हायपॉक्सिया होणार आहे, हायपॉक्सिया झाला की स्मूथ मसल डिस्फंक्शन होणार आहे, and that will lead to cavernous fibrosis, आणि एकदा फायब्रोसिस झालं की will lead to a veno-occlusive disease or erectile dysfunction. Now there is a repetition of previous slide, but this slide is important. काय important आहे? If you see the timeline through which this happens, पहिल्या सुरुवातीच्या टाइमला इट विल बी इन इनिशियल टाइम इट इज रिव्हर्सिबल, ओके, बट वन्स यू क्रॉस अ सर्टन लिमिट विच इज स्टिल नोबडी नोज वेन दॅट इज गोइंग टू हॅपन, इट इज बिकम इरिव्हर्सिबल. नाही, तुम्ही जर ED सिम्पटम्स बघितले तर अर्ली फेजमध्ये सिम्पटम्स आर व्हेरी मिनिमल, बट स्टिल दे आर इन अ रिव्हर्सिबल फेज, बट इन लेट फेज दे ऑलमोस्ट बिकम इरिव्हर्सिबल. Now if you look in a simplified way of pathophysiology, as I said की diabetes तर आहे, diabetes म्हणजे increased sugars, सगळ्यांना माहिती आहे, and insulin resistance. Along with that, जर if you have hyperlipidemia, hypertension, obesity and sedentary lifestyle, plus you have vasculopathy, you have neuropathy, you have hypogonadism, and if you have local factors, it is ultimately leading into decrease nitric oxide production and decrease vascular smooth muscles, decrease smooth muscle functions leading to erectile dysfunction. So with this slide we have to think की कुठल्या अशा कंडिशन आहेत ज्या रिव्हर्सिबल आहेत, where we can guide patients to make it reversible ED dysfunction. So to just summarize the risk factors, which are, some are in our control, some are not. Diabetes, age, dyslipidemia, hypertension, cardiovascular disease, obesity, metabolic syndrome, lack of exercise. So what we can control diabetes, we cannot control age, we can control lipids, we can control blood pressure, we have some control over cardiovascular disease, obesity definitely under our control, metabolic syndrome, exercise, smoking, low testosterone levels, in some or the other way are in our control. More you exercise, खूप papers आहेत, scientific papers. They have divided men who have exercised 30 minutes per day versus ज्यांनी काही exercise नाही केला or less than 30 minutes. And at the end of 6 months, testosterone levels केल्या. The difference between the two groups were twice. So those who are doing regular exercise, at least I think this will at least motivate you to have exercise every day, to have your better testosterone levels. To simplify, diabetes with comorbidities will lead to complications, and one direct complication is erectile dysfunction. And in this, one more important factor I have added is UTI. बऱ्याच diabetic patients say UTI. How seriously we take that UTI is a question mark. आता जे नवीन drugs आलेत, SGLT2 inhibitors, they increase sugars through urine, or your sugars will go down, but blood sugar केले तर normal, urine sugar केले 4+. So they have more chances of developing urinary tract infections. And in our country, the chances are huge. Even company claim karte ki there's less than 1% risk, but actually risk is bit more. Every UTI incidence is going to impact on your erectile function. So when you are treating UTI, you have to be very, very serious in that patient. So why this is important? Because as a clinician, probably we are like these people, learned illiterates we call them, or lack of awareness about this condition being so important in actual practice. And particularly lack of awareness of what? Only erectile dysfunction is mental satisfaction? No, the lack of awareness is mainly for link of erectile dysfunction to coronary artery disease. म्हणजे ज्या पेशंटला इरेक्टाइल डिस्फंक्शन आहे त्याचा कोरोनरी आर्टरीशी काहीतरी रिलेशन आहे याचा अवेअरनेस इज व्हेरी लो बिकॉज रिसेंट सर्वे डन बाय CMC Vellore and they have found that they have surveyed around 1,000 physicians. So in 1,000 practicing physicians who were practicing for more than 10 years, the awareness was less than 3%. That there is some link between erectile dysfunction and coronary arteries. Now how that link is there, we'll see in next slides. This first was published in year 2011 by this paper called by Charles. So त्यांनी काय paper publish केला होता की erectile dysfunction and coronary artery disease, particularly in younger men. So what he has found की ज्यांचा age group less than 45 आहे and त्यांना erectile dysfunction आहे diabetes मध्ये, they were at very high risk of developing coronary artery disease. Now what happens, we see, आपल्याला न्यूज मिळते 42 वर्षाचा माणूस सडनली गेला, रिच टू हॉस्पिटल, डिडंट सर्वाइव. ऑन कॉन्ट्री 70 वर्षाचा माणूस जातो, सर्वाइव होतो, 3 स्टेंट होतो. सो दे आर 2 डिफरंट coronary artery disease. But as a clinician, our priority to pick up coronary artery disease in this young population is very, very low. So there probably we have to link this erectile dysfunction to silent coronary artery disease, because he will never have that coronary symptoms till the time he will have a major impact on his health. So how it affects your coronary arteries? So in this chart you can see actually what it is doing. Hypertension hai, dyslipidemia, diabetes hai. It is leading to structural changes, leading to atherosclerosis and causing harm to arteries. So ultimately leading to reduced blood flow. So what they are saying, the same mechanism is happening to coronary arteries. And at an extent that we are not aware of this. So same pathophysiology, same risk factors, but less symptoms. And ED also, the symptoms may not be there till the time you talk to patient. So there is definite interplay between the coronary arteries and erectile dysfunction. And this was again a paper published in British Journal of Diabetes in 2016. So what they said, the summary of this was, erectile dysfunction precedes coronary artery disease by 2 to 5 years. मतलब मोठा टाइम आहे. एखादा coronary artery diseaseच्या आधी 2 ते 5 वर्षाचा आपण पिकअप करू शकलो, particularly age less than 60. Okay, so why this is? Because atherosclerotic complications of smaller arteries, such as those in cavernous areas, affect well before the larger arteries. So coronary impact व्हायच्या आधी आपल्या smaller artery affect होणारच आहेत. So what they are predicting, they are saying that ED should be considered an effective zero-cost predictor for cardiovascular disease, and further diagnostic investigations and aggressive risk-decreasing therapy should be planned in younger men, because we will be trying to save more lives. So they tithes nahi thamle. So probably when in 2011 they decided that it's a relation kaitari coronary artery disease hai, then they thought ki why this is happening. So what they have done in this paper, in the same paper, they have seen clinical presentation, artery size and lumen of artery. Again, same paper proved that threshold for symptoms is 50% reduction in the luminal artery. So they kai mantat. So when your cavernous arteries have a 50% reduced size, you can develop coronary artery disease. So well before the florid symptoms of ED actually appears. So they decided to look at the diabetic nephropathy also. So is there any link? Again, they found that 20 to 40% of the patients will have decreased or increased arterial resistance, therefore change in the glomerular filtration or hyperfiltration. And therefore erectile dysfunction, which is a very common problem in chronic kidney disease, can still have an impact on our outcome. So there is a strong correlation between albuminuria and ED. So now we are moving to a next group of patients who are long-standing diabetes with CKD and they develop erectile dysfunction. Again, the mechanism is different. Here they are acting through renin-angiotensin system. So what that signifies, the erectile dysfunction is happening with again a multiple mechanisms. Is there any relations with neuropathy? Definite relationships, because this will lead to advanced glycation products accumulation, leading to impaired axonal transport, leading to decreased nerve conduction, and if there is no nerve conduction, there will be decreased sensitivity of spinal spleen and ultimately leading to erectile dysfunction. So both peripheral and autonomic neuropathy is associated with erectile dysfunction. So ekada patient बराच वेळेस peripheral neuropathy develop नसते पण earlier autonomic neuropathy develop होते. So there you should think about erectile dysfunction before patient tells to you. So comorbidities, again there is a repetition. Why comorbidities are coming again and again? Because they are aggravating. 1 plus 1, 1 plus 1 is becoming 11, not 2. So that's why comorbidities. And one more comorbidity is obstructive sleep apnea. Manus ratri gortoy ka. If you ask a simple question, obstructive sleep apnea. Now how obstructive sleep apnea is connected to erectile dysfunction? Again through these various mechanisms. It is leading to hypertension, leading to more strokes, leading to insomnia, and when sleep is directly correlated to erectile dysfunction. So again, obstructive sleep apnea is also one important comorbidity which is associated with development of erectile dysfunction. So fine, there is no doubt that erectile dysfunction is important. So what we can do? Atta sadhya apan kai kartoy? So effects of present anti-diabetic drugs on male sexuality. There are various mechanisms. I am not interested into discussing what actually mechanisms are, but unknowingly you are helping patients. How? Metformin will help. So IRO is going up. That means it is helping erectile dysfunction to be better. So better erection. Pioglitazone. And this drug is going to come in a long way. See, pioglitazone वर खूप controversy होती. Weight gain, heart failure, द्यायचं नाही द्यायचं. But over last 2 years, role of pioglitazone in non-alcoholic fatty liver disease किंवा NASH is significant. And आता cases of NASH has significantly gone up. So this drug will come back because it has a beautiful effects on erectile functions in our patients. So it helps patients to get erectile functions back. Then come back to SGLT2 inhibitors. Again, there was a study done by measuring intracavernous pressures using this drug, and they demonstrated that empagliflozin improved erectile dysfunction in doses which are used for diabetes treatment. DPP-4 inhibitors like sitagliptin, vildagliptin, they also improve erectile dysfunction in diabetes. So बऱ्याच वेळेस काय होत असणार आहे की जेव्हा हे पेशंट येत आहेत आपल्याकडे undiagnosed, and then we start these drugs, unknowingly we are helping them to have a better erectile functions. But because of that, what is happening, we have to think in the mind. Unless we ask them, they will not tell symptoms. Because we are not modifying disease processes through these drugs. So we need to do something better than that. So how to solve the erection problems? If somebody commits and you diagnose, what are the options available? So options are lifestyle changes. If you have hormonal issues like low testosterone, replace. Then oral medications. This I am not dealing with. There are devices and implants. So first is lifestyle modification and glycemic control. 5% weight loss, if you can achieve, it has a significant impact on your erectile functions. Because by various mechanisms, BP improve होणार, lipids better होणार, blood sugar better होणार, atherosclerosis process slow down होणार. So it is ultimately going to help you. So weight loss is strongly recommended to these patients. Exercise again very strongly recommended in both type 1 and type 2 diabetes also. Then somebody may think, but what is the relation of HbA1c and erectile function? Patient सांगू शकतो माझा HbA1c 6.5 आहे, still I have a erectile dysfunction. How this is possible? So this is recent paper published in April 2022. This is published in May 2023. There is a contradictory results. They are not very sure now whether control in HbA1c is going to impact. But in nutshell, like with any other complications, ideally we should be targeting your HbA1c to the definite level. Now, what is the caveat of this paper? ह्या पेपरचा प्रॉब्लेम हा होता की त्यांनी फक्त HbA1c टार्गेट केलं होतं. ब्लड प्रेशर नाही, डिस्लिपिडेमिया नाही, वेट लॉस नाही, काहीच नाही. सो अशा प्रकारचे जेव्हा पेपर पब्लिश होतात एवढ्या चांगल्या जर्नल्समध्ये, तेव्हा जो मेसेज येतो तो सुद्धा आपल्याला तो पेपर फक्त त्याचं कन्क्लुजन वाचून उपयोग नाही आहे. सो त्याचा जो पेपरला जे काही पेशंट स्टडी ग्रुप होता तोच बायस्ड होता. सो प्रॉब्ली HbA1c हॅज अ इम्पॅक्ट ऑन दॅट. सो एक्सरसाइज फॉर डायबिटीज, व्हॉट इज मीन बाय एक्सरसाइज? 30 to 60 minutes brisk walk, meditation and yoga. तर अजून आपण अशा काहीतरी गोष्टी करतोय दॅट इज कॉजिंग इरेक्टाईल डिस्फंक्शन इन डायबिटीज, पर्टिक्युलरली बीटा ब्लॉकर्स. ऋतुपर्ण सर वॉज व्हेरी मच शुअर की टू हॅव अ लॉंगर लाईफ गिव्ह बीटा ब्लॉकर. बरं पेशंट मे टेल अस काय करायचं जगून एवढ्या लांब. सो प्रॉब्ली वेन वी यूज बीटा ब्लॉकर यू हॅव टू थिंक अबाउट सिलेक्टिव्ह बीटा ब्लॉकर्स. बीटा ब्लॉकर मध्ये सगळ्यांना बीटा ब्लॉकर देऊन काही उपयोग नाही. सो विच बीटा ब्लॉकर्स यू चूज दॅट ऑल्सो मॅटर्स. Statins same, diuretics, antidepressant, antipsychotics. So what options you left with ACE inhibitors and calcium channel blockers? So काय औषध द्यायला पाहिजे? What are the drugs that to be given? Sometimes patients comes to us and when he listens to us, we try to counsel. They say, sir ते सोडा, करायचं काय ते सांगा. So what is to be done? We have to use drugs, and drug is phosphodiesterase inhibitor. So out of this, for our liver, what are using is phosphodiesterase inhibitors. They are first line therapy for ED, and by various mechanisms like increasing cyclic GMP, leading to smooth muscle relaxation, leading to increased arterial blood flow, better constriction and better erection. So names are sildenafil, tadalafil and various fiddles. The problem with this drug is many. So if you look at this, ultimately it is leading to better penile erection. So your problems are getting sorted out. So where is the problem? The problem is 5 minutes. The problem is these drugs are being probably shown in a wrong way with its relation with coronary artery disease. So the various drugs like sildenafil, tadalafil, I'll just go. So most commonly used is sildenafil. So whenever we think about this drug, we always think about Shane Warne in Kausomi. So everybody thought, why Shane Warne died in Kausomi? Because people thought he were using phosphodiesterase inhibitors, and that had led to his death. But this is nutshell not true, because if you go through the side effects of phosphodiesterase inhibitors, main are facial flushing, headache, nasal decongestion, dizziness, dyspepsia, visual disturbances, blue hollow. That's why these slides are blue. So when you look blue, you will see that everything is blue around if there is too much of phosphodiesterase inhibitor is given to you. Then what are the contraindications? Important is recent cardiovascular event, nitrate, hypotension and anatomical deformities or predisposition to prolonged actions or erections. So I'll just try to touch upon the nitrates and use of phosphodiesterase inhibitor, which is very important. So if your patient on phosphodiesterase inhibitors develop chest pain, then you don't give nitrates if you are on a sildenafil for 1 day and on tadalafil for 48 hours. And recreational drugs, if patients are taking, there's a lot of drugs around now in and around Pune also. Then you should avoid nitrates, and you have to be very much aware that what are the other inhibitors patient is taking, particularly the incidence of retrovirus has significantly gone up, plus ketoconazole, erythromycin or alpha blockers. Particularly या patientला BPH पण असतं, ते alpha blocker पण घेत असतात. So when they are administered together, that can lead to hypotension. So why this slide is important, just look at the sildenafil and look at the duration of action. It's 4 hours. On contrary, if you look at the tadalafil, dose of action is 70.5 hours. So if you take one tablet, the injection lasts for at least, the action of drug is around for 1.5 day to 2 days. So long acting drug. So बऱ्याच लोकांना वाटतं long acting drug is better, but problem is if you give too long acting drug and this patient develops symptoms, they are at risk of developing coronary artery disease, then it can lead to probable issues. And one more point, all other drugs are affected by food except tadalafil, which is not affected by food. So when you talk about diabetes, you have hyperglycemia, insulin resistance, dyslipidemia, leading to heart failure. So people think that this drug is just giving erection and not helping patients. Because on one side I'm saying that erectile dysfunction is heart disease. And on one side I'm just talking about erectile dysfunction made better. But it is not true. The effects of phosphodiesterase inhibitors on all-cause mortality in type 2 diabetes, 25% reduction in the overall mortality, 55% reduction in major adverse event, 41% reduction in all-cause mortality. So they are come in guideline as a first-line therapy for male with erectile dysfunction or without erectile dysfunction. So this is very debatable issue. Low dose tadalafil for development of better muscle structure, for better remodeling of arteries, that is the coronary arteries. There may be a time in coming 2-3 years that this might be a first line drug to save more lives. I'll just skip this. So to just summarize, whenever you have erectile dysfunction, assess risk factors first, then look for any hormonal disorders, then always think of phosphodiesterase inhibitors in these patients. So take home message is, everybody wants to be on, but remember that recognition of erectile dysfunction in diabetic is not only thinking about his erections, but to reduce the risk of silent coronary artery disease and how we can save more life, because more than 75% patients of erectile dysfunction may have a coronary artery disease. So probably take home messages, we have to spend time with patient and you have to look at erectile dysfunction in an entirely different perspective. Thank you very much.
Thank you, sir. Topic is now open for discussion.
I think a lot of questions will come on lunchtime. They may not ask it here. So I have understood that.
I just want to ask, sir, in SGLT2 inhibitors, only empagliflozin is helpful or any DAPA? And
see, it is a class effect and not the drug effect. So all the drugs are helping, but the first was launched EMPA, that's why I have put EMPA, but okay, all the class will have the same effect.
Okay, thank you, sir.
But sir, gliflozins, dapagliflozins, these cause UTI also.
Yeah, see, why UTI happens using dapagliflozin, particularly because lack of hydration.
Yeah.
So there are two problems. If I have a patient whose LV function is not good, his renal function is not good, and then I'm telling him to restrict fluids, so there I'll be using lesser doses of dapagliflozin. But somebody who has normal renal function, normal cardiac functions, we have to tell them to drink plenty of water and have to have a better personal hygiene, because it is mostly causing surface infection like vaginitis and balanitis. So if you talk to them properly and train them, then need not discontinue them from the treatment. So actually incidence of UTI may be less if we talk to them appropriately, because they are wonder drugs, they are going to help significantly.
Thank you, Dr. Kapil, for wonderful session.
Sir,
now I would like to ask you.
Sir, my question is regarding diabetes. We all know the obesity one of the important factor for diabetes, particularly in our Indian or Asian settings. we have a normal BMI or a little obesity, but there is an issue of a visceral obesity. And there is a well evidence-backed research that shows when hepatic or the fat content of your liver or pancreas, if it is reduced, then there is a good chance to have a improvement in your glycemic control as well as insulin resistance. So in the West, what now they are doing, they are using a diet as an important tool to treat the patient of diabetes, or the patients who are having 15, 20 years of diabetes. They are completely reversed only with diets. So can we integrate such kind of tools in our clinical practice, or do we need more data to be a part of those tools as our standard practice? And my second question is that the use of pioglitazone. The pioglitazone long-term use is associated to have your urinary bladder cancer. So is it really safe to use pioglitazone for long-term?
If you I'll answer your second question first. Use of pioglitazone and development of cancer at a doses 45 milligram per day. So what we are trying to use the doses here, not more than 15 milligram per day. So definitely it is related to dose. Duration, again we can titrate, screen them appropriately, but I feel that is not the only factor where we can discard that drug. If you see the number of patients who are actually developing and the doses, if you can limit the doses, we can address this issue. Second question is, in our practice, or just he is trying to highlight the issue of something called diabetic reversal. So WHO has put a big question mark about this word diabetic reversal, because they say that this terminology needs a lot of understanding. First of all, how much time we give to our patient to counsel them about nutrition is a big question mark. Being a physician, whether I am a good nutritionist, answer is no. There should be involvement of a team in diabetes management. And I think over the years things will change. There will be people who will be definitely be given their own role to look into diabetes management. So definitely nutrition has a huge role to play, and we all are aware. We know when patient comes to us how it comes. So probably nutrition has a big role to play in diabetes management.
So we need to have
integrated approach for diabetes management. Those days will go in coming days. Wellness clinics, the way people are counseled. If you ask me, the percentage of people who want dietitian has significantly gone up. So previously kuni vicharala yaisa nahi dietitian kuni aaye ka. So probably now they ask, sir, what is the dietitian? So we tell them some printed chart and we tell them, hey kha. So probably that days have gone. We have to tell them according to weight, how much calories, how much protein, how much fat, how much to exercise. That is very, very important in diabetes management.
Right, sir. Because recently I was watching some videos on YouTube. So there is a Dr. Roy Taylor. He's one of the, who is doing the pioneer work on diabetes reversal in Newcastle University, UK. And he has published lots of papers. And in his practice, there are hundreds of patients on or who are reversed with their type 2 diabetes. So I think this is the untapped area where we need to look into. Thank you.
Yes,
thank you, sir.
But it is very difficult to counsel patients about their diet.
Thank you.
ते जिलेबी वगैरे खाऊन येतातच.
Hello, sir. I want to ask one question, because being a geriatrician, there are a lot of people coming to me having multiple comorbidities, and use of sildenafil is very restricted in that. So what is your opinion about local sprays like Lidoclin and Pyrrolicoin sprays which are coming in market nowadays? So what do you say about that?
I will probably, if you ask me as a clinician, I will prefer using phosphodiesterase inhibitors in even older patients. There is a very beautiful study done by a Canadian fellow who has given sildenafil and tadalafil to COVID patients and age group of more than 60. And what he has found that there was significant reduction in pulmonary artery pressures. So RVSP or right ventricular pulmonary pressures are significantly better. So that has not improved their erectile functions only, but their overall cardiac functions or 6-minute walk test has become better. So I feel phosphodiesterase inhibitors, we are more worried about side effect rather than their use. So at appropriate doses, if it is used, they have effects far beyond only erectile function improvement, because significant impact on pulmonary pressures. COVID people, a lot of people in even long COVID syndrome, there is an ongoing study. We are already doing that study on this molecule. More than 300 patients are enrolled, and we are seeing that serial echoes have significantly shown changes in right ventricular pulmonary pressures.
One more question, sir.
That was expected.
Very nicely you discussed about the erectile dysfunction in diabetic patient. What is the most common cause of erectile dysfunction overall?
I think psychogenic is more common. If you probably the first cause for any erectile dysfunction is performance pressure and psychogenic. So there are a lot of issues. Probably that's why I said probably I'm not the right person to deal with those kind of issues. We have Dr. Vinayak for that. So
very nicely delivered lecture. Erectile dysfunction is associated with coronary artery disease. It should be taken in consideration to prevent cardiac complications in younger diabetics. Now let us felicitate this our speaker. I would request Dr. S.B. Gaikwad sir to felicitate Dr. Kapil Buraoke sir.
फ्रंटला पाहिजे कारण काय झालं फुल हाईट आहे खाली काय
I request Dr. Bajrang Dhotre sir to felicitate the chairpersons. Dr. Dhotre sir, please come.
Moving towards the next session, our next lecture is by Dr. Sandeep Nemani on hematology for all. I request chairperson Dr. Sureka Borak Madam, Dr. Anand Binge and Dr. Suraj Tantak to come on stage to chair the session. Everyone knows our speaker Dr. Nemani sir. About him, he's completed his graduation from Government Medical College Mirrors and his postgraduate studies in internal medicine from Topiwala National Medical College and Nair Hospital, Mumbai. He did his DM in clinical hematology from prestigious Christian Medical College, Vellore, and he secured gold medal in MGR University, Tamil Nadu. He has been part of various publications and research work at CMC Vellore. His recent publication is on stem cells transplant in acute myeloid leukemia. It is published in Journal of Global Oncology. He is working as a consultant hematologist and stem cell transplant consultant at Sri Siddhivinayak Hospital, Mirrors. I request Dr. Nemani sir to start his session.
Good afternoon, and I thank organizers for giving me opportunity. मी सांगलीचा म्हणायचं की पंढरपूरचा म्हणायचं हेच मला कळत नाही ॲक्च्युली. I feel I am a local faculty only because I am providing services for last 6-7 years here. So taking it forward, and I am in between your lunch and the CME, so I will try to make it little interactive and I will try to, I want you to respond. And many of you might have heard me before speaking in various CMEs that we organize in this region. But this may be revision for them, and who are new, this may be the new topic for them. So with this, what I brought today is hematology for all. The reason for bringing hematology for all is, like, you are, all IMA members are from varied specialty. So hematology is this branch or the subject, like CBC we can call, is required for each and every branch. Without CBC, you can't operate the patient. Without CBC, you can't treat the patient. So CBC is the first primary investigation that all of us do when the patient comes to us. So with this, I start with the topic, and we will do a case-based discussion. So what I want is you interacting with me and you answering me what problems and what you think about this particular patients. So this is 52-year-old male referred for central retinal vein occlusion and thrombocytosis. So patient went to ophthalmologist for uniocular blindness. They found the patient has central retinal vein occlusion, and they got a CBC done and found that the platelet is high. So anybody wants to say what the CBC looks like? What abnormalities you can see in the CBC? Is the characteristic high platelet count, is the 16 lakhs. What is the other abnormality that you can see? Hemoglobin is low. So low hemoglobin, high platelet count. Once you know a patient has low hemoglobin, what is the next thing you see in the CBC? MCV you will see. So how much is the MCV? Is 56. So it is a microcytic anemia. When MCV is nothing but the size of RBC. If MCV is between 80 to 100, we call it as normocytic RBCs. When MCV is less than 80, we call it as microcytic RBCs. And when MCV is more than 100, we call it as macrocytic RBCs. So unless you don't classify the patients which type of anemia it is, whether it's a macro or normo, you can't give a differential diagnosis, what differential diagnosis the patient could be suffering from. So this is very important to classify them as depending upon the MCV. So this curve has shifted to left, suggestive of small RBCs. Peripheral smear examination is done. No CBC report is complete without doing a peripheral smear examination. So pathologist should see a CBC before you diagnose something on the CBC. So central pallor is increase in the RBC, suggestive of hypochromic cells, smaller cells, microcytic, and some elongated pencil cells with these small dots are nothing but the platelets. So hypochromic microcytic RBCs with thrombocytosis on peripheral smear. What is the commonest differential diagnosis in a patient with microcytic hypochromic anemia? Iron deficiency anemia. So we got an iron workup done. We found that iron is low, TIBC is elevated, transferrin saturation is low, and ferritin is low, suggestive of iron deficiency anemia. Now you have a patient with iron deficiency anemia. Is it the end diagnosis? What else you should do? You should search for the cause of iron deficiency anemia. So the cause of iron deficiency in a male, first foremost thing to do is stool occult blood testing when there is no obvious blood loss. Like if he's saying he's having hemorrhoids, then it's fine. But if there is no obvious blood loss, you should do a stool occult blood. It came positive. Then later on the patient was referred to gastroenterologist for endoscopies to search for the cause of GI bleeding. Now the second question is why this patient has high platelet count. So the platelet count is high because it is reactive thrombocytosis, and it is a very well-known fact since long time that iron deficiency anemia can have high platelet count. This is very extreme. 16 lakhs is quite extreme, but the patient can have platelet in the range of 5 lakhs, 6 lakhs, 7 lakhs in patients with iron deficiency anemia. And this is the reactive cause of thrombocytosis needs to be ruled out before you diagnose primary causes of thrombocytosis. And it is seen in around 30 to 60% patients with iron deficiency anemia. And usually once you start treatment for iron deficiency, the platelet count resolves to normal within a month's time. So this patient we started with iron therapy. Oral iron therapy was given because patient was very stable, well compensated iron deficiency anemia. Patient's HB has improved after 7 days to 6.2. You can see the new RBCs are coming up and the platelet has started dropping. And after 1 month of iron therapy, we found that the HB has nicely improved with platelet got normalized. Coming to next case, this is 22-year-old female, 2 months pregnant now, HB not improving with iron supplements. She was given multiple iron supplements in the past, but HB never improved. So can you tell what exactly you can see in the CBC? Low hemoglobin, right? 8.8. Then next thing to see is MCV. MCV is 68. So it's microcytic anemia. Then what else to do is the peripheral smear examination. Peripheral smear examination showed microcytic hypochromic RBCs with few target cells seen on the peripheral smear. Now what next to do? Commonest differential diagnosis for microcytic hypochromic anemia is iron deficiency. Though she is receiving iron therapy, we should do iron workup for the patient when there is microcytic hypochromic anemia. Iron studies were normal. Now you have a patient who is pregnant in her first trimester with non-iron deficient microcytic anemia. What is the other differential diagnosis? So we have to do HB electrophoresis. Why HB electrophoresis to be done? To rule out thalassemia minor. So the patient has HbA2 elevated, suggestive of beta thalassemia minor. Now you have a patient who is pregnant in her first trimester and patient is beta thalassemia minor. What is the next step to do? What is the next step? No, that is okay. Iron you will not give. But what else you to do? Now you have a patient with thalassemia minor in first trimester of pregnancy. Yes. So you have to check for the husband CBC. Husband CBC examination was done. Again, HB borderline, MCV low. Got iron studies done. Iron studies normal. HB electrophoresis done. Suggestive beta thalassemia minor. Now you have a couple who both are thalassemia minor in first trimester of pregnancy. What is the next step to do? Yes. So you have to do antenatal diagnosis. Antenatal diagnosis suggests a fetus suffering from beta thalassemia homozygous. That means beta thalassemia major. What is the next step to do? Refer the patient to gynecologist for MTP. So this is how we evaluate, like microcytic hypochromic anemia, non-iron deficient. This is how you should think, and you should prevent the birth of thalassemia major child in the couple if they are suffering from thalassemia minor. So especially you have a patient from a Gujarati community, Sindhi community, you should be more vigilant because the carrier frequency in that communities is in the range of 8 to 10%. And in our community, it is in the range around 3 to 5%. So you should always think about thalassemia minor status, and then you have to counsel the couple accordingly. Pre-marriage counseling is very important. That if two thalassemia minor individual, if they don't marry, that is the best thing to do. But if at all they marry, then you have to offer antenatal diagnosis to the couple. We have seen that the couple is having 2-3 children with thalassemia major. That should not happen in a civilized society where at least after birth of first thalassemia child, we should counsel the parents that before getting the second birth, you should do an antenatal diagnosis. Thalassemia major is the commonest single gene disorder. More than 10% of world's population with thalassemia major resides in our country. And still, more than 10,000 children are born each year with thalassemia major. And all of you know that thalassemia major requires monthly blood transfusion. So this is a big social burden, and we can easily prevent by proper looking at the CBC and doing a proper counseling. Now coming to this very fancy and very loved index by the learned people in the doctors, that it's the Metzger's index, and it has been taught in physiology, pathology as well. So what is Metzger's index? It is nothing but the MCV divided by the RBC count. And when this ratio comes less than 13, we can say that the patient can have thalassemia minor. And when the ratio of between MCV and RBC count is more than 13, we can say that it is a iron deficiency anemia. Some of the reports you will encounter at some pathologists write the Metzger's index also at the bottom to tell you whether it's an iron deficiency anemia or thalassemia minor. So what I did was, I did the Metzger's index application for 3 of our first patient. So first patient, you remember, the patient with iron deficiency with thrombocytosis. We got the MCV divided by the RBC count. The Metzger's index came more than 13. So yes, patient is suffering from iron deficiency anemia. Second is the wife who is pregnant with thalassemia minor, non-iron deficient. We applied the Metzger's index, but the value came more than 13. Actually, she was thalassemia minor, but the Metzger's index is showing that she is iron deficient. And the third is the husband of that female with MCV divided by the RBC count. Metzger's index is less than 13, suggesting that this husband is thalassemia minor. So what I want to show from this is Metzger's index application is good. It can give you a rough clue, but ultimately you have to rule out iron deficiency, and then you have to do the HB electrophoresis for confirmation that the patient is not having thalassemia minor. So only on Metzger's index you cannot classify the patients between iron deficiency and thalassemia minor. So this is the most important slide. You should classify the anemia depending upon the MCV, and once you classify, you have multiple differential diagnosis. For microcytic anemia, as we have discussed, iron deficiency, thalassemia are the commonest differentials. For macrocytic anemia, as all of us know, is the megaloblastic anemia, which is the commonest. And for normocytic anemia, there are a lot of diseases like bone marrow failures, anemia of chronic diseases. Patient may have rheumatoid arthritis and anemia, may have normocytic anemia, mild borderline anemia. That is anemia of chronic disease. So you have to see the clinical scenario in which the context the patient is developing anemia, and depending upon that you can do the workup of patients depending upon the size of the RBC. Next important thing to know is, if your patient has anemia, you have to know whether it's a production problem or whether it's a destruction problem. So can you tell me what is the commonest test, or what is the test you should do to know whether it's a production problem or destruction problem? Of course, bone marrow is a good test, but we cannot do a bone marrow test for all anemic patients. So what we can do in the blood? Yes? So reticulocyte count. So what is a reticulocyte? Reticulocytes are nothing but the new RBCs that are just thrown into the circulation from the bone marrow. So what happens is there are nucleated RBCs inside the bone marrow, and once they are thrown into the circulation from bone marrow, the nucleus is removed and only an empty bag containing hemoglobin is thrown into the circulation. So retics are the cell which are little larger and they still have ribosomal RNA in the cells. But the mature RBCs has only hemoglobin, no RNA. So what we do is we do supraorbital staining for the sample, and we find how many percentage of the cells which are new RBCs or the reticulocyte, and depending upon the percentage we can know whether the patient is having hypoproliferative anemia or whether the patient is having hemorrhage or hemolysis. So this differentiation can be done depending upon the reticulocyte value, and it is very important to stain that properly and get a good report of reticulocyte to differentiate between type of anemia. As I told you, iron deficiency anemia is not the end diagnosis. Always try to search for the cause. Always try to ask for menstrual history. Look for hematuria, look for menorrhagia, look for GI blood loss, look for hemorrhoids. So you have to always try to search for the causes of iron deficiency anemia, and then you will do the correct treatment of a patient with recurrent iron deficiency anemia. Coming to next case, this is 45-year-old male diagnosed as myelodysplastic syndrome outside. So patient was referred to me because pancytopenia was there. Somebody had done bone marrow that had shown that the patient is suffering from myelodysplastic syndrome, and the patient came to us for treatment. Anybody wants to say what the CBC is showing? HB is low, WBC looks normal, but there is left shift. Some blast cells are also seen, and platelet count is also low, 65,000. So there is definitely pancytopenia in this patient. What is the next thing to see is the MCV. Always, whenever there is low hemoglobin, look at the MCV. That is most important. So once you have seen the MCV, it is looking normocytic, little on the higher side. We got a peripheral smear examination done. Peripheral smear examination shows anisopoikilocytosis with little larger cells are also seen on the peripheral smear. Some target cells are also seen, and teardrop cells are also seen. So this curve got widened. That means there is anisopoikilocytosis. Means there is different sizes and shapes of the RBCs are there in the peripheral smear. So these cells are also seen on the peripheral smear. What are they? They are the neutrophils. And usually the neutrophils has 3 to 4 segments. And when the segments are more than 5, 6, we call it as hypersegmented neutrophil. And hypersegmented neutrophil is the characteristic finding of megaloblastic anemia. So megaloblastic anemia workup was done. Retic was low because it's an hypoproliferative anemia. LDH was very high in thousands. Sometimes we find that the patient is reported with a normal or low LDH, but we are suspecting megaloblastic anemia. That error is because the LDH value is so high, it is in thousands, that the machine cannot estimate that high LDH. So you have to talk with the pathologist that there is some error because clinically we are suspecting megaloblastic, but you have given a low or normal LDH. So that way LDH is very high. It is in thousands usually in megaloblastic anemia. And B12 level has come low and folate is normal. So it is a case of megaloblastic anemia. Treatment is B12 folate supplementation. Even for a patient, you can give a B12 folate trial. If that fails, then we can think of alternative diagnosis. So even therapeutic challenge of B12 and folic acid itself is good enough to screen the patient is megaloblastic anemia or not. Always look for treatable causes of dysplasia. So dysplasia is nothing but it's a precancerous changes that has happened inside the bone marrow, and that can happen with many things. Like suppose a patient of rheumatoid arthritis on methotrexate and develop pancytopenia. If you do a bone marrow, that marrow will show dysplasia. But we have to go in the history and see that the patient is suffering from having methotrexate toxicity. Likewise, a patient with HIV, HCV, HBsAg infection with cytopenia, if you do a marrow, the marrow may show dysplasia. So whether drug toxicities are there, alcohol abuse is there, B12 deficiency is there, all this can cause dysplasia inside the bone marrow. So always remember that before labeling somebody as precancerous or cancer, you should always have a differential diagnosis of treatable causes. So MDS should be a diagnosis of exclusion and not a diagnosis of choice. This is all very important. Because once you label a patient as MDS, then there is no possible cure for that patient and there is some palliative treatment that goes on. So essentially you should always rule out treatable causes of dysplasia inside the bone marrow causing cytopenia. Megaloblastic, as we have discussed, macrocytic, then hypersegmented neutrophils, LDH very high, indirect bilirubinemia can be there. There can be features of MDS in megaloblastic anemia, and bone marrow testing or B12 and folate levels can clinch the diagnosis of megaloblastic anemia. So with this brief discussion on anemia, what we will discuss is a little bit about thrombocytopenia. So this is 22-year-old female diagnosed with ITP since her childhood and referred for further management. Now this female never had any symptoms, but since her childhood she has low platelets. Whenever she checks the platelet comes low, but no menorrhagia, no skin spots, no gum bleeding, no symptoms. So this patient came to me because she wants to get married now. What about the pregnancy, childbirth, everything? A lot of questions were there with low platelets. But she told that I will not take steroid because many pediatricians, many doctors has given her steroid courses for increasing the platelet, but that has never helped her. So she came to us for evaluation. So what the CBC shows is isolated thrombocytopenia, platelet of 12,000. What is the next step to do? CBC showing low platelet. What is the next step? Yes. So peripheral smear examination. CBC is incomplete without peripheral smear examination. Always remember that. So peripheral smear examination was done. These small dots are nothing but the platelets, and it's not single platelet, it is sea of platelet. What has happened is the platelet has stick to each other, and we call it as platelet clumping. And this platelet clumping can cause, what machine does is, machine counts the cells when they come singly. Like one cell at a time, then the machine can count as a platelet. But if multiple cells or a clump of cell is coming in the machine cannot count the platelet. So what is happening here? Clumping of platelet is happening. So the machine is giving error and counting low platelets. So we call it as platelet clumping induced pseudothrombocytopenia. So what we did is we changed the anticoagulant. Now usually we do CBC in a purple top tube, which is EDTA tube, but here we use the citrate tube or the PTINR tube, or you can use a heparin tube also, and we found that the platelet has normalized to 2.2 lakhs. So it suggests that the patient is suffering from EDTA induced pseudothrombocytopenia and not actual thrombocytopenia. So we encounter this problem at many places, like at nursing homes, even in medical colleges. Patients are admitted with dengue fever, daily they are giving platelet for 10-15 days, but platelet is not improving. And then we diagnose that the patient is suffering from EDTA induced pseudothrombocytopenia. It is not actual thrombocytopenia. So this condition you should always keep in mind when the history and the lab findings are not correlating with you. So it's very well known fact again to cause EDTA induced pseudothrombocytopenia. So before going to actual thrombocytopenia, you should know what are the causes of pseudothrombocytopenia. So first, as we have discussed, is the EDTA induced pseudothrombocytopenia. Second is platelet satellitism. So what happens in platelet satellitism is the platelet sticks around the neutrophil. And what the machine again cannot count because it is sticking to the neutrophil, and there is a false low platelet. And third variety is the giant platelets. So giant platelet is what? The platelet size of the patient may be recovering from dengue fever, or maybe congenitally large platelets may be there on the smear. And what happens is this platelet size is as large as the RBC. So now the machine counts cells singly, and machine counts cells depending upon the size. If a smaller cell comes, it counts as platelet. If a larger cell comes, it counts as RBC. So now here the machine gets confused that whether to count this as a platelet or whether to count it as a RBC. So the machine gives a false value of low platelets, but actually the patient's platelet may be much higher than the machine value. So we call it a giant platelet induced pseudothrombocytopenia. Usually we have, suppose you have patients from eastern region, like from Bihar, Jharkhand, West Bengal, some railway workers or somebody, and they are pregnant, suppose they want a clearance for Caesar, and then they may have giant platelet. They have congenitally large platelet in some of them. So you have to know this entity that giant platelet can cause pseudothrombocytopenia. Coming to next case, 9-year-old male child with thrombocytopenia with bleeding manifestation, true thrombocytopenia, isolated low platelet count, steroid treatment was given, no response to treatment, treated as ITP, referred to us for further evaluation. We got the bone marrow aspirate and biopsy done. What I want to show is there is absence of a cell called as megakaryocyte inside the bone marrow, which is producing the platelet, and it is a megakaryocytic thrombocytopenia. 99% of times in pediatric age group, the patient may be suffering from ITP or with isolated thrombocytopenia with no organomegaly, but some patients can have alternative diagnosis, so we have to evaluate them properly. So when somebody asks me, or some doctors call me and tell me that, sir, we have a patient of thrombocytopenia, what to do? So first question I ask him, what is his hemoglobin and what is his WBC count? Why I ask this question is, I want to know whether the patient has pancytopenia or whether the patient has only true isolated thrombocytopenia. So he says, yes sir, hemoglobin is normal, WBC count is normal, everything is normal, only the platelet is low. Then next question I ask him whether it is a true thrombocytopenia or a false thrombocytopenia. Then I told you all the things which can cause false thrombocytopenia. Then he says, yes sir, we have seen, smear has been seen, there is true thrombocytopenia, patient has bleeding manifestation also. And then the third question comes in my mind is whether it's an immune thrombocytopenia or whether it's a non-immune thrombocytopenia. So isolated thrombocytopenia which is true can be of immune etiology or non-immune etiology. To confirm the patient is suffering from ITP or immune thrombocytopenia, there is no test. So what we have to do is, we have to do the test, battery of tests to rule out non-immune thrombocytopenia. Some of you may send the patient and I do a full workup for the patient. I also know that the patient is suffering from ITP. But why that workup is done? Just to rule out non-immune causes of thrombocytopenia. So we do HIV, HbCG, HCV because they can cause thrombocytopenia. We do an ultrasound abdomen to see whether there is hypersplenism, chronic liver disease causing thrombocytopenia. We do liver function test, kidney function test. This all is done to rule out other causes of thrombocytopenia. And once nothing is found and even bone marrow is normal, then we label the patient is suffering from immune thrombocytopenia, where there is no cause or the antibody mediated platelet destruction is happening. Dengue fever, all of you know, initially when I started practice 5-6 years back, people used to transfuse platelet at 50,000, 60,000 in dengue fever. Now everybody is, I think, aware that we don't need that much of platelet support to the patient to be given. 20,000 platelet is very good cutoff. Even at a tertiary care center, 10,000 also you can wait. So up to 10,000 platelet, no need to transfuse when the patient is very stable, not bleeding, vital functions are normal. So above 20,000 is very safe. Above 10,000, if you are in a tertiary care center where the blood bank is easily available, you can wait. But below 10,000, you have to give prophylactic platelet transfusion. But above 20,000, with no bleeding manifestation, no need for any platelet transfusion. Coming to next section is the bleeding. So this is 35-year-old female admitted with multiple hematomas. So she had multiple skin hematomas everywhere, on the skin, thighs, everywhere there were big hematomas were there. History of IC bleed in childhood. That is one point she had. Then she had 7 surgical procedures done in past with multiple RBC transfusions. So surgical procedures were done for hematoma evacuation, other surgeries were done. Even the hysterectomy was done because of menorrhagia, but with multiple blood transfusion because she was having repeated bleeding manifestation after surgery. She had 4 early abortions as well, first trimester abortion, and hysterectomy was also done because of menorrhagia. So with this profile, this patient was suspected to have bleeding disorder. So for bleeding disorder evaluation, what we do is we do a CBC, we do platelet count, we do PT, APTT and bleeding time. This is totally a different topic to discuss about the bleeding disorders, but what I want to show is sometimes this test may come normal and history is saying that the patient is suffering from bleeding disorder. So here we have to think something different, and this patient was suffering from factor 13 deficiency. Like you know, coagulation factors are from 1 to 13, and this patient had factor 13 deficiency because factor 13 deficiency is not picked up by any of the screening tests. And early abortions, IC bleed, these are typical histories in case of factor 13 deficiency. Always remember this slide, when you do patient screen for hemostatic disorder, either pre-operatively or if you screen the patient for bleeding workup, you should know this. Like if platelet is low, BT will be prolonged. Never do a bleeding time in a patient with thrombocytopenia. Platelet less than 50,000, no point in doing bleeding time because it has to come prolonged. So thrombocytopenia. If bleeding time is isolated, prolonged with PT, APTT and platelet count normal, we call it as platelet dysfunction. If BT is prolonged, with APTT is prolonged, then and platelet and PT is normal, it is mostly von Willebrand disease. When isolated APTT is prolonged, it is usually intrinsic pathway defect. I am not going into the details of the pathways because I told you it's a different topic. And when the PT is isolated prolonged, it is extrinsic pathway defect of the coagulation. And when PT, APTT both are prolonged, then it's a common pathway defect or the fibrinogen defect. And when everything is normal, still you are suspecting a bleeding disorder, then always think that the patient may be having factor 13 deficiency. Coming to next case, this is 4-year-old male with hepatosplenomegaly and pancytopenia. Now patient had hepatosplenomegaly, pancytopenia. Some treatment was given for fever on and off for 2 months and details were not available. Whenever the patient gets treatment for something for PO of unknown origin and the patient gets treatment, we suspect that the patient sometimes might have got some hydrocortisone or some steroid, some dexamethasone for the fever. But still, we see what happens. So pancytopenia was still there, organomegaly was still there, patient came to us. We found some atypical cells on the peripheral smear, but not very convincing. We got a bone marrow aspirate and biopsy done, that again showed some few atypical cells, but not very sure what exactly is happening in that patient. We suspected that some viral insult might have happened and the patient is recovering. We labeled that some regenerating bone marrow or something. We also don't know what exactly is happening in this child. But the patient was apparently stable. Cytopenia is not very severe. Platelet is in the range of 30-40,000. WBC in the range of 3,000. Hemoglobin 7-8. So very stable hepatosplenomegaly child. We kept a close follow-up on the patient. Just we told the parents to bring the child every 15 days. Just we'll evaluate how things are going on. And after 3 months when the patient came to us, we found the WBC count has increased to 1.5 lakhs. And the peripheral smear is fully studied with blast. So what I want to show is this patient was suffering from acute lymphoblastic leukemia. Always remember that the hematolymphoid malignancies are very steroid sensitive malignancies. You take lymphoma, you take myeloma, you take ALL, all malignancies are steroid sensitive and all have steroid as a major backbone in the treatment. So always remember, undiagnosed cytopenia patients, undiagnosed lymphadenopathy patients, undiagnosed hepatosplenomegaly patients, don't give steroids unless you know what the patient is suffering from. You can try B12, folate, blood transfusion, everything you can give, but never use steroid in an undiagnosed patient. Coming to next section, this is 24-year-old male, constitutional symptoms, detected to have abdominal lymphadenopathy. Biopsy was done, suggestive of non-Hodgkin's lymphoma. 3 cycles of CHOP chemotherapy was given. This is a little time back where the scheme was not providing rituximab therapy. So only CHOP chemotherapy was given, patient was not affording. On histopathological diagnosis alone it was given. Patient had progressive disease, so patient was referred to us. We got the slide blocks of the previous biopsy and we found that it's looking like NHL, non-Hodgkin's lymphoma only. The purpose of showing this case is not about non-Hodgkin's lymphoma. Purpose of showing is why the complete diagnosis and complete workup is very important. This histopathology is showing like round cell tumor, probably lymphoma. We got IHC done on the tissue. We found that there are markers which are positive, which are of not lymphoma, but they are of the metastatic seminoma. So actually the patient was suffering from seminoma, but was falsely labeled and treated for 3 months as non-Hodgkin's lymphoma. So the precious time has lost. What you have saved 10,000 rupees of IHC and the patient had a wrong diagnosis and wrong treatment. So what I want to show from this is always get the complete evaluation and diagnosis done before we treat the patient, because half-hearted workup, half-hearted diagnosis, this scheme business, this all is very troublesome sometimes, that the patient can land up in such problems and they can even die of the disease because the disease has progressed and the valuable time has been lost. Coming to last case, this is 40-year-old male, doctor from our region, sensory motor neuropathy. M band was positive when the neuropathy evaluation was done. So patient was referred by neurologist to us. We evaluated the patient for multiple myeloma. We evaluated by called as CRAB acronym. CRAB is nothing but hypercalcemia, renal failure, anemia and bone lesions. That was not there. Bone marrow was normal. So now at this point we are in confusion whether to call this patient as MGUS, that is monoclonal gammopathy of unknown significance, that means not requiring any treatment, or the patient is suffering from multiple myeloma. So recently we have a PET CT scan that has been available in Miraj. So we got a PET CT scan and patient was doctor. So we want to fully rule out everything. We got a PET scan done and we found only a single lesion in the ileum which is 4 by 5 centimeter. Rest all the skeleton was normal. And we got the biopsy done of that lesion and it came out to be plasmacytoma. We had given chemotherapy to the patient and we have done autologous transplant, and last 4 or 5 years the patient is doing well now. What this case shows is, in a routine case scenario, even I would have not done the PET scan. I would have just labeled the patient as MGUS. I would have told the neurologist to treat the neuropathy. I would have told that this patient is not having multiple myeloma. But because we have the ancillary test or the new diagnostic modalities now available, we can very well evaluate the PEO patients nicely, the malignancy patients nicely, and we can diagnose the patient early before they develop florid symptoms of that particular disease. And this is the patient's first PET scan. At diagnosis, only one single PET avid lesion, and this is after treatment. So it has totally disappeared. Because he was diagnosed early, the multiple myeloma got cured in the doctor. We have started bone marrow transplant in Miraj. I always show this slide because I always feel pride that in our region we are doing bone marrow transplant, which is usually done in the metro cities in Pune and Mumbai. So from January 2017, because of the COVID setback, we had little less cases, but we have done around 30 transplants. 3 autologous, means self stem cells were used, and 20 allogenic for various conditions we have done. One recently we have done haplo or 50% matched donor transplant was also done. We have a death of around 20%, that means 4 patients expired out of 30 within first 100 days of transplant. We call it as transplant related mortality. And this is the haplo transplant that we have done initially, and this is our first transplant patient that still is coming for OPD follow-up from January 2017. Thank you very much. If you have any questions, I will be happy to take.
Thank you, sir. Now the topic is open for the discussion. If any queries.
Hello, sir. Sir, I want to ask one question. Suppose if a patient comes to us with the symptoms of anemia, we evaluate him, we get the CBC done and we find pancytopenia in this patient. we look for the MCV, it shows macrocytosis. We look for the causes of macrocytosis, we get vitamin B12 deficiency. Then we treat the patient with vitamin B12 injections and the treatment, and look for the cause of vitamin B12 deficiency in these patients, and treat the common causes that are there, like we deworm the patients and look for tuberculosis and all. So my question is, when to follow up these patients in the future, because the patient might have like intrinsic factor deficiencies, there is a problem with the absorption of B12. In the settings of periphery, how to follow up these patients, when to get the investigation done?
First question I will ask you, how many of you think that megaloblastic anemia is a disease of vegetarian people and not of non-vegetarian people?
So it's not so.
So I have seen more non-vegetarian people suffering from megaloblastic anemia than the Jains and the non-vegetarian people, right?
Yes.
All Jain people don't develop megaloblastic anemia. Okay, so there is no problem in the B12. The B12 is a vitamin which is very well conserved inside the body. So the recommended daily allowance for B12 is 1 microgram. 1 microgram you can get from sprouts, from milk products, anywhere. So this 1 microgram, even that is well conserved by the body by a mechanism called as enterohepatic circulation. So whatever B12 has gone into the intestines from the bile, that is again reabsorbed from the ileum. It is called as enterohepatic circulation. And this is well conserved vitamin. Body never loses B12 from anywhere, not from skin, not from urine, not from stool. Everywhere it tried to conserve the B12. So unless there is a absorption defect, the megaloblastic anemia doesn't happen. So it may be either ileocecal tuberculosis which is causing megaloblastic anemia. It could be pernicious anemia with intrinsic factor or parietal cell antibodies positive which is causing megaloblastic anemia. So the dictum is, what we do in our practice is we always treat, once the patient has developed megaloblastic anemia, we treat the patient with B12 parenterally lifelong. You understood? Just leave it, no? So see, initially we give suppose 2 injections per week, then once in a week, then once in a month, and after 6 months, you can just tell the patient, take B12 injection every 3 monthly for lifelong. This problem will never recur in your life, whatever may be the etiology. So parenteral B12 supplementation in a patient with the patient may have subclinical B12 deficiency. That can cause neurological damage as well. So why to take a chance of a B12 injection which is quite cheap and to take 1 injection every 3 monthly? Once you have given 1 B12 injection, that can last inside the body for 3 months. So that is the reason, like we treat all megaloblastic anemia for life with B12 injections for lifelong. Usually.
So another question is, how do we treat the anemia of chronic disease apart from treating the disease?
So anemia of chronic disease, first important thing is, anemia of chronic disease, usually the hemoglobin doesn't go below 8. Always remember that. Once you have seen a patient with some chronic inflammation and hemoglobin is suppose 4, it is not anemia of chronic disease. Take it from me. It may be something else with anemia of chronic disease. The patient may have iron deficiency with anemia of chronic disease. You understood? So HB usually stays around 8 in anemia of chronic disease. In that situation, when the B12, folate and iron deficiency is ruled out, just treat the underlying cause. No need for a separate treatment for anemia. If in case you require some erythropoietin injection, something you can try, but actually primary treatment of primary problem itself is sufficient.
Thank you, sir.
Hello, sir. I want to ask one question regarding one patient. A 32-year male came to me on 30th September with breathlessness and diagnosed to be having acute pulmonary embolism. 1 month back, he had DVT. And he has been treated in some tertiary care and he was started on acetrom. But for 15 days he had taken the acetrom and now then he stopped. So I thrombolized him with STK and put him on heparin infusion for 48 hours. And after that I started him on dabigatran 150 mg BD. But again after 15 days, means on 15 October, he came with the same complaints. And again I have done CTP and again there is a massive pulmonary embolism. Only the thing is he missed only 1 dose, that is prior night dose of dabigatran. And again, because we can't use STK again within 15 days, I have thrombolized him with the tenecteplase. Patient is now stable. But my question is, what could be the cause for this and what is the next workup that we can do?
So, when you have a newer anticoagulant that is not working, either dabigatran, rivaroxaban or apixaban, you should always try to rule out APLA syndrome. Because APLA syndrome is the only condition where the newer anticoagulants are contraindicated. So in APLA syndrome, you should do workup for APLA anticardiolipin antibodies and glycoprotein antibodies, lupus anticoagulant, everything. ANA also you get it done. So once you have ruled out that, suppose APLA comes negative, if APLA is positive, treat with heparin acetrom, the conventional treatment you have to do. But suppose APLA is ruled out, then in this patient don't use novel agents. Try to use the conventional acetylrome and try to target the INR between 2 and 3 correctly. That is the only thing that you can do in this case, if he has failed with the NOAC.
Okay, sir.
Thank you, sir, for this wonderful academic feast and discussion. Now I call upon Dr. Sheetal Shah, sir, to felicitate Dr. Nemani. Moving towards next session by Dr. Kapil Borauke on approach to rapidly deteriorating patients. Now I request Dr. Dodke, Dr. Sudke and Dr. Saurabh Thadwe to chair the session. Now the topic by Dr. Kapil Borauke is approach to rapidly deteriorating patients in ICU.
हेच होतं ना हे कुठं होतं लावायचं yes
From Pune, diabetes and erectile dysfunction. Now I request Dr. Kapil to start his presentation.
PPT. Good afternoon and thank you very much for one more opportunity. As been commonly intensivist is called at an abnormal time. So we have a slight change in the schedule. For next 15 minutes I'll be just talking about approach to critically ill patient in any setup. Let it be ortho, gynec, ENT or irrespective of any specialty, what should be the approach to rapidly deteriorating patient. So what is the objective of this talk? Just to introduce what is this concept is. Second is to recognize life-threatening events as early as possible. There is some difference in approach and what is meant by A, B, C, D, E. So what is more important is critical illness is a life-threatening process. And why this happens probably is a failure of detection of altered physiology and establishment of that physiology. If it is not done appropriately, that ultimately leads to unplanned admissions to intensive care, multi-organ failure and unnecessary deaths. So as an intensivist or as a clinician, what is our job is to correct physiology to the best possible tune. Now simple appropriate measures sometimes if you do at appropriate time will reduce your ICU admission to the tune of 50%. For example, early administration of antibiotics to patient who is sick with infections. Okay, so if you have antibiotics given within 1 hour, probably you may not require ICU also. So what is important as a clinician of any specialty is to recognize them early. So this is very, very important. So these are top 5 signs or physiological deteriorations which actually help us pick up patients fast. One is partial airway obstruction. Second is poor peripheral circulation. If you are lucky to have ABG, then drop in pH to less than 7.2, and particularly surgical patients where drain fluid loss is more than expected. These are very, very important signs. I have experience of working with surgeons, and probably as a clinician, even though these numbers are there, what matters that how patient looks clinically, that matters a lot. If a clinician feels this patient is deteriorating for various reasons, probably that is the correct time to intervene. Second important, the late signs are its impact on sensorium, that is unresponsive to voice, and drop in urine output. So if you look which are the important parameters which are going to help us to identify sick patients are early, they all depend on our will to understand them or pick up them early. So there is something called early warning signs or something called mu scoring. So what happens, the Western world, they work less than us. So what work we do, 1/10 of that they do. So this scoring system was done by somebody sitting in Australia. So what he has developed something called modified early warning signs, and he has put a name as mu scoring system. And what is included in this scoring system is systolic blood pressure, heart rate, respiratory rate, temperature, and sensorium, that whether patient is alert, responding to voice, or stuporous or unresponsive. So everything is given marks. So you can have these kind of charts in your ward and train ward doctors to pick up these things early, so that if your mu score has more than 5, probably you are dealing with slightly sicker patient. So what is the difference in approach? Traditionally, when I was going through my MBBS days, what is being taught to us? Take history, do examination, do differential diagnosis, look for diagnosis, and then give treatment. But in real world, in critically ill patient, this doesn't work because we don't have time. So what modification we need to do in our approach is something called ABCDE approach. First, we have to secure or make that patient stabilization of that patient, which is the first step. So airway and oxygenation is very, very important. Second is breathing and circulation. Third is disability, and fourth is exposure. So what happens as a critical care clinician or any clinician where patient gets bad, you have to think about this ABCDE approach. Unless we have this approach, we will not have a time to rescue our patient. So for this, what is the safest approach? Use something called primary survey by ABCD approach, and secondary survey you can go through our traditional thought process, what is being taught. So usually in ABCD assessment you have to look for immediate life-threatening conditions and where rapid intervention is required, like giving oxygen, giving IV fluids, fluid challenge, and specific treatment. It doesn't take more than 5 minutes. And it can be repeated as many times as possible. And more you work, you will try to understand. So if you look at any deteriorated patient in ward or in casualty patient comes to you, what relatives are watching? Relatives are watching the same thing, how fast my doctor started treating my patient. So relative काय म्हणतो, patientला saline लावलं नाही, oxygen दिलं नाही. See, he is not talking out of his sense. Actually he is talking sense, because this is what is required for any patients coming to hospital. So it is very important to secure IV line and give oxygen. So what happens, first survey will allow you to decide whether you need to go to a secondary survey or whether this condition is beyond my control and call for help. This is very, very important. In secondary survey is done when patient is relatively stable. Then you talk to patient, get detailed history, ask for some examination, order investigations, and then you can probably go through the definitive treatment. We will have one case scenario. This is 66-year-old gentleman who has come to casualty, was not well for 2-3 days, had a vomiting, not passed much of a urine last few hours, also complaints of breathlessness. Patient also had a chest pain, and he says that's very sharp pain, stabbing nature, which is worse on inspiration and cough. So on observation, he was having blood pressure of 83/52, respiratory rate of 24, and saturation of 96. but his mu score is 3. So whether this patient is critically ill or not, what do you feel? This patient is critically ill or not? So that scoring system, if even though it is less than 5, don't be under impression that scoring system is going to help you. The clinical scenario warrants this patient needs to be in ICU because this patient is critically ill. So we have done a primary survey, airway was fine, patient was talking, patient had abnormal respiration, patient saturation improved on giving oxygen, his heart rate was regular, blood pressure was 83, and no urine output, and he was very cold. He was alert, GCS was good, and small amounts of catheter was put, so small amount of pus came through the urine. So probably we were dealing with UTI. So what was our plan? Plan was give oxygen by mask because he had a desaturation. Plan was to give IV fluids because blood pressure was low. Decided to have strict fluid balance because there was no urine output. So decided to do urine output monitoring hourly. We thought to involve some renal team for review, and we thought of something called VIP approach. So what is meant by VIP approach? Is ventilate, infuse and pump. Ventilate is oxygen administration or ventilation by securing airway. Infusion is fluid challenge. In any emergency situation when you are in doubt, give crystalloid, normal saline 30 ml per kg. And pump is vasoactive agent, where if you want that blood pressure is not improving, you want some definitive agent for that pump to improve. So VIP approach to everybody. So there are various causes. So initial assessment, either he can be unresponsive, responsive to added with added sounds, or accessory muscle respiration is there, or either any snoring, grunting. So these clinical features will help you for assessment of airways, whether your airway is patent or not. Then you can have some definitive measures to improve the airway like head tilt, jaw thrust, suction. So when we were going through medicine days, we thought this is not for us, this is for anesthesia, and this is not for us. But I think over the time, there is a lot of overlap between the specialties now. Every clinician should be aware of these maneuvers irrespective of the specialties. So airway interventions, always think of getting help. If you are in doubt, you have to use something called LMA, that is called laryngeal mask airways, and every hospital and every ward should have a laryngeal mask airways, because in a situation if you are not able to ventilate and intubate patient, till the time you do transport of this patient, LMA, if taught appropriately with minimal training, actually can save lives. There are n number of occasions in our hospital in Sayadri where in ward, if RMOs are not able to intubate, or if they are not trained, we have been strictly told them don't rush for intubation, either bag mask, or if you don't do bag mask or not able to do, then use LMA and get patient down to ICU. So training of LMA use is also very important. Once airway is open, you have to give oxygen to all, provided your patient is not a COPD patient. There are few patients where your oxygen actually can make things worse. COPD patient casualty deto, saturation 90 asto, oxygen deto, patient conscious asto, half an hour down, patient drowsy. What happens by giving too much of oxygen? His carbon dioxide will build significantly and he will have CO2 narcosis. So when you are giving oxygen, remember COPD आहे का तेवढा एकदा बघायला पाहिजे. The breathing causes I will not go into. So breathing assessment, look, listen and feel. If you go to the previous AHA guidelines, their breathing was first. So a traditional approach, look, listen and feel. Then look at the circulation. This is very important as a clinician. Signs of inadequate tissue perfusion. Whatever we are doing in ICU, हे सगळं का चाललंय तर we are facing difficulty in giving appropriate blood and oxygen to the tissues. So either due to loss of volume, or due to pump failure, or due to vasodilatation by sepsis, anaphylaxis, or some neurogenic causes. So you have to identify what is actually reason for this deterioration. So there are various ways through which we can probably differentiate between various causes of shock. But what can be done at the bedside? Look at the skin color. examine peripheries, look at the pulse and look at the urine output. If your patient is cold, बऱ्याच वेळेस आपल्याला नातेवाईक पण सांगतो ICU मध्ये पेशंट गार पडलाय काहीतरी बघा जरा. So probably sometimes now we feel ki he is trying to guide us and he is trying to teach us, but always take them very seriously. Recently I have come across a patient who was admitted to a different hospital, was shifted due to sepsis, and relatives told me, and I called relative and told him that your right lower limb had a thrombus and may require immediate surgery to save the limb. So relative told me for last 3 days I was trying to tell the doctor because patient went there for bilateral pneumonia. So patient's relative told me that I was telling that doctor for last 3 days, zara paay baga paay duktoy, paay baga paay duktoy, paay baga paay duktoy. But he said no, huge bad pneumonia. So the doctor kept on telling that are kai nahi, पाय दुखतो, जागून झोपत राहा, एका जाग्यावर आहे, सूज येतच असते. So what happens, what is an eye opener or learner? If relative is giving you some hint about some symptom, don't take it casually. Always go back, review, examine, and probably you may find something. Because in a busy schedule, we may sometimes tell them, okay, kai nahi hai, alai pneumonia sati. So this is very important to look and examine the patient. So it is a hell of a task because we cannot tell patient, our colleague, that we cannot tell he has not seen. So probably such situation can be avoided. Then there is something called SLR or straight leg raising test, which is very, very important to, we can do probably something called auto transfusion. Just elevate the legs to 30 to 45 degrees and see what is happening to heart rate, blood pressure. If there is a significant improvement, probably you are saving time. Suppose of them case मध्ये patient ला hypotension झाले. What can be done? Just raise the leg, let that blood return and increase venous return to improve the pump, so you can save time. Then disability, you have to look for the signs for inadequate tissue perfusions, sedative effects of the whatever you have been used, and important is blood sugar. So again, I can quote a situation where I have been called from the ward and said that this patient is doing bad, his sensorium is bad, temperature is 103, has developed some neck stiffness, so we probably decided to shift him to ICU and get neuro to be involved. Neuro was involved, decided to do imaging, thought of meningitis. Then by that time we reviewed, his blood sugar was 45. So till the time counseling is done about possible brain infection, and when dextrose was given, patient was fine within half hour's time. So these are simple measures probably where in that, what happens in that scenario where you are being bombarded in a situation where you have been forced to take a decisions rapidly, and you may not in a situation to take such decision, or you are not used to take such decisions, there never forget blood sugar levels. So disability, this I'll just skip. So exposure, remove clothes, examine head to toe, keep patient warm, and important maintain integrity. So secondary survey, as said, detail history, order investigations, management plan and referral, review response and monitoring. See, whatever we are doing has to be reviewed again and again. So no change to initial treatment indicates that the patient has deteriorated, our patient, because blood pressure has, if you remember, the blood pressure was 80, after giving fluid it was also 80. So probably our patient needs complex interventions like ABG, hemogram, electrolytes, renal functions, ECG, X-ray. And then something called MI approach, like measure, interpret and apply. Why this is important? Many times what happens, clinician comes, orders some investigation and goes, but he is not bothered to see actually what is being asked to do. Okay, ABG, but nobody goes back and see what happened to that ABG, what happened to platelet count, what happened to respiratory rate. What happens sometimes in too much chaos, it can happen, like basic investigation. So I always tell residents, hemogram, blood sugar, creatinine, ECG, X-ray, never to miss. For any patient anywhere admitted, these are minimum investigation that needs to be done. Recently, one patient was admitted for acute abdomen at a surgical hospital, Patient's primary diagnosis was or symptom was abdominal pain. X-ray done. Abdomen X-ray standing was done because surgical hospital. Amylase, lipase was done. CT abdomen was done. Patient's abdominal pain didn't improve. Sugars were 300. Patient referred to Sahyadri for further management. X-ray was done. X-ray chest. It was showing a patch in right upper zone. ABG was done and patient's primary complaint while referring was increase in breathing difficulty also. pH was done, ABG on arrival was 6.8 and patient was in severe metabolic acidosis. So we could correct metabolic acidosis, treat as decay, give antibiotics, but the primary presenting complaint was abdominal pain. So abdomen is the magic box. We all are aware that sometimes symptoms can be far away from the primary pathology. So they are like a cockpit approach. Whenever somebody flies a flight, they will have a checklist 1, 2, 3, 4, 5. Same way, our hospital, if you can have protocolized things, hemogram, renal function, liver function, blood sugar, ECG, X-ray, and I think echo is a very basic test to be done in any specialty. Then such immediate or emergency situations arising possibilities will go down significantly because we will be well prepared for this. Making a diagnosis is an essential part of subsequent management. Problem-oriented approach we have to definitely have to have. We have to understand what is the pathology and ultimate therapeutic goals. So this slide probably sums up right from airway, breathing, circulation, disability, and what are the things that can be done to fix the physiology, making breathing better, or identifying the things earlier, then probably we can have a plan. So probably this just sums up that what should be the initial assessment seat. There is something called initial assessment seat. So that has to be there in every hospital, irrespective of the specialty. So what will happen? That will lead to a better communication to the next consultant who is coming and reviewing these patients, because sometimes we feel that this investigation is not required at this moment, but later on may be very useful in such scenarios. So thank you. So probably my take-home message will be, irrespective of any specialty, basic investigations. There is a lot of debate when I sit with my anesthesia colleague about what should be the pre-operative evaluation for any patient. So as per the anesthesia guidelines, there are a lot of question marks like surgery has been divided into minor, major, X-rays may not be required, not required, or they have not probably shown important or not according to the guideline. But if you ask same question to ourselves, see, cost is an issue, money is required, but if you see the amount of investigation that are required to be done for any hospitalized patient, and we can have some package for that, definitely we can do all the basic things before any procedure also and after any admission also, so that such situations will arise very, very rarely.
Thank you, Dr. Kapil, for a very important lecture, very tedious lecture in Lishu language. Now the topic is open for discussion.
Hello, sir. Sir, here. Yeah. Hello. Sir, I need some insight from you regarding that something known as that is antibiotic stewardship. Because suppose, as an example, in the ICU, if the patient is on 2 antibiotics and he is being treated for ventilator-associated pneumonia, and we have found the organism which is culture proven and all, and the patient has shown signs of improvement. So what is the protocol to be followed to decrease the antibiotics? Because there are many anecdotes to keep the antibiotics for a particular duration of time. So when to decrease the antibiotics, what it is, from what it is driven by?
See, I'll tell you what we practice in our setup. Antibiotic stewardship is need of the hour, because probably rampant use of antibiotic is ultimately leading to antibiotic resistance. So what happens in clinical practice, the scenario what he is saying, suppose somebody has come to me with a mild looking infection, WBC count 12,000, urine pus cells 30 to 40, temperature 101, and that moment I thought, okay, start him on piperacillin tazobactam. 2 days down the line, patient improved, blood pressure improved, fever has gone, counts gone back. So as a clinician, we will be always reluctant to de-escalate antibiotic therapy. So what will you say? Okay, bara hotoy rahu de, 3 divas rahlet, complete karu. But what happens, I'll tell you, if you don't de-escalate, then you will have more resistance. So what we practice in our unit, we have a very strong microbiology department. So we get cultures from last 6 months, urine, blood and other specimens. We have a definite data that what was the commonest organism causing urinary tract infection, for example. And that organism was sensitive to piperacillin tazobactam. So on day of admission, our antibiotic of choice is driven by this antibiogram. Okay, but in closed ICU that is challenging. Suppose patient is under my care, it is possible. Suppose it is admitted under my surgical colleague, then probably I have to tell him what is the logic behind starting this antibiotic. Down the line, suppose on that particular day, I am fortunate enough to do some biomarkers for sepsis. Suppose I have done CRP or procalcitonin and that was high. And when I decide, okay, patient had a clinical improvement, patient blood pressure has improved, probably I will think about on what we do, we actually de-escalate to the molecule if we have a culture report or if we don't have culture report. And before that, what we do sepsis biomarkers. We see trend in CRP and we see trend in procalcitonin. Now caveat here that people will argue that procalcitonin is costly. But see, if I am giving suppose meropenem, the cost is around suppose 1000 rupees injection, 1 day cost is 3000, 3500, my procalcitonin cost is 800 rupees, my CRP cost is 500 rupees. So still it is justified. If my patient has not improved other way around, then my antibiotic escalation policy will not depend on biomarkers. But my de-escalation policy will depend on biomarkers because there is a medico-legal significance also. Suppose in the court of law I stand and patient gets deteriorated later, they may ask me why you changed the antibiotic which was working. So I should have a definite evidence to tell them, okay, see, look at WBC count, look at procalcitonin, look at CRP, had a downward trend. Then you will save antibiotics. So probably in a situation, don't be under impression ki no, he is improving, so I'll continue that. Particularly, you can label them as, what we do, we call them high alert antibiotics. And that is, special form needs to be filled by residents on duty, why that antibiotic is used. And for high alert, we have all carbapenems, we have tigecycline, we have colistin, we have phosphomycin. 8 antibiotics are being cefepime, avibactam. These are high alert antibiotics.
Sir, any specific criteria do you follow, like while looking for the trends of biomarkers? Like the biomarkers should fall by this much number, or these many days have gone that the patient is improving?
If clinical improvement is there, just drop in biomarkers is fine. We have to remember the T-half of biomarkers also. Like suppose somebody who had a high procalcitonin, high CRP, day 3 patient has not improved, I will not wait for antibiotics to be changed on biomarkers. There I will straightly change. But suppose I have to de-escalate, then there I will probably prefer doing procalcitonin first because that is a short half-life as compared to CRP. And if I am thinking about second infection, like procal is done, CRP is done, but I have to think of changing antibiotics. I have changed, but still I need subjective evidence. There I will do CRP because there's a shorter half-life as compared to procalcitonin. But biomarkers do help in taking decisions. But our antibiotic initiation, there are very clear words. Antibiotic initiation is not depending on biomarkers. That is your clinical decision. Antibiotic escalation is not depending on biomarkers. That is a clinical decision. And antibiotic de-escalation biomarkers can be useful.
Thank you, sir.
See, every month we provide our data to management team and we are answerable to them. There is something called HIC, Hospital Infection Committee. There we have to answer them how many catheter related bloodstream infections were there, how many urinary tract infections were there, how many bloodstream infections were there, and how many ventilator associated pneumonias were there. In that, we try to minimize it to the lowest, but our rate for catheter associated infection is around tune of 5%. VAP rate is around same 5 to 10%. Bloodstream infection rate 1 to 2%. Because we cannot deny that. Then we have a policy why these infections happen. Either we have to go, we usually go back and review how the central line was put, what methods were being used, whether cap, mask, gown, all aseptic precautions were used or not. That helps, but we see nosocomial infections in our ICU. And what is the single best thing which prevents hospital-acquired infection or ICU-acquired secondary infection is hand washing. So, frequent use of sterilium, there is something called 5-step approach, or 5 points where you have to use your antiseptic solution before touching the patient. If you can have 100% compliance to this, then rate of infections in ICU will definitely go down. Because mostly we have a lot of resistant bugs because this is tertiary care, Acinetobacter, Klebsiella, Pseudomonas. So we try to give nursing ratio 1:1, but that never happens. There is always a fight between whoever is the primary consultant. To give 1:1 ratio is difficult. So suppose 1:3 ratio, then I have to train my nursing staff to have better hand hygiene practices.
Thank you, sir. Now I request Dr. Dodke sir to felicitate our speaker.
Felicitated. Felicitation is already done.
Complete.
Again,
I request Dr. Minge sir to come on stage to felicitate our chairperson.
Oh. Hello. I request everybody to be in the hall so that we can continue the next session. I request everybody to come in the hall so that we can continue the next session.
हाँ ऐक की माझ्याकडे की हाँ. Welcome back all. Please gather into hall. So the next lecture is by our own Dr. Sudesh Doshi sir on hypertension in pregnancy. I request Mrs. Sujata Gundar ma'am to come onto the stage and occupy the chair as a chairperson. And I request Dr. Hanumant Kumbar sir and I request Dr. Seema Patil madam and Dr. Mohite sir to occupy as the chairperson. Come on to the stage. Humble request to all the chairperson to occupy. I would like to speak few words about Doshi sir. He is a well-known gynecologist in Pandharpur. He is a senior obstetrician and medical legal consultant working since 26 years at Agras Hospital, Pandharpur. He has experience of delivering over 15,000 babies at his nursing home. He was chairperson of Adolescent Health Committee and Medical Legal Committee AMOX. He is a member of NIMC PCPNDT FOXY. Right now he is the acting president of OBGYN Society Pandharpur and Vice President IMLEA Maharashtra chapter and a zonal coordinator of AMOX. I request sir to start the lecture. Please gather in hall.
Hello. Good afternoon, everybody. I hope everyone is awake after having this good lunch with 2 sweet dishes. So if all are awake, you can find something wrong in the title. Well, the spelling of disorders is wrong. I purposefully kept it so that you can know it. Now, talking about hypertensive disorders of pregnancy, as we all know, hypertension is not only a physician's domain, but also an obstetrician's domain. So hypertension you can get when the patient is not pregnant, or prior to pregnancy hypertension may be still existing there. Then patient may get hypertension after she becomes pregnant, and there can be severe hypertension, preeclampsia and eclampsia. These have been various definitions just to enumerate them. Hypertension is when blood pressure is more than 140/90 for 2 consecutive readings 4 hours apart. Chronic hypertension when the patient already has hypertension before 20 weeks of pregnancy. Pregnancy-induced hypertension is hypertension when the patient gets first-time hypertension after 20 weeks of pregnancy. Preeclampsia is 140/90 but less than 160/110 with proteinuria. Severe preeclampsia when blood pressure is more than 160/110 with proteinuria 3+ or 4+. And preeclampsia with presence of any symptoms like headache, blurring of vision, epigastric pain, oliguria, abnormal edema over face, hands, abdomen or vulva. And everything this with convulsions is called eclampsia. Convulsions in pregnancy, labor or postpartum period should be considered eclampsia unless proved otherwise. That is, if patient is a known patient of epilepsy, then only we can say it is epilepsy. Otherwise, pregnancy with convulsions is always taken as eclampsia. Now, this is definitions in some different called gestational hypertension. Various terminologies have been used as gestational hypertension, preeclampsia, toxemia, hypertension in pregnancy, pregnancy-induced hypertension. But now the current terminology which is used is hypertensive disorders of pregnancy. HDP is the current terminology which is being used for last 5 years. I don't know how much time it will remain. Maybe 5 years after we will change the terminology. Now, what are we more worried is about severe preeclampsia and eclampsia. Because pregnancy-induced hypertension carries a more amount of morbidity and unfortunately some mortality also. And mortality is in pregnancy, that is maternal mortality is an indicator of progress of your nation, and we have it by heart. And so we want to prevent every possible mortality. So Government of India has given some guidelines to decrease the morbidity and mortality, to have some screening test to predict, prevent and treat hypertension and preeclampsia and eclampsia. So I'll be going under those. So severe preeclampsia and these complications are major causes of maternal and perinatal morbidity and mortality. Not only maternal but perinatal, that is the mortality of the fetus is also more. Among all maternal deaths, 19% deaths are due to hypertension in pregnancy. And despite the phenomenal number of mothers seeking hospital-based delivery care, substantial gap is identified in the quality of care. Now, prediction of preeclampsia. Generally, when the patient is getting treatment for antenatal treatment, she may be coming to a private clinic, she may be going into a government medical college, or she may be coming to sub-district hospitals, or not even that, all the patients who are coming to a primary health center or sub-center, even at the level of ASHA workers, there have to be some tests where we can predict preeclampsia or severe preeclampsia, which may come early around 34 weeks, 32 weeks, 36 weeks. Because hypertension which comes around 37 weeks, 38 weeks is not much of worry, because that time the pregnancy is almost term, we can simply terminate the pregnancy, get the delivery done and it is over. But for those patients who get early preeclampsia, that is around 30 weeks, 32 weeks, 34 weeks, where the baby is not yet mature or where we have less amount of facilities for taking care of premature births and preterm births, then it adds to a huge morbidity. So for prediction, we have to have some tools, which one of which I will be discussing today, where we should be able to predict that this patient is more likely to have preeclampsia early, and how can we prevent it. So for prediction of eclampsia, universal screening is recommended, but there is no single effective screening test. There have been various tests, clinical tests. In our medical college days, we had a rollover test, then measuring hypertension in sitting position, lying down position. Then there were various biochemical markers and all those things, but none of them have been very effective. So none of these tests proposed till date to predict the at-risk population of preeclampsia qualified to be recommended for the general population screening. Thus, assessment of clinical risk factor helps us to be more vigilant. A careful history taken early in first trimester can warrant attention for effective prediction and prevention towards mothers at risk very early. This can be done by any health worker, care worker, by using HDP gestosis score. Now this gestosis score, which I will be talking more, is a simple score which can be used even by any healthcare worker. Healthcare worker does not include only doctors. Many times we have a zapad all around us that healthcare work means only doctors, but no. There are a lot of paramedical workers, there are a lot of social workers, there are a lot of machinery in the government which is working as a healthcare worker also. So a simple ASHA worker also can assess this gestosis score, and if it is more, she can refer it to the higher center or at least to a doctor or even a clinician. When takes a gestosis score, a simple remedy like starting 75 milligrams of aspirin and 1 gram of calcium per day can definitely prevent very early severe preeclampsia. So what is this gestosis score? Now this gestosis score has total 27 parameters. आता 27 parameters मध्ये लोकांना म्हणतं 27 वेळा कोण मोजणार? But this has been made very simple. There are few points which are score 1, few points which are score 2, and few points which are score 3. Now this I will go through one of them. Simple factors like age more than 35 years, age less than 19 years, maternal anemia, obesity more than BMI 30, a primigravida, short duration of sperm exposure, a woman born as a small for gestational age, family history of cardiovascular disease, conceived with IVF, mean arterial pressure of more than 85 millimeters of mercury, chronic vascular disease or excessive weight gain during pregnancy. आता याच्यामधलं mean arterial blood pressure सोडलं तर बाकीच्या सगळ्या गोष्टी डॉक्टर नसलेल्या व्यक्ती सुद्धा विचारू शकते. That is the simplicity of this thing. त्यानंतर there are few things where you can give score 2. Maternal hypothyroidism, family history of preeclampsia, gestational diabetes mellitus, obesity, multifetal pregnancy, hypertensive disease in previous pregnancy, याला 2 स्कोर आहे. आणि बाकीच्या गोष्टी which are more at risk, what we know, pre-gestational diabetes mellitus, chronic hypertension, mental disorder, inherited or acquired thrombophilia, maternal chronic kidney disease, autoimmune disease, pregnancy with assisted OD or surrogacy treatment, याला स्कोर 3 आहे. आता हे सगळं वाचताना लक्षात कसं ठेवायचं आणि मोजायचं कसं, कॅल्क्युलेशन कोण करणार, मॅथ्स कोण करणार, तर याच्यामध्ये टेक्नॉलॉजी इन्क्लूड केल्यामुळे हे खूप सोपं झालेलं आहे. याचं एक छोटंसं ॲप येतं. आय एम व्हेरी प्राऊड टू सो दॅट आवर इंडियन फेडरेशन ऑफ ऑब्झॅनिक सोसायटीज ऑफ इंडिया, दॅट इज फॉक्सी, हॅज डेव्हलप्ड दिस सिम्पल ॲप. And the man behind this app and this score is our own Dr. Gorak Mandrupkar from Islampur. छोट्याशा गावातला छोटा माणूस सुद्धा हे करू शकतो. मुंबईत आणि दिल्लीतच गेलं पाहिजे असं नाही. Who has developed this simple app. आणि त्या ॲपमध्ये now I am using this app for last almost 2 years. I have made my houseman and my staff to download this app compulsory and simple asking this question. This takes less than 90 seconds. 1, 2, 3, 4 you could go on ticking. आणि टोटल किती येते, स्कोर किती येतो. इफ द स्कोर इज मोर दॅन 3 यू हॅव टू स्टार्ट ॲस्पिरिन प्लस कॅल्शियम 1 gram per day. इफ स्कोर इज 2 यू हॅव टू जस्ट स्टार्ट ॲस्पिरिन. इफ स्कोर इज 1 यू डोंट हॅव टू डू एनिथिंग. सो ॲस्पिरिन, सिम्पल ॲस्पिरिन, फुकट गोळी आहे, 60 पैसा 20 पैशाला एक गोळी मिळते आणि त्यांनी आपण प्रिएक्लाम्पशिया बऱ्याच अंशी थांबवू शकतो. सो this is a gestosis score which I would recommend all the obstetricians to download and use in their practice. Gestosis score is available on Foxy website. It is available as an app on Google Store and Android and all Apple applications also. Simple thing, you download in your mobile and use for the first patient which comes to your clinic tomorrow, and you will know how simple it is and how effective it is. So what are the more predictors of preeclampsia? Now this is a little costly investigation, role of Dopplers in preeclampsia. Definitely role of Dopplers is there in prediction of preeclampsia and management of preeclampsia, management of fetal growth retardation due to eclampsia also, but that needs an expertise. You need a good Doppler ultrasound machine which would cost you around more than 10 lakh rupees, and more important that you need a trained personnel who can take the uterine artery Dopplers correctly, who can take the umbilical artery Dopplers correctly, and who can take MCA Dopplers correctly. So severe PH can be predicted by using Doppler measurements of uterine arteries and umbilical arteries. There is no single value which is predictor of preeclampsia, but there is a range, and which also you can have on the Delphi score if you go on the internet. Then it has also got predictive values there. कोणत्या gestation ageला PI किती असला पाहिजे याचे त्यांचे charts आहेत, and you can go through them so as to have the predictive value of preeclampsia. Further management of FGR due to PH can be guided by umbilical artery Dopplers, middle cerebral artery Dopplers, and ductus venosus. The indices which are helpful are pulsatility index, resistance index, and SD ratio. But now most of the times SD ratio, then early diastolic notch, resistance index are gone. Most of the people are using now PI. Now one more important thing is, while predicting preeclampsia or while measuring blood pressure, there are few simple steps which need to be done religiously, and many times we are very much in a hurry, and हे blood pressure मोजायचं टेक्निक आहे हेच बऱ्याच वेळेला आपल्याकडनं चुकतं. I'm sorry to say, पण including me, we are in a very much hurry. ब्लड प्रेशर बऱ्याच वेळेला आपण न बघता आपला कोणीतरी असिस्टंट किंवा अनट्रेन नर्स आणि कोणीच नसेल तर अगदी मावशी तेवढं मोजावं ब्लड प्रेशर असं काही ठिकाणी होतं अनफॉर्च्युनेटली. ते जरी झालं तरी त्या माणसाला तुम्ही ट्रेन केलं तर तो चांगला ब्लड प्रेशर बघू शकतो. वन थिंग इज पेशंट मस्ट बी सीटेड. आपण बहुतेक सगळे लोक पेशंट टेबलवर झोपल्यानंतर त्याचं ब्लड प्रेशर बघतो, पण इंटरनॅशनल रेकमेंडेशन्स आहेत की पेशंट बसल्यानंतर त्याचं ब्लड प्रेशर बघितलं पाहिजे आणि त्याचे पाय जमिनीला टेकलेले असले पाहिजेत. त्याचे पाय हवेत जरी असतील खुर्चीत बसल्यानंतर तरी ते ब्लड प्रेशर 5, 6, 7 मिलीमीटर ऑफ मर्क्युरीने वाढू शकतं. सो पेशंट मस्ट बी सीटेड with feet supported and she should be seated for 2 to 3 minutes before blood pressure measured. Left lateral recumbence position is preferred than supine position in bed bound mother. पेशंट लेबरमध्ये आहे, पेशंट बेडवर झोपलेला आहे, तो उठून त्याला खुर्चीत बसवणं शक्य नसेल तर लेफ्ट लॅटरल पोझिशनमध्ये घ्यावा. ब्लड प्रेशर शुड बी टेकन इन बोथ आर्म्स इन द फर्स्ट अँटीनेटल विजिट अँड इफ देर इज नो डिफरन्स देन वन आर्म कॅन बी टेकन. मोस्ट ऑफ द फिजिशियन्स वुड ॲग्री दॅट ब्लड प्रेशर शुड बी टेकन. ते तर आता 4 लिंब ब्लड प्रेशर घ्या म्हणतात, पण तेवढे शक्य नाही. पण ॲटलीस्ट फॉर द फर्स्ट विजिट शुड बी टेकन इन बोथ द आर्म्स बिकॉज वी आर लाईकली टू मिस सम कार्डियक लिजन्स इफ यू डोंट टेक इन बोथ आर्म्स. Right arm should be used thereafter if there is no significant difference between the arms. The first systolic blood pressure should be taken at brachial artery by palpation method. Then second systolic blood pressure is taken again with auscultatory method at Kortkopf phase 1. This is nothing but first year physiology lecture, clinical physiology. तुम्हाला जर आठवत असेल ब्लड प्रेशर कसं मोजतात त्याच्यावर 1 तास आपलं लेक्चर व्हायचं. This is simple things but we tend to forget them because we are not in use to do it again and again. We forget them. Diastolic blood pressure is recorded at Kortkopf phase 5. If phase 5 is absent, it can be recorded at phase 4. A standard cuff should be used for arms with circumference for less than 33 centimeters. Very large cuff, which most of us we don't have, असायला पाहिजे. Pediatrics वेगळा असतो, where circumference is more than 33 centimeter with the lower end of cuff 2.5 centimeter above the antecubital fossa. In absence of mercury manometers, calibrated and properly standardized anaeroid or digital equipments can be used. Early identification of women at risk for pregnancy-induced hypertension may help prevent complications of disease, and education about warning symptoms is also important because early recognition may help women receive treatment and prevent worsening of disease. So all at-risk women should be screened, and those who are at high risk, WHO recommends calcium supplementation in where the diet is deficient in calcium, and Government of India and FOXI, their recommendations are that each woman should be given calcium supplementation for 6 months during ANC period after first trimester and for 6 months during lactation. 2 calcium tablets, each containing 500 milligram of elemental calcium would be given daily, and each tablet should contain 250 international units of vitamin D3 also. Now this is a pie diagram showing preeclampsia, eclampsia as a leading cause of maternal mortality globally and in India. So how do you manage hypertensive disorders of pregnancy? Now mild hypertension in pregnancy where the blood pressure is around 140/90, urine albumin is trace or maybe 1+, patient does not have any pre-monitory symptoms like swelling, edema or blurring of vision, headache and all. Then they can be managed with outpatient with weekly visits and bed rest, or maybe if the patient is not possible for weekly visits, you can give an alternative of home monitoring with digital blood pressure apparatus, or the clinician is most of them available next door. आता प्रत्येक अगदी 1500-2000 वस्तीच्या गावात सुद्धा कोणीतरी एक डॉक्टर उपलब्ध असतो की ज्याला ब्लड प्रेशर मोजता येतं. जवळच्या लोकल डॉक्टरकडे त्यांना सकाळ संध्याकाळ ब्लड प्रेशर मॉनिटर करायला सांगा. एक चार्ट बनवून द्या आणि त्याच्यावर लिहून आणायला सांगा. कारण बऱ्याच वेळा अडचणी काय होतात, हे त्या जनरल प्रॅक्टिशनरकडे गेले की ते म्हणतात डॉक्टर आम्हाला नुसतं बीपी मोजायचं आहे. नुसतं बीपी मोजायचं अर्थ आम्ही तुम्हाला पैसे देणार नाही असा असतो. मग त्यालाही फारसा इंटरेस्ट नसतो मोजण्यामध्ये. सो गिव्ह देम अ चार्ट, आज देम सरांना बीपी मोजायला सांगा आणि या चार्टमध्ये लिहून द्यायला सांगा. मग त्याने काहीतरी लिहून दिलं की ह्या बिचारला काहीतरी पैसे त्याला परत द्यावे लागतात. सो यू हॅव अ चार्ट, इट इज अ रिटन प्रूफ देअर की नक्की कसं मॉनिटर केलं. नाही तर मग आपल्याला काहीतरी उत्तर मिळतात. हे सगळं अनुभवातनं शिकलो मी. नाही त्या डॉक्टरने सांगितलं बीपी नॉर्मल आहे, थोडंसंच वाढलेलं आहे, जास्त वाढलेलं नाही. मग एकदा तुमच्याकडे जर आठवड्याभराचं बीपी मॉनिटरिंगचं चार्ट असेल तर देन यू गेट सम आयडिया की काय करता येईल काय नाही. So that can be done. So antihypertensive therapy indicative diastolic blood pressure is repeatedly above. This is for severe preeclampsia. Hydralazine आपण वापरत नाही. पण आपल्याकडे आपण काय वापरतो, we use alpha dopa which is not available now, but labetalol is available. IV labetalol can be used and nifedipine also can be used. If the gestational hypertension is severe, more than 160, 100, or if patient is coming for seizure, then we can give magnesium sulfate prophylaxis or complete dose. So there is a multi-pronged approach. For management of severe preeclampsia, we have nursing care, we have role of medicines, we have role of magnesium sulfate, and we have delivery of the baby. In simple terms, which I remember our teacher used to tell, what is management of pregnancy-induced hypertension? Management of pregnancy-induced hypertension is delivery of the baby. So you remove the cause, but many times we have to wait till the baby is at term, or we can salvage the baby. So that's what we have to do. So tablet alpha-methyl-dopa or labetalol can be used for controlling BP. Target should be to maintain BP between 90 to 100 millimeter diastolic. In case of severe preeclampsia, nifedipine or labetalol may be used. One caution about nifedipine: when we use nifedipine for preeclampsia or severe preeclampsia, we had a habit in our days of residency, nifedipine गोळी मिळायची, त्याला टाचणी मारायची आणि अख्खीची अख्खी गोळी पिळायची. That is very dangerous. Patient can die because of that. So nowadays that is not recommended. You can give a sustained release tablet or a tablet or nifedipine is to be swallowed. Don't do that. We had a habit of doing that in residency days, but now it has been proven that it is very dangerous to give the अख्खीची अख्खी गोळी जिभेखाली पिळायची. That is dangerous. That should not be done. That should be avoided. Now we will be talking about severe preeclampsia, when this magnesium sulfate to be used. Now magnesium sulfate is a drug which we all have been using since our residency days, but now Government of India is giving training of magnesium sulfate, how to administer to prevent eclampsia or to treat eclampsia even at primary health center care level, where the medical officer is available there. He may not be an obstetrician, he may not be trained in obstetrics, but even the paramedical workers are being trained, those GNMs, ANMs who are there, they are being trained how to recognize premonitory symptoms of eclampsia and how to give magnesium sulfate. And even Foxy, along with Government of India, Government of Maharashtra, we all are giving trainings through Manyata Dakshata program to prevent the morbidity and mortality. की मॅग्नेशियम सल्फेट कसं द्यायचं याचं प्रशिक्षण फक्त गायनाकोलॉजिस्टलाच नाही, तर गायनाकोलॉजिस्टला ते माहीत आहे हे गृहीत धरून MBBS मेडिकल ऑफिसर्स, GNMs, ANMs जे आहेत त्या लोकांना सुद्धा मॅग्नेशियम सल्फेट कसं द्यायचं याचं ट्रेनिंग पूर्णतः दिलं जातं. आणि ते ट्रेनिंग दिल्यानंतर मलाही वैयक्तिक फरक जाणवायला लागले की पूर्वी जर मी रूममध्ये जर लेबर रूममध्ये एकलांशा झाला असं म्हटलं की माझे हार्टबीट बंद व्हायचे वर जाईपर्यंत, पण आता ज्यावेळेस माझ्या स्टाफला मी ट्रेन केलं की मॅग्नेशियम सल्फेट कसं द्यायचं तर मी त्यांना सांगू शकतो. पेशंटला कन्वर्जन आलं तर मॅग्नेशियम सल्फेट द्या, किंवा रादर ते सांगतात एक जण मॅग्नेशियम सल्फेट देत असतो दुसरा सांगतो सर पेशंटला कन्वर्जन आलंय, तर मी त्यांना सांगतो मॅग्नेशियम सल्फेट द्यायला सुरू करा, मी तोपर्यंत पोहोचतोय. सो दॅट इज द लेवल ऑफ डिफरन्स वेर इट मेक्स, की आपण गेल्यानंतर सगळं सुरू व्हायच्या आधी, आपण जायच्या आधी तिथं जर काही सुरू झालं, आता त्या गाड्यांच्या जाहिराती असतात बघा की गाडी चालू व्हायच्या आधी AC चालू करायचं आणि मग आपण गाडी गारदाला गाडी जाऊन बसायचं, तशा पद्धतीने आपण लेबर रूममध्ये पोहोचेपर्यंत मॅग्नेशियम सल्फेट द्यायला थांबायची गरज नाही. कन्वर्जन आहे एकलांशा पेशंटला मॅग्नेशियम सल्फेट लगेच लागणार आहे, तर प्रायमरी ऑब्स्टेट्रिशियन तिथं येईपर्यंत त्या पेशंटला जर मॅग्नेशियम सल्फेट गेलं तर पुढचं कन्वर्जन आपण थांबवू शकतो, पुढची मॉर्बिडिटी पुढची मॉर्टिलिटी आपण थांबवू शकतो. सो for eclampsia, severe preeclampsia, that is 160, 110 with proteinuria 3+4+ किंवा symptoms असतील तर how to give first dose total 10 grams 5-5 ग्राम दोन्ही बटकमध्ये द्या, लोडिंग डोस टोटल 14 ग्रामचा द्यायचा आहे, तो आपल्या सेकंड रेफरल युनिटला द्यायचा आहे. कशा पद्धतीचे डिटेल्स आहेत ते आता मी सांगायची गरज नाही. टॉक्सिसिटी सायन्स बघा, आपल्याला माहिती 3 गोष्टी बघायच्या आहेत, युरिन आउटपुट, डीप टेंडर रिफ्लेक्स आणि रेस्पिरेटरी, ह्या 3 गोष्टी बघूनच पुढचा डोस आपल्याला द्यायचा आहे. Magnesium sulfate is a safe drug to use. Government of India recommends magnesium sulfate by nurses in case of severe preeclampsia and eclampsia first dose. मी मगाशी म्हटलं होते अशा पद्धतीने देता येते. Now something about HELP syndrome. Now hypertension patients with hemolysis, elevated liver enzymes, low platelet count, 4 to 12% of patients with severe preeclampsia and eclampsia develop HELP syndrome. Most times HELP syndromeचा जर पेशंट असेल तर देन इट इज अ मल्टी स्पेशालिटी अप्रोच, मल्टी प्रॉंग्ड अप्रोच. जनरली पेशंट हेल्प किंवा DIC मध्ये द्यायला लागले की ऑब्स्टेट्रिशियनचा रोल कमी करून ऑब्स्टेट्रिशियन ते बर्डन सगळं थोडंसं फिजिशियनकडे शिफ्ट करतात, किंवा मल्टी स्पेशालिटी क्रिटिकल केअर जिथे अवेलेबल आहे तिथे शिफ्ट होतो. ब्लड अँड ब्लड प्रॉडक्टची अवेलेबिलिटी हॅज अ ग्रेट रोल टू प्ले. ते ब्लड प्रॉडक्ट्स कसे वापरायचे याची चांगली जाण असणं गरजेचं असतं. ते क्रिटिकल केअर युनिट आणि ऑब्स्टेट्रिशियन्स दोघं म्हणून जास्त चांगल्या रीतीने पेशंटला ट्रीट करू शकतात. सो हेल्प इट इज बेटर ट्रीटेड ॲट हाय डिपेंडन्सी युनिट किंवा मल्टी स्पेशालिटी अप्रोचनी जास्त चांगलं ट्रीट होतं आहे. So treatment is cardiovascular stabilization, correction of coagulation abnormalities and delivery, platelet transfusion before or after delivery if the platelet count is less than 20,000 as Nemani sir told today. If less than 32 weeks of gestation, steroid therapy may help stabilize the maternal platelet count. Now, आता 3 गोष्टी बघायच्या पण मॅग्नेशियम सल्फेट नर्सिंग केअर. ना हाऊ टू आयडेंटिफाय पेशंट्स हू नीड नर्सिंग केअर, म्हणजे ज्यांना ॲडमिट करून ठेवणं गरजेचं आहे, वीकली विजिट्सनी किंवा जमणार नाही. इफ द पेशंट इज हॅव्हिंग जेस्टेशनल हायपरटेन्शन, इफ शी इज प्रेझेंटिंग इन लेबर आणि प्रेझेंटिंग विदाउट लेबर, नर्सिंग केअर कशा पद्धतीने लागणार आहे, प्री एक्लाम्शामध्ये कधी लागणार आहे, सिव्हिअर प्री एक्लाम्शाला कधी लागणार आहे, एक्लाम्शाला कधी लागणार आहे. सो इफ द पेशंट इज प्रेझेंटिंग इन लेबर, नर्सिंग केअर लागणार. 1 more minute. Admit and treat as per progressively. If she is not in labor, nursing care is not required. You can give treatment, antihypertensives and call her for follow-up. Follow-up in after 1 week. Presenting in labor ला काय करायचं, admit and treat pre-eclampsia. Without labor असेल तरी नाही करायचं आहे. Severe pre-eclampsia मात्र nursing care पाहिजे, admit magnesium sulfate आणि treat करायचं आहे. Without labor असेल, severe असेल तरी सुद्धा admit करायचं आहे. eclampsia तर definitely admit करायचं आहेच. What are the warning symptoms and signs for patient? हे पेशंटला, ज्या पेशंटला ब्लड प्रेशर आहे, ज्याला घरी ब्लड प्रेशर मॉनिटरिंग करायला आपण सांगणार आहोत, त्याला हे डिस्क्राईब करून द्यायचं आहे. त्याच्याबरोबरच्या एका नातेवाईकाला बरोबर घ्यायचं, त्याला समजावून सांगायचं आहे. खूप डोकं दुखते, बाळाची हालचाल कमी होते, उलट्या होत आहेत, चक्कर येते, पोटात खूप दुखते, उजव्या बाजूला खूप दुखते, ब्लिडिंग होते, पोटाचा दगड झाल्यासारखं वाटतंय, चक्करून पडतोय पेशंट, डोळ्यासमोर अंधारी येते, अशा वेळेस पटकन यायचं आहे. आणि हा एक चार्ट आहे, whether to terminate the pregnancy or not. If she is already in labor, then let her progress labor. If only gestational hypertension, मग आपल्याला after 37 weeks तिला induce करायचे. If it is pre-eclampsia, then you have to induce after 37 weeks. If severe pre-eclampsia, less than 23 weeks असेल तर आपल्याला तिला terminate करून टाकायचं आहे, not waiting for the baby. आणि 24 to 34 weeks थोडंसं डायसी असतंय, 34 weeks गेले की पुढे ट्रीट करायचे. आणि एक्लाम्शियाला केव्हाही असू देत, यू हॅव टू डिलिव्हर द पेशंट अँड टर्मिनेट द प्रेग्नन्सी. दिस इज अ गुड चार्ट. दिस इज ऑन द NHRM वेबसाईट. यू कॅन टेक इट फ्रॉम इट. वेन यू आर इन डायसी सिच्युएशन, वेदर आय शुड गो अहेड विथ कन्झर्विंग द प्रेग्नन्सी और डिलिव्हरिंग द बेबी, दिस इज द चार्ट विच इज बीन टेकन. These are the few dietary guidelines about patients la diet sanga आम्ही काय करू. Salt restriction has been advised, small frequent meals, plenty of green leafy vegetables, and foods like oranges, sweet limes, watermelon, etc. Eat and drink at least 4 servings of calcium rich foods, 1 source of vitamin. And diet should be optimum amount of sodium. Increase in edema, hypertension असेल तर sodium restrict करायचं, salt intake reduce करायचं आहे, reduce the use of saturated fatty acids and so on. This is a sample plan, how to take a diet. This can be taken from the website. So these are the things about hypertensive disorders in pregnancy. I think I tried to complete as much as possible at the primary level. I once again thank Pandharpur IMA for giving this opportunity to talk in front of all of you. Thank you. Thank you so much.
Now topic is open for interaction. Any queries? Kindly you can ask Doshi sir.
Contraction is less and patient may go into PPH, severe PPH.
Yeah. Whenever we give Maxel, generally Maxel first dose given, we try to deliver the baby as early as possible, either vaginally or for LSCS. And we are very well known that magnesium sulfate has a uterine relaxant effect. Moreover, trials have been there for threatened labor. To prevent labor, magnesium sulfate has been administered to stop the labor. So we are very well aware and we are always prepared for PPH in cases of severe PIH for 2 things. One is because of use of nifedipine and magnesium sulfate. Yeah, sir. Yes, definitely, sir. Thank you so much.
Sudesh, excellent lecture. I would like to add 1 or 2 things. First is preeclamptic toxemia occurs because of faulty angiogenesis. And because it occurs because of faulty angiogenesis, there are certain biochemical markers which can help us in predicting toxemia. And these biochemical markers are directly related to placenta. That is placental binding factor, PA-PPA, which we do in the first trimester for aneuploidy also. But this also is related to placentation. So low levels of PA-PPA, low levels of placental binding factor and glycosylated F1, This also will help us in future in identifying the patients of preeclamptic toxemia. In all, placental binding factor also decreases because we know that whenever we deliver a patient of toxemia, placentas are small.
And we have been doing in few patients. The only problem is the limitation in their interpretation, limitation of availability of markers. Only few places they are available, their interpretation and the cost. I predominantly concentrate more on the mass basis. Whatever you added is a quite good thing. And yes, definitely, just to complete the list, we had these things. Thank you so much, ma'am, for the addition.
Thank you, Doshi sir. I request Gundevar ma'am to felicitate Doshi sir. After that, I request Senior Menkudre sir to felicitate the chairperson. Please come onto the stage. So we need to think about the better treatment options instead of thinking early delivery due to preeclampsia. Very nice and informative lecture, post-lunch lecture given by Doshi sir.
Thank you, sir. Moving toward the next session, which is most awaited session of the today's CME, the lecture by Dr. M.K. Inamdar sir on ideal emergency room in a rural multi-speciality hospital. I call upon Dr. V.G. Bopatkar sir, Dr. Vishal Phade sir, Dr. Sriraj Kane sir, and Dr. Sujay Gaikwad sir to chair the session. Please come on the stage. There is no need of introduction to Dr. M.K. Inamdar sir in our area. He is a well-known stalwart to all of us. He has done his graduate and postgraduate studies from GMC Mirrors. He has developed a cardiac care unit in a rural hospital since last 36 years. And now he is running well-equipped ICU, color doctor unit, ABP and Holter monitor. He has taken extensive training in interventional cardiology for 2 years and has an established cardiac care unit since 2004. He has performed more than 15,000 procedures including coronary angiography, angioplasty, pacemaker, IVC filter and about 7,000 angioplasties, including 2,000 PAMIs. He is a regular speaker at national and international conferences. He has received late B.V. Mule Oration Award of IMA Solapur, Parker Foundation's Lifetime Achievement Award. He has received a fellowship from American College of Cardiology and Indian Society of Cardiology. He is member of Cardiology Society of India. He was president of IMA Akulus. I request Dr. Inamdar sir to start his presentation.
Respected chairpersons and dear friends, I thank M A Pandharpur for calling me for this lecture to PanCon. This is my experience, emergency room, how it should be. There is no ideal emergency room as such. How big hospital is there or how much small hospital is. But you can come to a near completion or near ideal situation where you can find out more easier work in emergency this. Where in and out there are always emergencies pouring in. You should have at least good protocol for this so that you can save many lives. This is an integral part and most important part of the hospital. The emergency room is absolutely essential part of the hospital. This is a mirror of the hospital actually. This is when you enter the emergency room, how many patients will go in, how many patients will go out, and how many patients will go up. It depends upon the type of emergency room you are dealing with. It decides overall mortality of the critically ill patients, because whatever emergency is there, it is to be tackled within 15 minutes, not more than that, because 15 minutes you should almost complete your goal and you should decide. Of course, there are many situations where you have to struggle it for longer time, but once patient comes there, right from diagnosis to treatment, primary treatment, it should complete within 10 to 15 minutes. Better the emergency room, better the outcome. It works 24/7. Quick and accurate diagnosis is very important. Provision of immediate and appropriate life-saving treatment is absolutely essential. Rapid institution of BLS or ACLS. Protocols for resuscitation should be immediately there. All persons should be trained. The patients coming to ER or emergency room, those are handled by a person who is well trained in this, including doctors, assistants, nurses, even the ward boys, mama and maushis. Briefings relatives about the illness and complications, immediately you have to tell them. For example, patient comes with a pulmonary embolism, massive pulmonary embolism, and if you tell them that this massive pulmonary embolism, it is going to be very critical, patients may die within hours or so, and you have to give an injection of 40,000, 50,000, nobody will agree, I think. And the patients also this. So you have to help them out, that telling that this condition is critical, we will supply the medicines first and then you have to reimburse it. But right now within 2 to 3 minutes this is required. Or case of myocardial infarction where the primary angioplasty is not possible, you have to give thrombolysis. There you have to explain the relations very well. And for that 10 staff is required, 10 doctors is required who can manage all this. Maintaining records of MLC and non-MLC cases also is a very important part of emergency this. So many times in my settings I have seen that patient comes it's already brought dead. And they tell the patients who is dead about half an hour ago, then सांगतात नाते सर काहीतरी करा. So you have to tell them that see these eyes are totally sclerosed, dry. His death is more than 30 minutes earlier and I cannot do anything. Strictly or boldly you have to tell. So many times they don't agree. If you smell something fishy, then you have to inform police immediately. माझ्याकडे तर नेहमी प्रॉब्लेम असतो, पेशंट आलेला असतो, पेशंट येतो ब्रॉट डेड ऑन अरायवल आणि काहीतरी फिशिंग असतं तर ते एक्सपायर झालं PM करावं लागेल म्हणून सांगितलं की ते बॉडी घेऊन जातात तसेच अँड देन इट बिकम्स अ प्रॉब्लेम. So one day police officer came to my inquiry. He said that तुम्ही असा पेशंट पाहिला आणि तुम्ही आम्हाला कळवलं नाही. So I told that हो तो पेशंट होता, मी पाहिला, तो ऑलरेडी डेड होता, मी कळवणार म्हटल्यानंतर तोपर्यंत त्यांनी पेशंट घेऊन गेले आणि मला त्याचं नाव माहीत नाही काय माहीत नाही म्हणून मी काय कळवलं नाही तुम्हाला. So you have to get yourself also excused for this. This is very important and very this. So many times patient comes with the road traffic accidents. माझ्याकडे तर नेहमीचं उदाहरण आहे की कुणीतरी रोड ट्रॅफिक ॲक्सिडेंट झालेला असतो, कुणीतरी उचलून आणलेलं असतं, उचलून आणून टाकलेलं असतं पेशंट आणि nobody is there, no relatives, nothing. So you have to treat these patients absolutely with this. कारण कधीतरी असं बऱ्याच वेळा होतं की हा माणूस फार मोठा माणूस निघतो आणि नंतर त्यांच्या भरपूर इन्क्वायरी होतात आणि कधी असंही होतं की तो पेशंट शेवटपर्यंत कोणी येत नाही त्याच्याकडं अँड देन यू हॅव टू सफर बट यू हॅव टू ट्रीट दिस पेशंट. समटाइम्स आय हॅव last month only I treated one patient with severe head injury. Patient came in deep unconsciousness, brought by ambulance from Muswad. Then he was treated, one fellow came there, he ran away afterwards. And for 1 month patient was treated, patient was ventilated, intubated, tracheostomy done, wean off killer, and even till that time nobody came, including hospital bill and including medicines, everything was charity. But if you are treating emergencies, you have to accept all this, at least 100तला एखादी पेशंट असा निघणारच जो हॉस्पिटलला घंटा घडून जाणार हे लक्षात घ्यायला पाहिजे. And that's why this is very important. So briefing is absolutely important. Once the relatives are agreeing for this, then our work becomes more easier. Education and training and research is always there. Education to the staff is very important. The staff should be stable. It should not be changing all the time. If emergency comes, my hand is on the right thigh, right femoral. I only direct everything. So if I tell that intubation, then my assistant, for example, Dr. Anand is there. So Anand will say that Dr. Anand intubating. So my work is finished. So I should not ask anybody this. Give adrenaline. So sister will say that sister so and so giving adrenaline. So if that work is done, so nobody else will run away. नाहीतर काय होतं की ॲड्रेनलिन म्हणलं की सगळे लोक तिकडे धावायला लागतात आणि मग मोठा प्रॉब्लेम येतो, केऑस निर्माण होतो. सो द पर्सन हू इज डुईंग दॅट ड्युटी ऑर जॉब शुड say loudly that I am doing this, so that that work becomes this, and then it gets channelized everything. You have to do so many times. Cardiac arrest patients come. In a year, almost 12 to 15 patients of straight line, cardiac straight line, or the ECG monitoring is straight line can be revived or are revived in my hospital. Because I know the history. Somebody has sent me a patient. He says that patient la myocardial and patient itach stop jalla. So you have to resuscitate it in proper way. And always resuscitation in these patients is very, very fruitful. Always you have to be very careful and very hopeful that this patient can be survived. Once one single beat comes, heartbeat comes, then your work is easier. You can immediately go on for next things. So resuscitation, and this is very important. And for this, staff to be trained is very, very important, because trained staff will save your all worries or decrease your worries. So right time, patient comes in a right time, right place, right treatment, right resources. Then emergency can be tackled very well. Then it can give speedy recovery. It can give sympathy of the relatives and this. And if you apply science, it will be always better for this. So outcome significantly improved in patients with cardiac arrest, acute myocardial infarction, patients undergoing PAMI as a lesser door to balloon time. I have one incidence in my patients when I was having that MJPGY scheme. One patient came, 70 years old lady with a very small girl with her granddaughter. And she came arrested, had a complete heart block. I saw the ECG, I took her there in cath lab. The pacing was done. Then without taking left catheter, I directly took a right catheter. Then RCA plasty was done. Everything was done in 5 minutes 29 seconds. And the life was saved. With the same small girl, she went after 7 days home. So that can be done many a times, and that's why that's very important. Tachyarrhythmia and VT, SVT, you have to treat very immediately. Snake bite patients, especially cobra bite. If your friend tells that, sir, I have sent the patient, probably cobra, then you have to be very watchful, because till that time, patient comes, patient has arrest. And if arrested just 2-3 minutes earlier, then you can definitely resuscitate. One small boy, I remember, in a school, he just went for just playing and had a bite. It was a cobra bite. He was brought there. My friend Dr. Vidusha told me that probably cobra bite patient is, and there was a bazaar day. So while coming, it took little more time, 7-8 minutes. Patient came, it was arrested. So I was knowing the diagnosis that it is a cobra bite. So we resuscitated, fruitful resuscitation, and exactly after 24 hours, patient was discharged walking, because it was a cobra bite. So that can help you very much. Organ of hospital same, you have to intubate and take care everything. Acute massive pulmonary embolism, as I told, that you have to thrombolize the patients immediately. Immediately your team should be there. You should have always ultrasonography, good ultrasonography or echocardiography machine in a ER room, so that you can immediately see the dilated RARV, pre-wall motion abnormality, pulmonary thrombus in a pulmonary artery. And then you can, your your diagnosis becomes more quicker. Acute ischemic strokes, polytrauma patients in shock state, status epilepticus, respiratory emergencies like asthma, COPD, exacerbations, and anaphylactic shocks. These are some of the conditions which are usually you have to treat it in a minute. And that's why your ER should be always on an alert mode. It should never sleep. So location of the emergency room is very, very important. If your hospital is nearby, your ER should be as close to a door. From the door directly, patient should come in an emergency room. So on the ground floor, direct access from the main road, location adjacent to the OPD, so that so many times patients, they don't know where to go. Patients usually come to OPD, then you can immediately take the patients to emergency room. Passage for carrying patients should be straight and broad. It should be adequate to move trolley of the patient along with all accessories like ventilators. Well lightened both day and night. The light arrangement should be very prompt. So this should be wide open this. How to receive the patients. This is very, very important. Those patients will tackle this. आपल्याकडे पद्धत आहे की पेशंट ॲम्ब्युलन्समध्ये घालतात खेडेगावातून. पेशंट आणतो, पेशंटला तिथं त्यांनी ॲड्रेनलिन नॉर ॲड्रेनलिन लावलेलं असतं डॉक्टरनी. पेशंट काही माहिती देत नाही, पेशंट येणार म्हणून डॉक्टर कळवत नाहीत. पेशंट येतो, दरवाजामध्ये येतो, ते सिरिंज पंप लावलेले असतात. त्यांना पेशंट त्यांच्या लोकांना काही असते. All ambulance drivers and this that just keep the patients like delivering the goods. You have to deliver the patient and go away. मग ते काय करतात, सिरिंज पंपचे सगळे सिरिंजेस काढतात, सगळं बोचकं ठेवतात आणि टेबलवर ठेवतात. पेशंट हू इज हॅव्हिंग हायपोटेन्शन ऑन अ वाझोप्रेसर्स, इफ यू रिमूव्ह द सिरिंजेस फ्रॉम सिरिंज पंप, कीप दॅट, देन पेशंट विदिन अ मिनिट गोज. इथं होईपर्यंत चांगला होता आणि आला गेला. सो we have decided a protocol. Any ambulance comes, we never allow patients to come in directly. Our staff, our doctor goes there, sees the conditions, what the condition of the patient is, how many equipment are with him attached. For example, syringe pump, ventilators, then support, all this. Then you go inside the ambulance, see what all this. You take your equipment. If there is a syringe pump, 2-3 syringe pump, then you take your syringe pumps, match the settings, take it on your syringe pump. Ventilator setting, you just see, take a transport ventilation, you see the this and then match those and then bring the patients inside. That is very, very important. 15 days back only one patient was about to die. My own patients, myocardial, old myocardial with cardiac shock, was brought nothing, and night time there was nobody. My ward boy was not there. So patient was directly brought. Luckily I was there. Then the syringes that I thought that the patient will go. And same thing happened, that broad QRS complexes, hypotension, everything. So we treated that patient urgently. So that should not happen. So emergency in a multi-specialty hospital or a bigger hospital where the emergencies are always coming, and they are, especially in our area, they are coming from a rural area. So this should be very well kept in mind, that patient should, how it should be received, then it is logically in good condition it should be received. If intubated, all facilities should be kept at the door. Trained personnel should enter the ambulance, review the situation. All ventilatory settings and drip rates or the inotropes and vasopressors should be matched to the hospital equipment and then shifted the patient to the hospital. So many times this happens. Patient ni titha intubate केलेलं असतं peripheralला proper intubation झालं असतं नसतं माहित नाही आपल्याला. We don't know. Then patients may have some wrong intubation so many times. Or during movement, patient's tube has slipped and it has gone in esophagus. So many times we have seen like this. So then it becomes a problem. So immediately assess the situation within a minute and then re-intubate if required. So all essential and functional equipments should be there. All should be in a pair. I am 100%, everybody will agree that in our hospital, nowadays in this situation, everything should be in pair. Means everything, including your duty doctor, including your consultant, including your generator, everything. Because light goes, one generator doesn't work, immediately it should go to other generator, it should start. Your all essential equipments like a ventilator, this you should have a separate line with a UPS, so that even if the electricity goes, your patient is not this. So everything should be paired. I always say that you should have in a hospital always a pair. In a pair, you should work better. But in a house, you should have only one wife, not a pair. Because that is the thing where you spend 18 to 20 hours in a hospital. You should have always everything in a pair. That's a very, very important this. I have seen so many times that defibrillator, it's working, but all of a sudden it stops. So you should have a spare defibrillator. Oxygen supply also should be dual. Laryngoscopes, all sizes should be available. Tracheostomy set should be, including stab tracheostomy. Up till now, I must have done almost 15 stab tracheostomies in an emergency room only. Because patients come with a previous history of intubation, long ventilation, patient come with a tracheal stenosis, intubation is very difficult. Then you have to directly go for a stab tracheostomy, like you have seen in a picture of anaconda. Like that, you have to do a stab and then save the life. That is very important. Ambu bag is absolutely essential. Now, once you become expert, it may not be required, because once you know that whether it is right, the tube is directly in a trachea, you can definitely know. But till that time, at least we should have ambu bag. Emergency medicines and nebulizer should be there. Dressing material should be there. UR should be close to OPD, OT, ICU, radiology, endoscopy unit. For example, out of this OT is not possible, so many times ICU is not possible, but at least radiology and endoscopy unit should be there. So many times bleeding disorders and this, they come, you have to immediately do an endoscopy. That life-saving drugs, as you know, everything should be there. So many times rare drugs are required. My advantage is that my hospital, the emergency room is on door side, and next side is a medical store. So my medical store, there is no need to keep so many medicines here. We give separate cheat, separate color cheat to medical stores when there is an emergency. So by seeing that cheat, when there is a rush, the cheat is picked up and given it immediately, so that the drugs are delivered immediately. All drugs that I will not enumerate. Protocols for advanced cardiac life support is very important. I always say that your basic life supports are resuscitation and advanced life support, this should be prompt. You should always teach your doctors that how to resuscitate the patients. And this is really this. One patient, last 6 months back, I treated where the arrest was for 15 minutes. It was because of myocardial infarction and ventricular fibrillation. Possibly patient came to me with an intermittent fibrillation or intermittent pulse, but patient was drop dead, resuscitated after 10 minutes of this. Then immediately thrombolysis was done, and patient was taken to cath lab. LAD was totally blocked. It was stent was put. Patient survived. I told patient was unconscious, so I told that cardiac-wise everything I have done, but I don't know how much is the neurological status. But to my, fortunately, the patient totally came out this. This was because of prompt resuscitation and treatment. So, your success of hospital or your success of practice, I feel that almost 50% depends upon your emergency room. And your emergency room is well managed, your emergency procedures are well managed, then everything will go smooth. So, as I told that, so many times आपल्याकडे कॉमन इमर्जन्सी असते, इव्हनिंग टाईम, नाईट टाईम, म्हणजे आता जरा कमी झाली, पण पूर्वीच्या काळात तर असं व्हायचं, 7-8 वाजता फिमेल पेशंट्स comes to your hospital with hyperventilation. That is 100% anxiety. So you have to see the patients, यांना कन्सोल रिलेटिव्हला सगळं काउन्सिलिंग करून 1-2 तासामध्ये पेशंट घरी पाठवता येतो. त्यामुळे जास्त काय गाजावाजा न करता पेशंट घरी जातो. आणलेला असतो त्यांनी गडबडीत की पेशंटला काहीतरी झालं म्हणून. तर अशा बरेच पेशंट असतात, ते लगेच बाहेर जातात. Some non-poisonous snake bites, they are kept in a casualty for longer time, 3 to 4 hours, and then they are sent home. So many emergencies are there that can be sent without admissions. So many patients are there that those should be treated in emergency only. Half of the work is done there only, and then to be admitted, and then patients go home nicely. If you delay in the emergency diagnosis, the ER room diagnosis, then everything is delayed and the time is wasted. So this is my experience. Still I feel that some patients goes without success or without this, and always I feel that something has gone wrong with me. I have not picked up this condition or that this. So many times it is beyond the human body resistance. Massive, this is for example electrical shock. Patient comes in a cardiac arrest. You may not revive him properly. But if you think logically, then most of the emergencies can be treated very well. This is a little busy slide. Thank you. So, I just want to tell you that केल्याने होता आहे रे आधी केलेची पाहिजे. त्यामुळं इमर्जन्सीमध्ये तुमच्याकडे आलं की पेशंट फार खराब आहे, होणारच नाही, बरा होणारच नाही असं म्हणून काय चालत नाही. स्पेशली कार्डिओलॉजिस्ट किंवा फिजिशियन्स लोकांना, सिनियर लोकांनी ते पेशंट रिससाईट करणं अतिशय महत्त्वाचं आहे आणि बऱ्याच वेळा आपल्याला चांगलं रिवॉर्ड मिळतं. त्यामुळे इमर्जन्सी रूम चांगली ठेवणं हे अतिशय महत्त्वाचं आहे.
Thank you, sir, for this wonderful session and academic feast. Now the topic is open for discussion.
Not only about medical treatment, but overall treatment of emergency room. As you said about training, so what is your experience about delegation of work to a proper person? जसे MBA चे लोक जे सांगतात की योग्य माणसाला योग्य काम नेमलं पाहिजे. मग त्याच्यामध्ये what you do in your practice, do you take regular training sessions? कारण कोणी ना कोणीतरी माणूस बदलतो, हाऊसवन बदलतो, मामा बदलते, मावशी बदलते. मग त्यांच्यासाठी रिपीटेड ट्रेनिंग सेशन्स वगैरे 6 महिन्यातनं वर्षात एकदा असे काही घेता का तुम्ही? आणि तुमचा अनुभव काय आहे त्याच्यातला?
युजली इट इज व्हेरी डिफिकल्ट ॲक्च्युली, बट एस्पेशली काय आहे की डॉक्टर्स बदलतात बऱ्याच वेळा. पण आय हॅव दिस दॅट आय ऑलवेज आस्क द डॉक्टर हू जॉईन्स माय ड्युटी whether you want to stay longer or shorter. Accordingly, you give them duty. There are about 10 house surgeons in my hospital. They are 25 years with me. So you can depend upon them for anything, for difficult intubation, everything. Like these patients, if you keep, then there is no problem. Your ward boys, they are for 20 years with me. And that's why, I'll tell you, one patient came to hospital, not my hospital, came to some other hospital. Patient died because there was no much of diagnosis. And after 15 days, his brother came again. This time he was brought to my hospital and my ward boy phoned me directly. Night time, it was 3 o'clock. Sir, patient alay, बेशुद्ध आहे, unconscious आहे. मी सरांना कळवलं आहे दुसऱ्या हाऊस सर्जनला, पण तुम्ही लगेच या, मला इंट्युबेशन लागेल असं वाटतं, क्रेट बाईट आहे. सो दिस इज अ डिफरन्स. इफ यू ट्रेन एव्हरीबडी देन इट इज रिअली दिस. आणि ऑलवेज तुमच्या इमर्जन्सीमध्ये असेल तर तुमचं 24 तास ते उघडंच पाहिजे. म्हणजे हॉस्पिटलला कुलू बेल वगैरे असलं काही नाही पाहिजे. रात्रीच्या वेळेस आली, बेल दाबला, डॉक्टर जागा झाला, हे तर बिलकुल नाही पाहिजे. हे असेल तर अतिशय चांगला रिझल्ट येऊ शकतो.
व्हॉट आय वॉन्ट टू एम्फसाइज की मनुष्यबळ व्यवस्थापन आणि त्यांचं वारंवार होणारं प्रशिक्षण, विशेषतः एस्पेशली तुम्ही जसं वॉर्ड बायचं एक्झाम्पल सांगितलं की आता आमच्या ऑब्स्टेटिक्समध्ये बऱ्याच वेळेला वॉर्डातल्या आया असतात किंवा त्या मावशी असतात, त्या बऱ्याच वेळा सांगतात सर आता एक अर्धा तास होण्यासारखे बरं का, तुम्ही या किंवा काय. सर ते हे प्रशिक्षित मनुष्यबळ खरंच गरजेचं असतं. म्हणजे त्यांच्या शिक्षणाकडे किंवा त्यांच्या दर्जाकडे न बघता त्यांचा त्यातला जो अनुभव असतो तो आपल्याला बऱ्याच वेळेला कामी येतो. आणि वी शुड बी
वी डोंट टेक मच ट्रेनिंग, बट at the end of the case, where the patient goes gets admitted, after that we always discuss that what we should have done.
That is a part of training actually.
Yeah, so it is a sort of training. Every case is discussed after that. So that is a sort of training only.
Because now government is coming with lot of protocols, especially in obstetrics. ते आपलं सगळं मनुष्यबळ ते प्रशिक्षित करतायत. राईट फ्रॉम आयाज, सिस्टर्स, नर्सेस, लहान बाळाचं रिसिसिटेशन असो किंवा मदरमध्ये PIH असो, एक्लॅम्पशी असो, PPH असो, शॉक असो, ह्या सगळ्याचं ट्रेनिंग गव्हर्नमेंट घेते आणि ते मी माझ्या हॉस्पिटलला करून घेतलं. मला खूप फरक जाणवला की आपण बऱ्याच वेळा म्हणतो तो काय वॉर्ड त्याला काय अक्कल, सगळी अक्कल फक्त मलाच आहे, पण मला असेल अक्कल थोडी वाटली तर माझी कमी होत नाही, त्याचा मला जास्त फायदा होतो.
All my senior house surgeons who are working there, they have done a course of emergency medicine, so they know basically this.
Thank you, sir. Thank you.
Thank you, sir. Thank you, sir. Now I request Dr.
Sir, I have one question.
Sorry.
Sir, usually in our rural settings, there might not be an availability of intensivists 24/7. So nowadays, a concept has come like cloud ICU or tele ICU, in which one intensivist is sitting somewhere and he is observing your ICU 24/7, and he is giving inputs to your doctors who are working there, paramedicos or your houseman doctors. So would it be a viable option in our the rural settings? So what do you feel about it?
Which option, viable option?
The cloud ICU or tele ICU, in which
Yeah. That's what I'm telling, that if your staff is very trained one.
No, sir. I'm now some companies. आता अशा काही कंपनीज येत आहेत. बँगलोर बेस्ड एक कंपनी आहे क्लाउड ICU. तर त्यांनी कोविडमध्ये काय केलं होतं की बऱ्याच रुरल एरियामध्ये कॅमेरा बसवायचे आणि पेशंटचे सगळे डिटेल्स तिथं जे इंटेन्सिव्हिस्ट असायचे त्यांच्याकडे जायचे. आपल्याकडे काय होतं की 24 तास इंटेन्सिव्हिस्ट अवेलेबल असू शकत नाहीत प्रत्येक वेळेस, हाऊसमन्स असतात. मग तिथं होतं कसं की तिथं इंटेन्सिव्हिस्टची अवेलेबिलिटी 24 तास असते. ते आपले पेशंट ऑब्झर्व करत असतात आणि कुठलीही डिफिकल्टी आली की ॲट इन्स्टंट आपण त्यांना इन्फॉर्म केलं की ते आपल्याला इनपुट्स देतात आणि तिथं जे डॉक्टर्स अवेलेबल असतील इव्हन त्यांना ते असिस्ट पण करतात की काय करायचं आहे. तर आपल्या या ग्रामीण भागामध्ये अशा कन्सेप्टचा काय फायदा होऊ शकेल का?
नाही, फायदा होतो बऱ्याच वेळा बरं का. म्हणजे तो फायदा डेफिनेटली होईल, परंतु बऱ्याच वेळा टेलिफोनिक कन्सल्टेशन जे होतं, आता यू आर टॉकिंग अबाउट टेलिमेडिसिन म्हणजे
येस काइंड ऑफ टेलिमेडिसिन. येस,
बट हिअर सो मेनी टाइम्स इट इज अ टेलिफोनिक डिस्कशन फॉर इमर्जन्सीज की असा पेशंट आलेला असा आहे, तो प्रोबेबल इफ यू गिव्ह ॲडवाइस टू दॅम इट इज ऑलवेज इट हेल्प्स.
येस सर, थँक्यू.
म्हणजे ते चांगल्या स्ट्रक्चर फॉर्ममध्ये करणं जरा थोडं डिफिकल्ट आहे.
ती सर ते काय करतात, ते पूर्ण सेटअप करून देतात, तिथं कॅमेराज असतात आणि 24/7 पेशंटचं काय चाललंय त्यांना ते दिसत असतं तिथं, आणि त्यांची एक डेडिकेटेड ICU टीम असते की ते आपल्याला इनपुट देत असतात.
थँक्यू डॉक्टर इनामदार.
थँक्यू
फॉर सच ए elaborate lecture. This topic is actually, it can go for hours together. Thank you for narrating in a short time.
Thank you, sir. I request Dr. Bopatkar sir to felicitate Dr. Inamdar sir. I request Dr. Sandhya Gowda madam to felicitate our chairpersons. Now I request Dr. Karande sir to felicitate Dr. B.K. Dhotre, today's MMC observer. I request Dr. Kechi sir to present vote of thanks.
A wide round of applause to all the faculty members who came across from Pune, Akluz, such a far distance to deliver the academic fees to M A Pandharpur, and they made all complicated lectures in such a simple and simple way to understand for us, and it will be helpful us in future to manage the patients. Now, first of all, I would like to thank our MMC observer, Dr. B.K. Dotre sir, for his guidance. I would like to thank IMA 2023-24 committee member for the organizing such a wonderful event. I would like to thank all the participants for patient listening and the interaction which was going between the faculty members and the participants. It was very informative for the junior doctors also. Such a wonderful academic session it was going on this Sunday. So it was very nice to be a part of it. And then I would like to thank the sponsors also, the pharma companies, MCure Pharma, Dan Leon, HBC, Meditune Pharma, Eris, Zuventus Florina and Rejuvenate Pharma for supporting us and for sponsoring such a wonderful event. I would like to thank our special thanks to Pappu Unare, who has provided us such a delicious breakfast in the morning. Because of him we were totally energized to listen the lectures. Means everyone was awake during the lectures. I would like to thank the caterers also. And I would like to thank the Nikte caterers for such a wonderful and delicious food. Though it is in a month of fasting, so they have provided us very much good and delicious food. And variety of food was there. I would like to thank the stage decorators, Sharad Rajguru and Lavekar, who has made this event. YouTube live streaming was going on and the recording. I thank all the cameramen who has worked for this event. I would like to thank Javanja for the sound system also. Overall, this event was success. For this grand success, I would like to thank our respected IMA President sir, under his guidance, under his team, Honorable Secretary Dr. Dhotre, Guzre sir, Borake sir, who took such efforts. It is not possible to mention everyone's name, but this kind of event is going to held in future also. And post-COVID, it was a mega event from the IMA Pandharpur branch. I would like to announce in the evening around 7 to 10 p.m. we are having Dandiya session in Chennai Hall. Everybody should participate with their family members and enjoy the event. Thank you all, one and all. Thank you very much.
Good evening all. I would like to thank our IMA Pandharpur branch dynamic committee members for very good anchoring and for very rigorous planning since few days for this event. I request our IMA Pandharpur President Dr. Sunil Karande sir to come on dais to felicitate our anchoring team. I request Dr. Shahapure madam, please come on dais. Dr. Vinayak Rao sir. Dr. Pradeep Keche sir. Dr. Masnurkar madam just left for her some problem. Thank you. And I would like to announce
have arranged high tea. I request everybody to enjoy the high tea. I think it is much needed. So today's CM is over. Thank you for so much enthusiastic response. I request all the organizing team to come on the stage for the photograph. Hurry up. You have to be ready for Dandiya also, especially the ladies wing. Yes, especially the ladies wing.